Hello, good afternoon, everyone. Today we will start with this session of medicine, and this will be covering the two important topics of medicine, CVS and GIT, and it is based on the DFX. So let's start with the revision of your CVS and GIT. Remember, this is a revision session, so just to make you understand key what are the important topics that you should focus upon. So first topic is cardiovascular system. So in cardiovascular system, pulse abnormality. So the pulse abnormality, first is the Faggot sign, which all of you know by the name of relative bradycardia. So Faggot sign is relative bradycardia. So the most common cause of this relative bradycardia is typhoid fever. So most common cause is typhoid fever. Pulses by Gemini, every alternate beat will be due to premature ventricle ectopic. Again, a very important question from the pharma, that is digoxin toxicity. So it is because of digoxin toxicity. Coming to the number third pulse, pulsus alternans. So pulsar alternans is regular alteration of the pulse amplitude that you can see here, and it is seen in cases of LV failure. So LV failure, pulsus alternans. Now the characteristic pulse, which is a low amplitude and late peak. So this is very popularly known as parvus et tardus. Parvus et tardus, low amplitude, late peak. So this will be present in cases of aortic stenosis. AS, aortic stenosis. Now, pulsus bis variance, two peaks in the systole will be present, two peaks in the systole. So it is a feature of aortic regurgitation, and the second important condition is HOCM, two peaks in the systole. Now, pulsus paradoxus. So pulsus paradoxus is difference of systolic BP in expiration minus systolic BP in inspiration should be more than 10 plus 10. So this is known as pulsus paradoxus. The most common cause of pulsus paradoxus being COPD. Most common cardiovascular cause being cardiac tamponade. So these are the two important most common cause of the pulsus paradoxus. Why? Reverse pulsus paradoxus. Reverse pulsus paradoxus is systolic BP during inspiration will be more than the systolic BP during expiratory phase. So two important cause will be present here, and these are HOCM and positive pressure ventilation. Positive pressure ventilation. So let me give you a question. Let me check who will give me the correct answer here. So the question on the pulse is two peaks of the pulse will be present. What? One peak will be in systole and the other peak is in diastole. So this is known by the name of which pulse. So there will be two peaks. One will be seen in cases of systole and other peak is in diastole of pulse. Two peaks of pulse. Yes. Can anyone tell me what is the name of this pulse description? So the name of this pulse description is diacrotic pulse. Yes, this is diacrotic pulse. And diacrotic pulse is seen in cases of septic shock. This is seen in septic shock. So these are the very important pulse abnormality that you will be likely to get. So yes, it is seen in cases of the septic shock. Now the second important topic of the examiner is the JVP description. So in the JVP description, the first wave is the A wave, and A wave is because of atrial contractions. So it is because of the right atrial contractions. So this is seen in cases of late diastole. So the very important question key, it will be absent if the atrial contractions are absent, and that condition is known as very important MCQ, absent A wave atrial fibrillation. It will be present. Why? Large A will be present when the atrial contraction are very, very forceful. So it is seen in cases of tricuspid stenosis, TS. No, in PSVT. In the PSVT, the pulse seen will be the JVP pulsation will be Canon A wave. So Canon A wave is a very, very large A wave, very, very large A wave, Canon A wave. So this is seen in cases of third degree AV block. It is seen in cases of PSVT and junction rhythm. These are the three causes of the Canon A wave. Again, a very important question for the exams. Why? When the tricuspid valve bulge into the right atria, so right atrial pressure increase and the large C wave will be present, and the cause of the large C wave will be tricuspid regurgitation. Tricuspid regurgitation, large C wave. Why? Tricuspid valve pulled down by RV shortening, that is X descent will be present, and absent X descent will be seen in cases of tricuspid regurgitation. So remember the features of TR. So that is an expected question this time. Tricuspid regurgitation, large C wave, absent X descent, and large V wave. And any cause of the large V wave will produce a rapid Y descent. It will produce a rapid Y descent here. So these are the important descriptions of the JVP, out of which absent Y is being asked very, very frequently. So absent Y is seen in cases of cardiac tamponade. This is one of the FAQs, absent Y descent in the JVP. So these are the important descriptions of the JVP examination. Now moving on to the next one. Kussmaul sign. So the Kussmaul sign is JVP increasing on the inspiratory phase. Normally it decreases in the inspiratory phase. So two important causes will be there of Kussmaul sign. These causes are important causes: restrictive cardiomyopathy and constrictive pericarditis. Indeed, these are the two conditions where pulse and JVP abnormalities are same. Pulse and JVP abnormalities are same here. So it is a Kussmaul sign, and it is not seen in cases of tamponade. It is not seen in cases of tamponade. So the JVP will increase in inspiration. Right atria is non-compliant. Right atria is non-compliant. Now, coming to the topic of the cardiac murmur. So the topic of the cardiac murmur diagram will be given to you. First you have to identify which murmur is that and which valvular defect will lead to this murmur. So if you can see the first diagram, in the first diagram the murmur is showing increasing trend and decreasing trend. So this is increasing and decreasing trend of the murmur. So this is known as a crescendo and decrescendo type of murmur, and two important valvular defects can lead to this murmur: ejection systolic, aortic stenosis, and pulmonary stenosis, AS and PS. Why? This murmur, obvious from the diagram, it is occupying full systole. It is occupying the full systole. So it is a pansystolic murmur, and pansystolic murmur is a feature of two valvular defects, MR and TR. So remember, whatever is the valvular disease of the right side is the valvular disease of left side also, same murmur will be present. So MR and TR, it will be present. Of course, it will be present in cases of ventricle septal defects as well. While early systolic murmur, it will be seen in cases of acute conditions or small VSD. Small VSD, it will be present. Yes, chronic MR and TR, very nice. The cause of these conditions, chronic MR and TR, is rheumatic heart disease. Is seen in cases of rheumatic heart disease. While late systolic murmur is a feature of mitral valve prolapse. Important MCQ. It is seen in MVP condition. While early diastolic murmur, as you can see this diagram, this murmur is present in the early part of the diastole. So early diastolic murmur, only two valvular defects can lead to this murmur. One is aortic regurgitation, and other is a pulmonary regurgitation. With respective name of these murmurs, one is Key-Hodgkin's murmur and other is Graham-Steele's murmur. Graham-Steele's murmur. So two important murmur, that is early diastolic murmurs. Now, coming to the murmur, as you can see the diagram, this murmur is mainly occupying the mid diastolic part. You can see the duration, mid diastole. Yes, this is a mid diastolic part which is occupied here maximum, and just before the systole, you can see that there is a pre-systolic increase here. So mid diastolic murmur with pre-systolic accentuation is present here. So this is seen in cases of anatomical MS and TS. Anatomical MS and TS, it will be present with pre-systolic accentuation. While continuous murmur is occupying the systole as well as the diastole, and it is because of the vascular disease. So this is a very important trick for your exam. Vascular disease will cause the continuous murmur, whether it is AV fistula, PDA, patent ductus arteriosus, arterial stenosis, or cervical hump that can be present. While it is never due to valvular disease, because valvular disease will cause either systolic or diastolic murmurs. So in the exam, whenever vascular disease is given, always go for a continuous murmur. It will produce a continuous murmur. Now, moving on to the next one. Next is a very important criteria, that is a Jones criteria. Jones criteria are for rheumatic fever, and these should be on your tips. So the most common major Jones criteria is arthritis, that is a joint involvement. Most common major criteria. While most common cause of death, it is carditis, and carditis leading to the heart failure. An important question of the carditis, most common valvular lesion which is present here is mitral regurgitation. While Sydenham's chorea with abnormal movements, it is a late manifestation. While skin manifestation, subcutaneous nodule and erythema marginatum, these are rare manifestations but considered as a major criteria. Rare but major criteria it will be considered as. While in India, minor criteria will be monoarthalgia, fever of more than 38, ESR of more than 30. So these are the important values for you to remember as a minor criteria. And this is the stat diagram which is given to you. As you can see here, there will be a red color margin rash. So red is erythema and margin is marginatum. So this is a erythema marginatum which is present here, and it is present on trunk and limb area. And to make a diagnosis of Jones rheumatic fever, two major criteria should be present, or there should be a one major plus two minor criteria will be present. So this is the criteria fulfill, two major or one major plus two minor. Why? Prophylaxis. Prophylaxis is a secondary prophylaxis or a primary prophylaxis. So, in the secondary prophylaxis, we want to prevent the recurrent rheumatic fever episodes. So, acute rheumatic fever should not convert into recurrent attacks. That is secondary prophylaxis. Primary prophylaxis is pharyngitis should not convert into acute rheumatic fever. So, for the primary prophylaxis, we give benzathine penicillin within 9 days. A single dose will be sufficient here. While in cases of secondary prophylaxis, benzathine penicillin is given for a long duration. So if patient does not have any carditis, so we will give for a total 5 years of duration, or till patient age is 21. If the patient has carditis episodes, so we will give it for 10 years or till 21 years of age, whichever is the longer duration, we will be giving the duration of prophylaxis. While if patient has mitral stenosis or rheumatic heart disease, that is fibrosis has occurred, then it will be lifelong. we will give it for lifelong duration. Now, the second important topic of the cardiovascular system is a valvular heart disease. So, to diagnose the valvular heart disease, the most important thing that you should be doing is the site. Where is the murmur being heard? So, site will define the lesion. For example, very simple. If it is a mitral valvular lesions, so it will be heard at mitral area. So, the murmur will be mid diastolic murmur. So, it is at mitral area. At mitral area, only two lesions will be present, MS or MR. So you should tick mark only one out of them. Tricuspid stenosis, it will be at tricuspid area. It will be at tricuspid area. And both the murmur of MS and TS are same. So these murmur, we will revise it once again. These murmur are mid diastolic murmurs like this. So this is S2. This is mid diastolic murmur like this. Mid diastolic murmur is present here. While for cases of MR and TR, again, site is important. MR will be mitral area, TR will be tricuspid area, and they will produce a pansystolic murmur. This is producing a pansystolic murmur here. While AS and PS, both of them will produce the same type of the murmur, and the murmur here will be this type of the murmur, which is known as ejection systolic murmur. So this will be like this, ejection systolic murmur will be present. AS and PS, and AS, it will be present at aortic area, while PS will be present at pulmonary area. It will be at the pulmonary area. So these are the areas which will define the type of the valvular disease murmur being heard. While AR and PR, they are early diastolic murmur. So this is S2, this is S1. So it is present like this. So this is an early diastolic murmur. So aortic regurgitation is present at, this is a unique area. This is present at the ups area. Ups area is left third intercostal space. Left third intercostal space is the ups area which will be present. This murmur, early diastolic murmur. PR, early diastolic murmur, and as the name suggests, it will be present at pulmonary area. It will be present at the pulmonary area. So these are the types of the different murmur and their areas. So this diagram or this table you should be doing, and this is always a potential question. So these are the areas which we have discussed earlier. Now, coming to infective endocarditis. So infective endocarditis, usually the organisms will be asked from you, and the Duke's criteria will be asked. So the native infective endocarditis, most common cause is Streptococcus viridans, while hospital acquired is Staph aureus. But if the question is, what is the most common cause of native infective endocarditis? Answer will be Staph aureus. It will be Staph aureus. While for prosthetic valve, it is Coagulase negative staph, and one of the example of Coagulase negative staph is Staph epidermidis. Staph epidermidis will be the example here. So within 1 year it is Coagulase negative, and after 1 year it will be Streptococcus viridans. And most common cause of prosthetic valve infective endocarditis, if overall is asked, overall answer will be Coagulase negative staph. Coagulase negative staph. While in the Dukes criteria, the important is the new Dukes criteria you should be doing. So the important Dukes criteria will be vegetation. So there will be a presence of the vegetation on the echocardiogram and evidence of the microorganisms. While the third criteria is added, that is if patient has a vegetation which is seen during the surgery. So that is a major criteria, vegetation seen during the surgery. While if a patient has a minor criteria, so two minor has been added. Five minor were old criteria: predisposing factor, fever more than 38 degrees Celsius, immune phenomena, vascular events, and culture or serology, but not satisfying the major criteria. So they will be considered as minor. While FDG PET scan and new clinically regurgitation murmur, they are new criteria which are added in minor. These are new criteria added in minor. So these will become a potential question for you. What are the new criteria for infective endocarditis? Treatment of the infective endocarditis. So there is a whole list, but the most important one you should be remembering is the methicillin resistant staph. So that will be the type of the question you will be getting. So methicillin resistant staph aureus, and that too prosthetic valve. If it is a native valve, only one drug is given, that is vancomycin. While if it is prosthetic valve, along with the vancomycin, we will add gentamicin and very important drug rifampicin. So rifampicin has one more use, that besides the ATT, it can be used in infective endocarditis. Yes, for prosthetic valve. It penetrates the prosthetic valve infective endocarditis. So rather than remembering the whole list, the important one you should remember, that is methicillin resistance cases. They are more important questions. They are more important questions. Why? Cardiomyopathies. So cardiomyopathy topics, dilated cardiomyopathy, restrictive, and HOCM. So dilated cardiomyopathy is the most common pattern of the cardiomyopathy. So this is most common pattern. Most common pattern is dilated cardiomyopathy. So here the symptom will be left ventricle failure like, that is dyspnea, and this sign we have already done. There will be systolic dysfunction, so pulsus alternans will be present in dilated cardiomyopathy, and most important feature is ejection fraction of less than 40%. Ejection fraction of less than 40% will be present here. While the etiologies wise, most common genetic cause is titin mutation. Genetic cause, titin mutation, important MCQ. Most common toxin will be alcohol, and most common cause of myocarditis will be Coxsackie virus. But tricky question comes. If the question is most common infectious cause of DCNP, most common infectious cause of the DCNP, then it will be Trypanosoma cruzi. Trypanosoma cruzi. It is the most common infectious cause of DCMP. While for myocarditis, the answer will be Coxsackie virus. While for restrictive cardiomyopathy, it is a failure of the relaxation, and the symptom will be right ventricle failure like. So RV failure like, swelling will be present here. While in the clinical sign, the pulsus paradoxus is present in restrictive cardiomyopathy. Pulsus paradoxus. While the most common cause is amyloidosis, and two important amyloidosis can cause restrictive cardiomyopathy: primary and familial. Primary and familial. Yes, doxorubicin is the top drug which can cause a dilated cardiomyopathy. It is the drug which leads to dilated cardiomyopathy. Other causes can be hemochromatosis and sarcoidosis. While the most important cardiomyopathy which is asked is HOCM, hypertrophic obstructive cardiomyopathy, and it is the most common cause of sudden cardiac death in young or adult people because of angina episode. LV systolic function are high, LV demand for blood is more, so patient can have angina and leading to death. While the classical pulse was, we have discussed earlier that BIS variance pulse is the classical pulse of HOCM, BIS variance pulse. While drug of choice is beta blocker, and ICD will be given when there is a high risk of sudden cardiac death. Suppose patient has past history of ventricular arrhythmias, so put the patient on ICD device, and this full form is implantable cardioverter defibrillator device. So that will be given. If a patient has high risk, then go for ICD. Most common mutation is beta myosin mutation. And this is the classical diagram which will be given to you of HOCM. Hypertrophic septum will be present here. This is hypertrophic septum. And it will be a banana shaped LV cavity which is present. So you can see the septum is bulging into the left ventricle, making it a banana shaped cavity, high yielding point or hallmark of HOCM. Why? In the heart failure, so the heart failure is a reduced ejection fraction or preserved ejection fraction. Reduced ejection fraction is less than 40, preserved is more than 50. So the most common symptom of heart failure, it is the dyspnea. And whenever someone asks which is the most specific symptom of the heart failure, answer will be paroxysmal nocturnal dyspnea. PND will be the answer. PND. While most specific pulse we have discussed earlier, it is pulsus alternans will be present. And serum BNP elevation is the diagnostic investigation. So they will be asking the diagnostic investigation. And more important questions are first line agents. So first line agents are decreasing the mortality. So the meaning of first line, they decrease mortality. So these are the agents: ACE inhibitors or valsartan sacubitril combination, beta blockers, only 3 beta blockers: MBC, metoprolol, bisoprolol, carvedilol, anti-aldosterone agent, spironolactone, and SGLT inhibitors, empagliflozin or dapagliflozin. They will be given for reducing the mortality. And out of this, the agent which also approved for preserved ejection fraction is SGLT inhibitor. It is SGLT inhibitor. And one more agent is approved for heart failure with preserved ejection fraction. Maybe a potential question, and that is also Finrenone is approved. So this agent is a mineralocorticoid receptor antagonist. So could be a PQ potential question for this year, this week exam. Now come to the pericardial disease. So in the pericardial disease, the most important focus that you should be doing will be on the tamponade. One question they always ask from the tamponade process. So tamponade is a type of a shock, compressive shock. So it is a type of compressive shock or obstructive shock. So patient will have low blood pressure, patient will have elevated neck veins, and patient will have soft heart sounds. So this is a classical backstride which will be present here. Backstride. Well, JVP will show absence of Y descent that we have discussed earlier. And in the ECG, we will see the voltage alternatively increasing amplitude, decrease amplitude, increase and decreasing amplitude, known as electrical alternance. And treatment of choice is pericardiocentesis. Treatment of choice is pericardiocentesis, and the most important hallmark finding here will be this is pathognomic. That is, on the echo finding, right ventricle diastolic collapse will be present. So right ventricle will collapse in the diastolic phase, a very very important sign of echo sign of cardiac tamponade. So out of all the pericardial disease, my advice, one day before the exam, just go through cardiac tamponade. While topic of the hypertension, so the topic of the hypertension will be the medication which will be asked from you. So you should be knowing the meaning of grade 1 hypertension and grade 2 hypertension. So any BP which is more than 160 and 110 is a grade 2 hypertension. While resistant hypertension is patient is taking 3 or more than 3 drugs, still BP is not under control. So that is resistant hypertension. Malignant hypertension will be with fibrinoid necrosis, emergency end organ damage like myocardial infarction, stroke, aortic dissection, and BP will be 180, 120 with end organ damage, but without any end organ damage, it will be known as hypertensive urgency. The maximum question you will get is on the management point of view. So management is, if a patient has a grade 1 hypertension, we will assess the comorbid conditions CAD, CKD and diabetes. If none of them is present, then we will go for lifestyle modification. If any one of them, along with the lifestyle, we will add the drugs. While grade 2 hypertension, all the patients should receive drug along with lifestyle modifications, and combination will be given. So most important is the combinations. So combination of A stand for ACE inhibitor and C stand for calcium channel blocker. Always give two drugs. Two drugs will be given, but in a low dose, so that side effect should be less. If BP is uncontrolled after a month, then we will increase the dose of ACE inhibitor with CCB. If BP is still not controlled, diuretic should be added. Still high, known as resistant hypertension, spironolactone will be added in that scenario. Now, ischemic heart disease, one question always come. This is your last moment revision topic, LMR topic. They will ask you the wall of the myocardial infarction. You have to diagnose which wall of the MI is involved. So if a septum is affected, V1, V2 will be the ECG lead showing ST elevation. Anterior wall V3, V4 shows ST elevation. Lateral wall V5, V6, 1 and AVL. V5, V6, 1 and AVL. While inferior wall will be 2, 3 AVF. And if expected question come, what will be the posterior wall MI detected in? So can anyone tell me? Posterior wall is supplied by left circumflex artery, posterior wall. So this will be V7, V8 and V9. This will show ST elevation. Yes, ST elevation will be present in these leads for posterior wall. So they might ask you the question this year, posterior wall MI detected in which ECG leads with reciprocal ST depression in V1 to V4. So there will be reciprocal ST depression, and posterior wall will show ST elevation. Now, two scenario. The first scenario is patient present with angina pain. ECG will be done within 10 minutes. First scenario is ST depression. So always think of it is a unstable angina or non-escalation MI. So the differentiating point here will be troponin. So troponin will differentiate these two conditions. Troponin is normal, then it will be unstable angina. Why? If troponin is elevated, non-escalation MI. While ST elevation MI, troponin is normal, it is Prince metal angina. And if troponin is elevated, ST elevation MI. And many times this question is asked, which is the best cardiac marker, FAQ. So answer will be troponin I. It is the best cardiac marker, troponin I, for reinfarction. So reinfarction, we will go for CPK-MB between 3 to 10 days. If question is about the reinfarction, CPK-MB will be assessed. Now the treatment. So if a patient has a non-escalation MI, we will go for conservative treatment. So remember, these are managed by conservative. We go for antiplatelet agents, which is aspirin and clopidogrel. Low molecular weight heparin will be added, nitrate will be added, and beta blocker will be added. So 4 agents will be given here. And equally important question, contraindicated in non-escalation MI is thrombolytic therapy. It is a thrombolytic therapy which will be contraindicated here. For Prince metal angina, it is a vasospasm. So we will go for nitrate first. So this is given in emergency. And for maintenance, CCB will be given. CCB will be given here. Contraindicated will be aspirin, beta blocker, thrombolytics. While for ST elevation MI, now this is very important. For ST elevation MI, thrombus is very big thrombus. So we have to remove the thrombus. So the definitive treatment in this condition. So remember, definitive treatment is reperfusion. Reperfusion is remove the thrombus. This is the meaning of reperfusion. And establish the blood flow. Establish the blood flow. So this is done with percutaneous coronary intervention, that is known as PCI, or thrombolytic agent. But PCI is better than thrombolysis. So PCI is always better than the thrombolysis therapy. So whenever PCI available, always go for the PCI. Thrombolysis is done when PCI is not available. When PCI is not available. And these are the very important time limits. Symptom onset for which you can do a PCI is less than 24 hours. For thrombolysis, less than 12 hours. While door to balloon time is from the arrival time till the PCI completed. So that should be less than 90 minutes. So this is arrival time of the patient, arrival of patient till PCI done. That is the meaning of the door to balloon time. While for thrombolysis, if we can't shift the patient to big center, so we'll do the thrombolysis within 30 minutes. So 30 minutes is door to needle time. Needle time means start of thrombolysis. Start of thrombolysis. So these are the very important decision making or treatment of myocardial infarction. Now, coming to the some of the important questions on the ECG. So Brugada pattern, this is given in your previous years. Brugada syndrome. This is a mutation of sodium channel, and it will produce a coved. Look at the cove. So this is a coved ST elevation which will be present. So it is known as Brugada syndrome. Brugada syndrome. While there is ST segment depression. So ST segment depression is present in a pattern of hockey stick. So this is hockey stick. This is seen in digoxin. This is seen in digoxin. Some more image-based questions. So when you see a tall T wave, it will be a part of hyperkalemia. Very frequently asked question. Tall T wave is seen in hyperkalemia and also in hyperacute MI. When the T wave is a narrow T wave, thin T wave, this is hyperkalemia, and when it is a broad-based T wave, it is seen in myocardial infarction, MI. Now, coming to the some of the T wave abnormality. So when the T wave is tall and ST segment depression is present, ST depression, tall T wave. So this is known by the name of Wallin T wave, important MCQ, and it is seen in cases of LED blocking causing the myocardial infarction, anterior leads, anterior chest leads. So T wave will be tall. This is a T wave which is tall, and ST segment depression. Both are seen in the same patient, Wallin T wave. While when the T wave is deeply inverted, it is deeply inverted T wave. So this is known as a giant T wave inversion, and it is a hallmark of HOCM hallmark. While QT interval, so this question is usually a pharmacological question. So the drug are important for prolongation of the QT, and these are all the drugs that you should be knowing. Antiarrhythmic drugs, class 1A and class 3. Many antibiotics can lead to the QT interval prolongation, and very important, and tricyclic and tetracyclic antidepressants. So at least these you should be knowing about the prolongation of the QT. Now moving on to the arrhythmias. So in the arrhythmias, most important arrhythmia at your level are the AV blocks. So focus on the AV blocks. So these are most important bradyarrhythmias. AV node origin. AV node origin. So first degree AV block will be that all the P will be followed by QRS and PR interval will be prolonged. So this is P wave, and as you can see, each P followed by QRS. But PR interval, this is the PR interval which is determined here. PR interval is prolonged. PR interval is prolonged. It will be more than 5 mm. More than 5 mm. So this is a typical description of first degree AV block. While second degree AV block, each P not followed by QRS. Here the third P wave is not followed by QRS. In this second P is not followed by QRS. So these are some of the diagram based, image based questions, very important. So this is a variable PR interval in the above one. So if the PR interval is progressively increasing or variable, it is MOBIS type 1. While if the PR interval is fixed, it is MOBIS type 2. While third degree AV block is no atrial impulse is going to the ventricle, and there is no relation between P and QRS. P wave is coming separately, QRS is coming separately, and how to diagnose it very fast? QRS will be wide. So whenever you see a wide QRS complex with bradyarrhythmia, third degree is given to you. It is a case of third degree AV block. Third degree AV block. While tachycardias, so the most important tachycardia you will be getting are direct stat questions, image based questions, atrial flutter. So whenever you see these types of flutter waves, so these are the flutter waves. These are the flutter waves, sawtooth waves, like the instrument to cut the woods. So these are the typical pattern of sawtooth P wave appearance. So whenever it is mentioned, atrial flutter will be the answer. While P wave absent and irregular heart rate. Indeed, any tachycardia with irregular heart rate for your level, mark this as a case of atrial fibrillation. So important hallmark is irregular. So here you can see there is no P wave which is present. No definitive P which is present in this ECG. P is absent. While the same thing, if the P wave is absent but with regular heart rate, so you can see heart rate is regular here. Heart rate is regular. So this is a case of regular rhythm. So this is a regular heart rate, and only one wave is seen between two QRS, that is known as a T wave. So P wave is absent. So important hallmark PSVT will be the answer here. While supraventricular tachycardia, so ventricular tachycardia will be here. The QRS complex will be wide. So, in cases of ventricular tachyarrhythmia, wide QRS will be present. If the heart rate is 100 to 250, it is a ventricular tachycardia. While when the heart rate is more than 250, these are all QRS complexes which are coming. So when it becomes more than 250, ventricle flutter will be present. And when no definitive QRS are present, so you can see no definitive identifiable QRS. This is ventricle fibrillation. Treatment of choice, DC shock will be given in ventricle fibrillation. And Torsades de Puentes, QRS is showing increasing trend, decreasing trend, increasing and decreasing trend. So this is important part of Torsades de Puentes. So the drug of choice for Torsades de Puentes is asked. So the drug of choice for Torsades de Puentes is magnesium sulfate. For ventricular tachycardia, if it is a polymorphic ventricular tachycardia or ventricle fibrillation, go for DC shock. If it is monomorphic, patient is stable, we will go for emetron. So emetron will be given here. So these are some of the image based. So in your mind, just look at the image and then they will ask you what treatment you should be giving in those patients. So ECG, one question is guaranteed, especially the arrhythmia questions. Now moving on to the GIT part. So in the GIT, esophageal disorders they will ask, and especially the image based questions. So as you can see in this image, there is a cork screw esophagus on the barium swallow. So if there is a cork screw, this is seen in cases of diffuse esophageal spasm. So esophageal spasm are present. They might ask you what will be the treatment. Muscle relaxant, nitrate and calcium channel blocker will be given. While if there is a bird beak appearance, so look here, this is a bird beak appearance. So here the lower esophageal sphincter, it is defective here. So this is a case of eclasia. So this is eclasia, bird beak esophagus eclasia, and treatment is usually surgical treatment. Heller's myotomy will be given here. So two important diagrams of radiology and medical diagnosis. Coming to the H. pylori. So H. pylori infection is asked, and especially the investigations will be asked from you. So in the H. pylori investigation, most sensitive investigation will be the biopsy test, biopsy urease test. Specific will be culture, and this question, best for treatment follows. It is a urea breath test. Urea breath test. So if H. pylori you are reading just before the exam, just go through this section, investigations. This will be investigations. Now, Poem syndrome. Poem syndrome is seen in multiple myeloma. It is seen in multiple myeloma. While the topic of the diarrhea, so in the topic of the diarrhea, I would recommend just go through the inflammatory or invasive diarrhea. Frequently asked question are from here. So salmonella will cause pea soup diarrhea, and very important question, Guillain-Barré syndrome, most common infectious cause of the GBS is Campylobacter jejuni. Pseudoappendicitis, it is caused by Yersinia. Hemolytic uremic syndrome, Shigella, and liver abscess will be by Entamoeba histolytica. So every important systemic manifestation is a potential question. Now, coming to the inflammatory bowel disease. So one question will always come. Last moment revision topic. Last movement revision topic, and the keywords. Keywords for ulcerative colitis is tenesmus. Keyword for Crohn's disease is fistula formation. So clinically, these will be the findings. These will be the finding. Ulcerative colitis, you will get a rectal inflammation, tenesmus, ileum disorder, you will get fistula formation. While antibody will be P ANCA. So focus on this column, and ASCA will be for Crohn's disease. For the Crohn's disease, non-casetic granuloma, it will be present in Crohn's disease. That will be sufficient to make a diagnosis of CD. Drug of choice for severe IBD will be methylprednisolone. In your exam, treatment-based questions are less for ulcerative colitis, Crohn's disease. Many questions are on the pathogenesis or pathological aspects and complications. Now, this topic, neuroendocrine topic, is a favorite topic of your examiner. Even in the same exam, 2-3 questions come from this neuroendocrine system, and what they pick a unique clinical feature. So just focus on this unique clinical feature, FAQ. Focus on that. So if a patient has a secretory diarrhea, hypokalemia, pancreatic cholera, we call this as. So this is a case of VIP. Carcinoid will cause tricuspid regurgitation murmur along with the secretory diarrhea. Glucogonoma, it will show skin migratory rashes. So this is again repeated many times, necrolytic migratory erythema. So that is seen in glucogonoma. While in spite of the tumor, patient has weight gain. So weight gain in tumor, it is going against the logic. So weight gain will be present when patient has hypoglycemia seen in insulinoma. And the drug which can be given is diazoxide that decreases the insulin release from the pancreas, and investigation will be fasting hypoglycemia. While in jaundice, the most important section will be the hepatitis portion. So unique viral hepatitis with their keywords. So epidemiological wise or serological wise. So if the question is most common cause of AVH in children, answer will be hepatitis A. While most common cause of AVH in pregnancy or adults, answer will be E, and it has got a maximum risk of fulminant hepatitis in cases of pregnancy. E is a very important virus. While most common blood transfusion related virus, as well as it is the most common viral cause of the chronic hepatitis. Most common cause of chronic hepatitis, viral cause, most common cause of the carrier state, answer will be hepatitis B. And hepatitis B, this portion will be asked from you, that is post exposure prophylaxis, PEP. This is must. Last moment revision topic. Post-exposure prophylaxis, if someone has got a needle stick injury from infected patient, hepatitis B. So the person who got the needle stick injury, if that person is vaccinated, check the anti-HBs level. If the level are below 10, then give immunoglobulin and booster dose. While level, protective antibody level is more than 10. Anti-HBs is a protective antibody, nothing to be done. So read the levels very carefully. More than 10, nothing to be done in that case. Unvaccinated individuals, we will have no other choice other than immunoglobulin will be given along with first dose of vaccine we will start with. So this is very important. And two other viruses where PEP will be asked, rabies and HIV infection. That should be on your tips. While the hepatitis C virus. So hepatitis C has an important epidemiology that it is the most common viral cause of the cirrhosis, and the risk of chronicity is very high. It is very high. And for chronic hepatitis C, we will go for antiviral therapy, and that can be asked from the pharma also. We will go for sofosbuvir plus velpatasvir, and that is 12 weeks of duration. But when the cirrhosis is decompensated, there is no other option other than liver transplant. Indeed, most common indication, most common indication of liver transplant in the world these days is hepatitis C. It is hepatitis C, not alcohol. Hepatitis C is the most common indication for the liver transplantation. While for hepatitis D, it has the maximum risk of fulminant hepatitis. Reason, there are two viruses in the body. One is B, other is D. So when two viruses damage the liver, that it will be more damage. Fulminant hepatitis risk will be very, very high in this hepatitis D. While for the chronic hepatitis, my advice to you is Wilson disease. Wilson disease and non-alcoholic fatty liver disease. Nowadays it is known as MASLD. Question will be coming from these two. So MASLD is associated with obesity and type 2 diabetes, and new drug have come for MASLD, non-alcoholic fatty liver disease. So that drug can be a potential question. Resmetirom. This is a new drug. Resmetirom. It increases fatty acid oxidation. So fatty acid will not make more triglycerides. Hence it is useful. Hence it is useful. While for Wilson disease, tremor and KF ring will be given to you. Ceruloplasmin will be low, and gold standard test will be liver biopsy. Drug of choice, zinc and penicillin. While in the scoring system, my prediction is BELD score will be asked and a MADRE score. These are the two scoring system. MELD score is for liver transplant and MADRE score is for alcoholic liver disease. So MCQ potential. So two parameters are used in every scoring: bilirubin and INR, bilirubin and prothrombin time. Extra parameter you should remember is creatinine. Creatinine is used for MELD scoring system. While for the complications of liver failure, out of all the complication, SBP you should be knowing. They are giving more and more questions on spontaneous bacterial peritonitis. So the most important pathognomic hallmark of SBP is this one: ascites fluid neutrophil count will be more than 250. So they will give you a question: patient has ascites. Whether you give diuretic or whether you give antibiotic, decision will be dependent on this single most parameter, neutrophil count in the ascitic fluid. If it is more than 250, go for cefotaxime. If it is less than 250, diuretic will be given. That is a case of ascites. That is a case of simple ascites. Diuretic will be given in that scenario. So out of all complication, just focus on SBP, spontaneous bacterial peritonitis. So these are the important topics of the medicine that we have discussed. So if I will summarize for you the topic that you should be doing in the last moment from cardiovascular system, JVP is must. JVP is must. Second important topic is cardiac murmur. Third will be valvular heart disease. Heart failure topic, especially the drugs. Then topic of MI and in the ECG arrhythmia. So out of these 6 topics, you will definitely get 2-3 questions from these topics of CVS and from the GIT. From the GIT, the esophageal disorders, then neuroendocrine tumors like carcinoid syndrome, insulinoma, glucagonoma, they will be asking. Then they will ask you hepatitis B especially. That is a very, very important topic. And in the chronic disease, Wilson will be asked. And in complication, it will be SBP. So this is a summary for you ki just before the exam, when you have less time, you want to study the high yielding topics. So these are the high yielding topics of CVS and GIT. So with this, I finish my session and wishing you all the very best for your upcoming exam.
Hello everyone, how are you guys? Hello everyone, how are you guys? So we are going to start our session now. Can you please acknowledge, is everything fine at your end? Audio video is fine? If everything fine at your end, beta. If everything fine, then we can start our session and we will be starting with our, all right. So how are you guys? How is the preparation going on? कैसे चल रही है तैयारी? हाँ. So I know कि you guys have already prepared and you guys have worked hard. So believe in yourself and believe in God, and very soon, very bright future is waiting for you guys. So with that positive attitude, let's start our session. Yes, Rab Rakha. So dear friends, all these are the high yield topics that we have to quickly, revise. What is this topic? This is where the question is asked, the patient got injured in the posterior triangle of the neck, the spinal accessory nerve got injured. The spinal accessory nerve will be injured. The user history is given, there was no light, the person was going through the staircase and the nail was hit, something like that. Or they can give the history that the patient coming to you for the lymph node biopsy. For the lymph node biopsy, when you try to do the lymph node biopsy, the nerve also got cut. Which nerve is got cut? That is your spinal accessory nerve. And what muscle will be paralyzed? That is your trapezius only. Only trapezius muscle will be paralyzed. But if the same nerve gets injured at the level of, you know base of the skull over here, and then it travels like this, if it is getting injured over here, in that case both trapezius as well as the sternocleidomastoid will be injured. Is that okay? Chalo, bahut अच्छे. Now here we have the muscles of the tongue. Which one is the safety muscle? So as per the position, palate is above, it does the elevation. It does the elevation. Higher it is below, it does the, depression. Genio is in front, so it will do the protrusion, and stylo is behind, so it will do the retrusion. Those are the actions. Now, which muscle is called as a safety muscle of tongue? The genioglossus is called as the safety muscle of tongue. And what is the safety muscle of the larynx? Safety muscle of the larynx is nothing but the PCA, safety muscle of the tongue, but safety muscle of the larynx, if they ask, then answer will be PCA, posterior cricoarytenoid. Very good, Prince. Genioglossus is the correct answer. Very good. Now we can see the two more muscles over here, geniohyoid and thyrohyoid. They both are supplied by the same nerve. Can you tell me what is the nerve supply for both of them? Both of them are supplied by C1 fibers, which travel via the hypoglossal nerve. Is that okay? Let's discuss this. Hanji. Pterion. This is very, very important area where meeting of the four bones are there. But what is the question asked? The question is asked what lies deep to it. So we have anterior division of middle meningeal artery. And if they ask which bony landmark, then answer will be lesser wing of sphenoid. And if they ask which part of the brain is related deep to that, then answer will be stem of lateral sulcus, like that. ठीक है? And middle meningeal artery. Question to all of you. Middle meningeal artery is a branch of which artery? Middle meningeal artery is a branch of which artery? Next area is this, where we have all muscles of the palate and the pharynx are supplied by vago accessory complex, mainly the 10th nerve. Mainly the 10th nerve. But we have the exception over here, tensor palatini muscle and the For the palate, which is supplied by mandibular nerve. For the pharynx, we have stylopharyngeus muscle, which is supplied by ninth nerve. For the larynx, we have recurrent laryngeal nerve for all of the, all of the muscles, but we have exception cricothyroid, which is supplied by external laryngeal nerve. For the tongue, as we understand, the hypoglossal nerve, and all the muscles of the tongue will be supplied by the hypoglossal nerve except palatoglossus. Palatoglossus is supplied by VAC because it has got two components, palato and glossus. Glossus means tongue. It is coming for the tongue, it is in the exception list, means it is not taking supply from the glossal side. It must take from the palate side. And what is the supply of the palate? VAC. That's why it is also supplied by VAC. Will you remember this? Now here you can see that we have infrahyoid muscles. All of them are supplied by the ansa cervicalis except thyrohyoid. Now this is very important. Why? This is a recent question. Last exam, this was the question. The marking was there on the ansa. And they said which one of the following, is not be supplied by this mark structure. Very good, beta. Very good. Now we have these glands and these parasympathetic nerves, right? So we have lacrimal gland here, the highest position, and for that something great is required, that is greater petrosal nerve for the lacrimation. Okay, and this is the gland over here, parotid gland, where we have position is little less, so lesser is okay, lesser petrosal nerve. And here we have the submandibular gland, position wise third gland, first, second, third. And for the third gland, we have the third alphabet C, that is coda tympani. But for the coda tympani, we have one more role, that is to carry the taste from anterior two-third of tongue. From the anterior two-third of the tongue. Lingual will be carrying all the general sensation from the anterior two-third of the tongue. And ninth nerve, it supplies all type of sensation in the posterior one-third of the tongue. Internal laryngeal nerve, which is going to supply all the sensation in the posterior most part of the tongue. Internal laryngeal nerve is a branch of which nerve? Can you tell? Internal laryngeal nerve or the posterior most part of the tongue is supplied by which nerve? That means internal laryngeal nerve is a branch of what? It is a branch of vagus nerve. Very good, beta. It's a branch of vagus nerve. Now let's have very quick revision. And we know that what are the vitamin K dependent factors? Vitamin K dependent factors are 2, 7, 9, 10. What are the parasympathetic nerve supply? Parasympathetic nerve supply was 3, 7, 9, 10. That means these nerve carry parasympathetic fibers also. And we have pharyngeal arch nerve supply. All the pharyngeal arches, they get the nerve supply, that is 5, 7, 9, 10. Right, very good. Now what we can see over here is this nerve which is going to approach the pinna from below. That is the great auricular nerve. Now from this aspect we can learn the nerve supply of the pinna very easily. I hope you remember what we discussed in the class. Do you remember that V, which was great auricular nerve, and we were holding the pinna like this? You remember that? So here we can say that lower part of the pinna, both outer surface and inner surface are supplied by great auricular nerve. Upper and outer part is next to parotid, so auriculotemporal nerve. Upper and inner part is next to the occiput, so we have the lesser occipital nerve. And we have the concha region over here, which is, supplied on both aspects by the auricular branch of the vagus nerve, which is also called as Arnold's and Alterman's nerve. So far, so good. Now, dear friends, okay, let me ask one question here. There will be two different syndromes that we are going to talk about. And let me give you the two scenarios. You have to identify the name of the syndrome. You are having food, okay, and you are offering the food to your friend, and your friend starts crying. What is this syndrome? If you are offering a food and the friend is now started crying, what is this syndrome? Is this true cry? No. The false tear? Yes. The false tears are called as crocodile. So the name of the syndrome is crocodile tear syndrome. Now take the second situation. You ask you offered the food to friend, but then the patient or the friend started sweating. What type of sweating? When we offered food, that is gustatory sweating. Gustatory sweating is called as Frey syndrome. Are you understanding? Frey syndrome. For the Frey syndrome, what nerve is involved? Auriculotemporal nerve and great auricular nerve both. But for crocodile tear syndrome, seventh nerve is involved. Do you appreciate, beta? Very good, beta. Very good. Good to see that you have identified both the syndromes properly. Good. Now, what is this? This is the part which is we have articular disc, which is in continuity with the lateral pterygoid muscle. Lateral pterygoid muscle is the mouth opener. Please remember. And sometime while yawning, some people will open the mouth in a violent manner. Ah, like that, है ना? तो मुंह खोला खोला और खुलेगा खुला रह गया, because the force will be transmitted to the articular disc. It will be given over here, and the joint will be dislocated. The patient opens the mouth but could not close because the joint was dislocated. Very good, Vera. Very good. So far, so good. What is this? Now, this topic is a projected question. Why? Because it has been asked in the INI exam, it has been asked in the NEET exam number of times. Even though in our exam till now it has not been asked. But if you look at the pattern, right? In last 2 3 years, if you observe the pattern in all the exams, FMG exam, now the pattern and the difficulty level is that of the NEET and the INI level, and the board is also same. That is why I have put this question. Just in case they ask this question, you should be prepared. Okay. So what are the set of questions they can ask over here? The question is, if they ask, like, you are as a surgeon, you are operating on the submandibular gland excision, right? Which nerve is at risk of injury? Then we have these nerves at risk of injury: lingual nerve, hypoglossal nerve, and marginal mandibular nerve. All three are at risk of injury. But if they ask which one is the most common involved, in that case you have to understand this is the most common involved, beta. This is the most common involved. But they can also ask, when you are you are doing the surgery in this whole area, which nerve is not at risk? Not at risk will be inferior alveolar nerve, also ninth nerve, because ninth nerve is protected by the shield of a muscle, like that. Okay. And if at all they give structure to identify, these are the structure which get injured and not injured. But sometimes they can simply give a marker and then they can ask you to identify. For identification, you have to understand if the structure is above the gland, or the structure is below the gland. If the structure is above the gland, then it can be either the lingual nerve, or it can be the facial artery. Lingual nerve or facial artery. Okay, lingual nerve and facial artery. But structure below will be the hypoglossal nerve. So far, so good. So these are directly asked question, beta. So be ready with that. Now, what are the layers? We know once one layer is investing all the structure together, that will be called as the investing layer of deep cervical fascia. One, we have the vertebra. We have the vertebral muscles, prevertebral, paravertebral. As a whole, we have a compartment, the vertebra with the muscles, and that is surrounded by the prevertebral fascia. In front, we have esophagus. Further in front, we have trachea. And in front of the trachea, we have the thyroid gland, and the thyroid gland is covered by one fascia which is in front of the trachea, and that is why it is called as pretracheal fascia. And between the trachea and esophagus, we have a nerve. Yes, dear friends, can you tell what is the name of the nerve? Recurrent laryngeal nerve. Recurrent laryngeal nerve. And we have all the three fascias contributing towards the formation of this sheath, which is called as carotid sheath. Now, carotid sheath is important for us. Before I show you, can you tell me what are the relationship of the carotid sheath? Who is present anterior and who is present posterior? Anteriorly, we have one nerve, ansa, and posteriorly we have one trunk, that is sympathetic trunk. Do you appreciate this? All right. Now see this part. Here you can see anteriorly we have ansa, posteriorly we have the sympathetic trunk. Inside we have artery, vein, and the nerve. Which artery is not contained? Carotid sheath. So carotid arteries will be present. Common carotid arteries there. internal carotid artery is also there, but external carotid artery is not there. It is going outside. Okay, like that. The point is, what nerves are present in between? We have the 10th nerve continuously present, but at the level of the root of the neck, where we have, the formation of the in the uppermost part of the sheath. That time we have 9 to 12th nerve. All are the contents which are present, but out of these nerves, 9 to 12, the rest will pierce and go out. Only 10th nerve will be continuously present. That's how we will say the 10th nerve is the continuous content. So far, so good. Now, dear friends, this is what is the syndrome. These features are given to you. Identify what is the syndrome here. What is the name of the syndrome? The name of the syndrome is Brown-Sequard syndrome hemisection, which is the hemisection. And what really happens here, all the features here are ipsilateral. If you check, you will say ipsilateral loss of fine sensation. Okay, ipsilateral loss of ipsilateral spastic palsy below the lesion, ipsilateral flaccid palsy at the lesion. So everything is ipsilateral, except for one thing, contralateral loss of pain and temperature. Only one thing is contralateral, that is pain and temperature. Okay, so this is hemisection, Brown-Sequard syndrome. All are ipsi except contra. One is contra, which is crude, which crosses. You remember our mnemonic? What was our mnemonic? Do you remember the mnemonic here? For this tracks part, we have learned one mnemonic. I hope you remember that. That is FUCC. Remember that. Fine moves upward, crude will cross. Because fine remain on the same side. That's why ipsilateral loss of the fine sensation is there. But crude is going to cross. That's why it becomes contralateral. So crude, cross, contralateral. Rest all the features are ipsilateral. Will you please remember this? And please confirm if you have understood, all of you. Are you guys done, beta? What are these? These are the deep nuclei of the cerebellum, and we have from lateral to medial. This mnemonic is this: doctors eat good food. Do we really? No, we eat. Doctors eat given food, or you can say doctors eat Gautam Nagar food, right? So what is that? Dentate, emboliform, globose, and fastigial. Correct है? Dentate, emboliform, globose, and fastigial. And these two taken together is equal to nervus interpositus. So all of us, we know there has been evolution in the cerebellum. If I ask you, fastigial belongs to which part of cerebellum? It is a part of archicerebellum. And nucleus interpositus is a part of paleocerebellum. Dentate is a part of neocerebellum. That is, it is the latest one. The dentate is the latest one. What are the layers of the cerebellum, beta? We can remember them as MPG, molecular layer, Purkinje layer, and the granular layer. Molecular layer, Purkinje layer, and the granular layer. Molecular layer is having two cells. What cells are there? Basket cell and stellate cell. Those are present in the molecular layer. Purkinje cells layer is present, only one cells are there, that is Purkinje. That too only cell body will be there because dendrites are above. You can see the dendrites are here and the axon is coming out. In the granular layer, we have the granule cells. Also, we have the Golgi cells. And this is how, the question can be asked. You're missing paratha, हाँ warm up paratha याद आ रहा है आपको? And let me tell you, dear friends, आपने जो एक एम को लेकर के चले थे ना, आप you guys are almost about to get that dream, right? You are almost about to reach that aim. And when you look back, है ना, when you एक होता है rewind पे आप, you will relive all those moments, you will see, and then you will have a very good smile on your face, and you will think that, oh, your future self will thank you, that thanks buddy, that you have taken all the pain and now I can enjoy. So your future self is going to enjoy definitely. Okay, so dear students, keep on working hard because now very less time is remaining, and जितना भी है अभी के पूरे टाइम में एफर्ट लगा दो, बहुत ही जल्दी आपको बहुत ही अच्छा एक रिजल्ट मिलने वाला है। और आपने जो सपना सालों पहले देखा था, वो सारी चीजें अब एक स्ट्रीमलाइन हो जाने वाली है ना? ठीक है बच्चे, कैसा लगता है आपको? एक बार के लिए चैट में जो जो लोग मौजूद हैं वो अपनी प्रेजेंस लगवाएंगे और बताएंगे कौन कौन अभी कमिट कर रहा है कि यस, अब जो रिमेनिंग टाइम है इसमें मैं रेगरेट नहीं करूंगा कि मेरा टाइम कहाँ कहाँ वेस्ट हुआ। इसमें रेगरेट करने के बजाय मैं इसमें पूरा कंसोलिडेटेड वे में पढ़ूंगा। राइट? कौन कौन प्रॉमिस कर सकता है इन द चैट बॉक्स नाउ, राइट नाउ? चलो एक वेव ऑफ पॉजिटिविटी क्रिएट करते हैं राइट नाउ फॉर एवरीवन। एज ए सेड कि नेगेटिविटी आपको ढूंढनी नहीं पड़ती, वो ढूंढते हुए आपके पीछे आती है, तो आपको उसको अवॉइड करना है। आपको अपने सराउंडिंग में हमेशा पॉजिटिव ऑरा बना के रखना है ताकि आप और आपके फ्रेंड्स सभी उससे बेनिफिटेड हो, क्योंकि ये कॉम्पिटिटिव एग्जाम नहीं है। हम और हमारे फ्रेंड्स एक साथ पास होने चाहिए, ऐसा हमें एफर्ट करना चाहिए, और हो सकते हैं और होंगे भी। राइट? तो डियर फ्रेंड्स, एक पूरी पॉजिटिविटी के साथ अपन या आगे बढ़ते हैं। बहुत अच्छे बेटा, बहुत बढ़िया। ऐसा ही एक पॉजिटिविटी का वेव बनाए रखें अपनी सराउंडिंग में। ओके, चलिए बहुत बढ़िया। What are the type of fiber here? There are two type of fiber mainly. One type of fiber which can climb up to the highest. That's why they are called as climbing fiber. And these fibers are coming from the olivary nucleus. These fibers are coming from the olivary nucleus. Rest all fibers, they are not, they are coming from different sources. Different sources they are coming from, and they all together they are called as mossy fibers. All together they are called as mossy fibers. राइट? हाँ बेटा, जरूर जरूर अर्ज करेंगे। कुछ कुछ पोर्शन हमारा है, ये हो जाए मैं आपको शायरी जरूर सुनाऊंगा। इसके बिना ऐसा हो ही नहीं सकता कि क्लास बिना शायरी के पूरी हो जाए। राइट? तो Mossy fibers ka, we don't have to remember the source, but the question will be asked here where these fibers are relaying, or indirectly what is the output cell. Can you tell me? Let me ask all of you guys. Output cell of the cortex. Output cell of the cortex. Yes, सब पास होंगे। Very good. An output cell of Purkinje. Output cell of the cerebellum, not output cell of the cerebellum as a whole. Output cell of the cortex will be Purkinje. Output cell of the cortex will be Purkinje. And output cell of the cerebellum will be deep nuclei. Yes, Mosi will be heavy. Very good. Now, dear friends, this is flow of the fourth ventricle. The floor of the fourth ventricle. What question can be asked here? Let me highlight the things which can be asked. They can ask you the question over here, facial colliculus. Because facial colliculus, which nerve around which nucleus? Because the name is facial, it is the seventh nerve around sixth nerve nucleus. Question can be asked over here, upper part of the pons where we have locus ceruleus. Locus ceruleus is the one which is norepinephrine releasing. Vagal triangle, which is 10th nerve nucleus is present. Hypoglossal triangle, 12th nerve nucleus is present. From above downward, we have the position like 6th, 8th, 12, and 10. That is the relationship. From above downward, we don't have 6, 8, 10, and 12. We have 6, 8, 12, and 10. And this is again very important, area postrema. Area postrema is vomiting center. Area postrema is vomiting center, CTZ. All right, dear friends. So, are you guys done up to this much part, everyone? तो यहाँ पे एक छोटा सा शेर आपको सुनाते हैं, ठीक है, आपको मोटिवेट करने के लिए और आपको बताने के लिए कि वक्त बहुत जल्दी बदलने वाला है। तो अर्ज किया है, यहाँ पे आपने इरशाद बनाया, लिखो आपके कमेंट्स में। करें, सुनाए। तो अर्ज किया है कि वक्त से लड़के जो अपना नसीब बदल दे, इंसान वही है जो अपनी तकदीर बदल दे। वक्त से लड़के जो अपना नसीब बदल दे, इंसान वही है जो अपनी तकदीर बदल दे। कल क्या होगा ये मत सोचो, क्या पता कल वक्त खुद अपनी तस्वीर बदल दे। ओके, ऑल द वेरी बेस्ट। आई रियली होप कि आप लोग एक्सेल करेंगे इस एग्जाम में, राइट? नाउ व्हाट आर दीज आर ओपनिंग्स ऑफ द डायाफ्राम वेयर वी हैव IVC opening, esophageal opening and aortic opening. What will happen to them? We know the esophageal IVC opening will undergo dilatation. It will dilate, and because the venous return is increasing, okay, IVC will pass and only right phrenic nerve will pass from here, whereas esophagus along with left and right vagus will pass from the esophageal apparatus, okay, and the left gastric artery branches also for the esophagus. Aortic opening, we have ATA, that is aorta, thoracic duct and azygous vein. And what will happen to it's no change because it is behind. It is behind. ठीक है? And the levels are T8, T10 and T12. What are the question asked at this level? Root of the lung. The question are asked to anterior to posterior VAB, vein, artery, bronchus. Highest structure on the left side, pulmonary artery. On the right side, epiarterial bronchus. Why? Because above the artery and below the artery, we have two bronchus. For two bronchus, we have one bronchial artery. Whereas for one bronchus, we have two bronchial artery on the left side. Bronchopulmonary segments. What are the important features? It is conical, having everything inside, like tertiary bronchus inside, pulmonary artery inside, bronchial artery inside. Only one thing is shared. Can you tell me what is shared here? Is the artery or the vein? What is being shared here? Pulmonary vein is the only structure which is being shared. That is intersegmental. And now surgically they are resectable. That's very, very important. And the question has been asked on this point, surgically resectable or not resectable, right? Now these are major coronary arteries, right coronary artery, LAD artery, and this will be LCX artery because these two are the branches of left coronary artery. And the accompanying vein are LAD will be accompanied by the great cardiac vein. Okay, this will be accompanied by the small cardiac vein. And this we need to remember, dominance is determined by PIVA. Do you guys remember PIVA? PIVA याद है सबको? सब लोगों को PIVA याद है? PIVA की कहानी? So PIVA determines the dominance. Mostly it is the right dominance, very less left dominance, and rarely codominance also. Widowmaker artery is the left anterior descending artery. Right conus artery is the first branch, and it is the third coronary artery. Third coronary artery. And diagonal arteries won't supply the right ventricle. कभी कभी right ventricle को मार्क कर देते हैं, उसके बाद पूछते हैं कि कौन सी arteries को supply नहीं कराएगी, तो आंसर उसमें होता है हमारा diagonal artery. This is the coronary sinus, and the question is usually asked which of the following will not, drain into it. So these are the veins which are not draining into it: anterior cardiac vein, Thebetian vein, and the right marginal vein. Among them, anterior cardiac vein is more important because the name is cardiac, yet it is not draining into coronary sinus. So far, so good. And this is the oblique sinus behind which we have esophagus. So if I ask you, in front of the esophagus, which chamber of the heart is present? What's your answer? Which chamber of the heart is present? What's your answer? That's left atrium in front of esophagus. and behind the sternum who is present, that is right ventricle behind the sternum is present. And please remember this, very, very important. Fossa ovalis represents foramen ovale. Floor of fossa ovalis made by septum primum. Limbus is made by septum secundum. Directly asked question. This is a PYQ beta, salt spa. You remember superior thoracic, acromiothoracic, lateral thoracic, salt spa. What is that? Subscapular artery, pacha acha. Can you tell me the full form of pacha acha? Do you remember that? And here the question is to identify also. The image based question was asked previously that you have to, remember here. Superior thoracic, that is the first branch. Second branch, acromiothoracic. Just lateral to the muscle, we have lateral thoracic, subscapular artery, anterior and posterior circumflex humeral artery. What is the full form? Anterior and posterior circumflex humeral artery. Now, House palsy versus Klumpke's palsy, very important area. So we know upper trunk C5, C6, lower trunk C8, T1. What will happen? Policeman tip. And I told you that you don't really have to mug up. Simply make the policeman tip deformity like this and think arm is adducted or abducted. Arm is adducted. And arm looks like medially rotated or laterally rotated. Arm looks like medially rotated. So two features at arm are adducted and medially rotated. Now when you do so, the forearm is looking like flex or extended. Extended, it is supine or prone. It is prone. So this is how you have to understand about the House palsy and Klumpke's palsy. In Klumpke's palsy, we have claw hand and also we have Horner syndrome. Very, very important feature. So these are the features of House palsy, and this is how the feature is of the Klumpke's will develop. Then person is falling from the height, suddenly tries to grab something, right? And if you pull the baby's hand like that, now I told you that even if this person is having this knowledge that when he's falling from the height, suppose someone is falling from the height and he's having the knowledge that if he tries to grab something, chances of clump case is there, but still he will try ना. ऐसा थोड़ी सोचेगा कि प्राण भले निकल जाए, क्लम्प केस नहीं होना चाहिए, राइट? और ये जो हैंड बेबी का बाहर आ रहा है, इसमें तो यू आर नॉट गोइंग टू डू द वेजाइनल डिलीवरी, राइट? तो ये अगर कोई सही डॉक्टर नहीं है, क्वैक है, तो क्या सोचेगा कि बेबी ऑलमोस्ट तो आ ही गया है, हाथ बाहर निकाल ही रहा है, तो हाथ से हाथ मिलाना, साथ ही हाथ बढ़ाना, ऐसे पकड़ के खींच लेते हैं। तो अगर वो ऐसे करेगा तो दिक्कत आएगी, यानी कि क्लम्प केस हो जाएगा। अंडरस्टैंडिंग, इन दोनों सूरत हाल में क्लम्प केस होना तय है, और अगर क्लम्प केस हुआ तो फिर ये सिचुएशन बन जाएगी कि उसका हॉर्नर्स भी हो जाएगा साथ ही साथ और क्लो हैंड भी हो जाएगा। डू यू अंडरस्टैंड? What is this? This is winging in action. Serratus anterior. Action क्या कर रहा है? जो hand है वो anteriorly present है, because the hands are anterior. That's why serratus anterior. That's why serratus anterior. ये क्या है? Winging at rest. तो hands अब rest में है, तो trapezius palsy. Okay. And what is this? This is your triangle of auscultation, and you don't really have to mug up. Simply think of big muscles which are visible from behind. So you can see trapezius, you can see latissimus dorsi, and you can see the scapula. These three are making the triangle. Let me show you: trapezius, latissimus dorsi, and the scapula. That's the triangle of auscultation. Okay. And the dorsal scapular nerve supplies all the muscles in the medial aspect: levator scapulae, rhomboideus minor and major. And action will be elevation, retraction, and glenoid cavity downward. Can anyone tell, if they ask single answer, what will be the answer? Elevation, retraction, या क्या? In that case, answer will be retraction. That's the most important action. Okay. And can anyone guess and tell me what is the name of the nerve which pierces a muscle? The name of the muscle will be coracobrachialis, and name of the nerve will be musculocutaneous nerve, which will continue as lateral cutaneous nerve. That's a question. Carpal tunnel syndrome, Palmar sensations are intact. Please remember, there is no loss of Palmar sensation. Guyan canal syndrome or fracture of hook of Hammett. In all these cases, ulnar nerve will be involved. Tinel sign. And what is this? What is this sign, beta? Or test name? Phelan test. Phelan test. So Tinel sign and Phelan test, they are for the carpal tunnel syndrome. We are aggravating the situation here, and the features of the patient will aggravate like that. Do you remember the story of two brothers? Small brother anteriorly present, big brother posteriorly present, brevis and longus. But the lady who was married to big brother, now she started living with the small brother. So abductor pollicis longus with the extensor pollicis brevis. And who is left all alone? Extensor pollicis longus. This is how we can remember the boundaries. What's there in the content? That is your radial artery. What's there in the roof? You have superficial branch of radial nerve, which is called as chiralgia. But what is there in the floor? We have to remember only one bone, that is scaphoid. Only one bone, that is scaphoid. Why? Because the blood supply is retrograde manner. If there is a fracture, then the proximal part will suffer. The healing will be poor. What is this Wartenberg syndrome? Wartenberg syndrome is the other name of chiralgia. But as soon as you change the term from syndrome to sign, Wartenberg sign, now what is this? Abduction of the fifth finger. Abduction of the fifth finger. Okay. And in this case, ulnar nerve will be involved. Previous Wartenberg syndrome, the radial nerve was involved. Wartenberg sign, the ulnar nerve is involved. Now, can you tell me CAR test and IGAVA test? They are done for which muscle? CAR test is checking which muscle and the IGAVA test is checking which muscle, right? This is for PAD. IGAVA is for DAB. Book test, yes. Can you tell which muscle is being tested here? The muscle which is being tested here is adductor pollicis. And which nerve? All these tests which we have discussed, like CAR test, IGAVA test, book test, they all are under ulnar nerve. Now, if adductor pollicis is working, the patient will hold the book like that. But if the adductor is not working, patient will make the fragment like this, and the same fragment is called as OK. The same fragment is called as OK. This fragment sign or OK. That is for ulnar nerve injury and adductor pollicis is not working. Is that okay? Now, these are some specific one-liner question that you have to remember. I am providing directly, which we have discussed already. Wrist drop, radial nerve, finger drop, posterior anterior nerve, foot drop, deep peroneal or common peroneal nerve, Brunner's gland, duodenum, Peyer's patches, ileum, Hess's corpuscles, thymus, Billroth gland, cord, spleen, lymphatic nodule with the central arteriole, spleen, housemaid knee, prepatellar bursa, clergyman knee, infrapatellar bursa. Pes and Serinus is girl between two surgeons, gracilis sartorius semitendinosus. An iliotibial tract will be inserted into the gluteus maximus and tensor fasciolata. Tennis elbow, lateral epicondylitis. Golfer's elbow, medial epicondylitis. These gluteal muscle, one of the sure short question, beta. Sure short question. One question will be asked from here. Inferior gluteal nerve supplying the gluteus maximus. This gluteal nerve supplying the gluteus medius and minimus. What is the action? They are the abductor and medial rotator. What about the maximus? Chief extensor. Trendelenburg sign. Do you remember? Now, if I ask you, the patient is having the right-sided drop. If the drop is the right side, where is the weakness? If the drop is observed on the right side, where is the weakness? The weakness will be on the left side. Now, if the weakness is on the left side, in which side the sign is positive? Weakness is there on the left side. So the sign will be also positive on the left side and the drop will be observed opposite. So drop will be seen on the right side. Do you understand? If the drop is on the right side, weakness and the sign positive will be on the left side. For the great saphenous vein and the short saphenous vein, what is the origin? Medial lateral. Regarding with respect to malleolus, This passes anterior and this passes posterior. What is the course? The course is medial leg behind knee, medial thigh. But here the course is posterior leg and accompanied by saphenous nerve, here sural nerve. Termination into the femoral vein and the popliteal vein like that. Now this is for you guys. Which artery is being palpated in both the pictures? Can you tell? Picture A and picture B. Which artery is being palpated? Dorsalis pedis artery and posterior tibial artery palpation. Now here you can see that we have different levels. Transtubercular plane is passing disc between T4 and T5. Very good. Smridhi. Transtubercular L5, transpyloric L1 and subcostal L3. Umbilicus L3, L4 ka disc like that. Now, dear friends, my question to all of you, if they give one picture of the plane and the plane has been drawn above like that, like this, then how to identify whether it is transpyloric or subcostal, because this may not be mentioned over there, right? Anji, we will make use of the costal margin. If it is below the costal margin, it has to be subcostal L3 level. If we're cutting across the costal margin, then it will be the transpyloric L1 level. Okay, very good, beta. Now, anteriorly, who is present? We have external oblique present. Can you see this arching? This one and this one. They are making the roof. And then we have conjoint tendon. Along with the facial transversalis, they're making the posterior wall. Then who is there in the inferior wall, or you can say floor? We know the floor is made by the inguinal ligament. हाँ जी, याद है सब? सर्जन कौन कौन आप जो अभी अटेंड कर रहे हैं उनमें से सर्जरी किसका फेवरेट सब्जेक्ट है? ड्रीम सब्जेक्ट? हाँ जी, ड्रीम के बारे में सोच लो और किसी को बताओ ही नहीं कि ड्रीम क्या है। बस आगे बढ़ते जाओ और जब जो हासिल हो जाए उसके बाद बताना ड्रीम यही था, है ना? जैसे आप सर्जरी में पहुंच के बताओ सर्जरी ड्रीम था, ऑर्थो में पहुंच के बताओ ऑर्थो ही ड्रीम था, गायनी पहुंच के बताओ गायनी। उससे क्या होता है कि आपको पत्ते नहीं खोलने हैं अभी, राइट? और आपका ड्रीम और बीच में कुछ नहीं है ना। और दूसरा कि कई बार नजर भी लग जाती है, जैसे आप लोग याद होगा अंधविश्वास में पूर्ण विश्वास। डू यू रिमेंबर दैट? Now, dear friends, what you can see here, these are some embryological remnants. You can see from the bladder to the umbilicus, we have median umbilical ligament, and on both sides we have medial umbilical ligament. What are the remnant of? Median is for urachus, medial is for umbilical. This medial umbilical ligament and making umbilical artery. That is the remnant of umbilical artery. So what about the umbilical vein? We have two umbilical artery. We have one umbilical vein. Left vein is left behind. And that left umbilical vein will be making the ligamentum teres. Do you appreciate now? So these are the boundaries of epiploic foramen. And epiploic foramen, above we have liver. Below we have D1, first part of duodenum. Yes, anteriorly. Right free margin of the lesser omentum, and I will not tell you guys will have to tell me Sometimes there's a bleeding, because I know that you have a very good command on the clinics part, right? If there's a bleeding during the surgery, the surgeon try to clamp this part. What is the maneuver name? What is the maneuver name, beta? First of all, this. And second thing, what triad is present here? These two are very, very important. So we can see in the posterior aspect, we have IVC, right suprarenal, and T12. And the triad which is present is the portal triad. And the name of the maneuver is Pringle's maneuver. What is this? Ejaculatory duct. At the time of ejaculation, the semen can go up or semen can go down. But to maintain the normal physiological condition, the semen has to go downward. How it is maintained? By this muscle which is proximal to this, and this muscle, uh, internal urethral sphincter, is going to contract exactly at the time of ejaculation. So this will be not allowing anything to go above, so the semen will go downward only. So that is how retrograde ejaculation will be prevented. In case of female, this is absent or poorly developed. Here we can see this median lobe is having the tendency for BPH, which undergoes enlargement. As a surgeon, you are removing this, and your approach was transurethral resection of the prostate. That's why the complication here will be what? Retrograde ejaculation. Why? Because when you solve this problem, the problem is solved because of the enlarged part of the prostate you have removed, but the sphincter is gone. Sphincter was the protection. Protection is also gone. So retrograde ejaculation will be the, it will be what? It will be your complication, beta. So far so good. Dentate line is above. Why? This is important. Above and below we have different features. Above endoderm, below ectoderm. Above it is supplied by ANS, and below it is somatic. ANS is painful or painless. Thus, the above area supplied by ANS will be painless or painful. It will be painless. But below it will be painful. Now, painful ke spelling mein, this is the normal right complete spelling, But sometimes students will add one more L over here. Maybe they want to tell it's heavily painful, right? But anyway. And what about the artery? Above we have superior rectal, below we have inferior rectal artery. So far as the veins are concerned, above is the portal vein, below is the systemic vein. And internal iliac lymph nodes and superficial inguinal lymph node. This is important. Why? This is important because recent question. That anal carcinoma near the anal verge will drain into superficial inguinal lymph nodes. Epithelium, simple columnar and stratified squamous. These are the typical, arrangement at the level of the epithelia. Now, what you can see over here, what is the diagnosis? Cell nest seen, no fiber seen, so hyaline. But if you see, observe the cells are present with the nest or single based cell also there, and long wavy and short wavy fibers are present over here. And then this one, look at the behavior, alternate fiber, alternate cell, parallel. Why this is so? This is fibrocartilage, which is having the fiber type 1 and type 2. Type 1 dominant. Now here you can see capsule, yes, but below the capsule, do you observe this small continuous gap is there? This small continuous gap is there. So this is the subcapsular sinus, which is a typical scenario for lymph nodes. Hanji, done? Are you understanding better? What is this slide? This is spleen, because we can see the red pulp and the white pulp and central artery. What is this? We can see this much thickness, which can be justified by the stratified epithelium, and the crypts are present. Can you see the crypts? This is very important that anterior neuropore day 25, posterior neuropore day 28. This is again a sure short question area. Sure short question area. If anterior doesn't close, anencephaly, posterior doesn't close, spina bifida. Okay, do you remember? And this is what formation of the upper lip. One frontonasal, two maxillary, and two mandibular. Mandibular will fuse very early to make the lower lip and chin. Without I show you, can you recall what are the processes which are involved in the formation of the upper lip? There are four processes: maxillary, medial nasal, and maxillary. These are the features: maxillary, medial nasal, and maxillary, like that. Wherever there is a formation, there will be a fort like that. All right. Non-fusion is equal to cleft lip or palate or both. So, dear friends, question can be asked the formation of the kidney. Please remember, pronephros and mesonephros, they are temporarily present. The final system will be made by ureteric and metanephros. How come? Metanephros makes excretory part. Ureteric bud will make collection part. Alright. Now, where is the kidney? Kidneys must ascend, beta. Testes descend and the kidneys ascend. If the kidneys ascend, it's okay. But if the kidneys fail to ascend, can you tell me in the chat box which artery will block the ascent? The kidneys normally should ascend, but if it is failed to ascend, which artery will block the ascent? It is the inferior mesenteric artery which will block the ascent. This is the pharyngeal arches. I hope you remember. What are the name of the arches? Mandibular arch and hyoid arch. After that, there is no name. What's the name of the cartilage? Meckel's cartilage and Richard's cartilage. After that, there is no name. Name of the nerve. Name of the nerve is 5, 7, 9, and 10. After that, we talk about the skeleton. We have mandible, premaxilla, maxilla, zygomatic, malleus, incus. Up to the first arch, done. Stapes, styloid, stylohyoid. After this, we need to tell about the hyoid. And remember this way that we have hyoid bone, hyoid bone, okay, upper part of the hyoid along with the smaller cornu, and this one will be the bigger cornu. वेरी गुड बेटा. ठीक है, ये याद है आपको? डू यू guys remember now pharyngeal arches? Can you do it? Okay. And regarding this pressure epiphysis, the one which makes the joint, always check the joint making. Always check which is not joint making. For example, if I ask you the condyle of the femur, that makes the joint? Yes. Head of the femur, that makes the joint? Yes. But trochanter, will they make the joint? No. They are jutting out part of the bone, that is traction. For atavistic, only two examples are there that you need to memorize: coracoid process and ostrigonum. So these are the only two examples for the atavistic and that you have to memorize. Aberrant means aberrant epiphysis not always present, sometimes present. Like for example, head of first and base of other. This is the called as aberrant epiphysis. रिमेंबर, जीतने का मज़ा तभी आता है जब सभी आपके हारने का इंतज़ार कर रहे हों. बहुत सारे लोग हैं आपकी लाइफ में भी जो आपके काइंड ऑफ वेल विशर्स हैं. आपको याद होगा, अब समय आ गया है उनको सबको जवाब देने का है, राइट? तो डियर फ्रेंड्स, अपना बेस्ट दीजिए और बी फोकस अर्जुना के तरह, ताकि आपको भी चिड़िया नहीं चिड़िया की आंख दिखाई दे, अपना लक्ष्य दिखाई दे, यू एंड योर गोल एंड नथिंग इन बिटवीन. So now let's do one very quick, mantra. I am the best. Repeat with me. I am the best. I know that I am a winner. I know that I am a winner. God is with me. God is with me. I can do it. I can do it. I can do it. Yes, I can. Yes, I can. Yes, I can. So thank you so much, dear friends. That is what we had to remember and revise in this part. Okay, all the very best. I know that you guys are going to rock, and this time you'll get very good marks. Believe me, okay, and believe yourself and have trust in God. Very soon, miracle is going to happen in your life. All right. All the very best. God bless you all. Take care.
My dear FMG students, welcome to the FMG Marathon, subject Pediatrics. I hope you all are ready. I hope everything is okay now. All good? Good evening, Mukul. So I think there should be no problem. Are we ready to start? Yes. Good evening. I hope now it is no more stuck. We are live here. So welcome to the session of FMG Marathon. We'll be talking of the very important topics which are very important for the FMG exam. So I've taken only those topics here is there. So if we talk here, basically the topic of the short stature. In the short stature, we are saying is the physiological causes. And in the physiological causes, we say CDGP, constitutional delay in the growth and puberty. It is CDGP. Now, in the CDGP, what we normally say, both parents are normal in height. Both parents are normal in height. Birth length is normal. Both parents are normal. Birth length is normal. There is delayed puberty. And because of the delayed puberty, what we get is bone age is less than chronological age. What we say here, bone age is less than chronological age. So both parents are here, particularly we say normal in height is there, right? Birth length is normal, puberty is delayed, but bone age is less than chronological age. But if you consider what is the ultimate height, that is normal. Ultimate height is normal. Now, if we consider the another physiological cause, familial short stature, what we say here, usually one or both parents are short. Usually one or both parents are short. If the child is short, ultimately the child has to be short only. So if the ultimately the child has to be short, what will be the birth length? The birth length is decreased. The birth length is decreased. But there is normal puberty. Because there is normal puberty, what we get here is bone age is equal to chronological age. BA is equal to CA, bone age is equal to chronological age. What is the ultimate height? Ultimate height is short according to population. Ultimate height is short according to population, but is but is normal for mid-parental height. But is normal for the mid-parental height is there. So is the child short according to the parents? No. Is the child short according to the population? Yes. It's a very important thing to be remembered from the FMG point of view. The difference between the familial short stature, and the constitutional delay in the growth and the puberty. An important thing to be remembered this one, right? Next topic I have taken is the APGAR score, right? Most of the times the APGAR score, how to calculate APGAR score. So we are getting these questions. So we are basically telling is the APGAR score. And my first line says APGAR score does not tell us about the need of resuscitation, because the first APGAR score is taken at 1 minute and resuscitation is started at birth. So APGAR score does not tells you about the need of resuscitation. APGAR score, why it was designed? APGAR score was designed that in the newborn we should come to know regarding the respiratory system, regarding the CNS, regarding the cardiovascular system. So for this there is an APGAR score. So if you say particularly in the APGAR score, the components are A, which can be for activity, P is pulse, G is grimace, A is appearance, and R is respiration. So if you particularly see here, this activity tells you about CNS, pulse, it tells you about CVS, grimace again tells you about CNS, and appearance, skin color, respiratory system. Here also it tells about the respiratory system. Now, first we talk is the activity. Now, when we say here, if the child, the question you give is the child is limp. Limp का मतलब है tone is absent. The APGAR score is 0. If there is partial flexion, it should be the word partially flexed arm and leg. You are giving partial flexion, your word is 1. If it is child is active, the meaning of active is child is moving limbs. Child is moving limbs, that goes in favor of 2. Right? Very, very true. Right? If the question can be a child is limp, not moving limbs at all. If the child is not moving limbs at all, your APGAR score is 0. Child is in partial flexion, your APGAR score is 1. Complete flexion or moving limbs, your score is 2 is there. Then is the pulse. Although we say pulse, but what we measure is the heart rate. We say pulse, but we measure heart rate. If the heart rate is absent, 0. Heart rate is less than 101. Heart rate is more than 100, 2 is there. Then is the grimace, which is basically a reflex irritability. Reflex irritability. Now, what basically it means is, right? Now, this is my hand. If I give a painful stimulus here, two things will happen. I will withdraw my hand and there will be a facial expression of pain. So when you are doing suction in a newborn, when you are doing particularly suction in a newborn, you are giving a painful stimulus. If there is no response, your APGAR score is 0. There is no response. If there is minimal response I am writing below here. What does this minimal response implies? Only the face becomes grim. Grimace is present. Only the face becomes grim, right? And if there is prompt response means you're doing suction, child is moving head, child is coughing, you're giving a score of 2. Every FMG student should know how to calculate APGAR score is there. Then is the appearance or the skin color. If the child is having central cyanosis, they write tongue is blue. You should think of central cyanosis 0. If there is pink body but blue extremities, peripheral cyanosis, your answer is 1. And if the whole of the body is pink, your answer is 2 is there. Last is respiration or respiratory efforts. Both are the same thing in the MCQs. Remember, respiration or it can be respiratory efforts. If they are absent, 0. If there is slow and irregular respiration. Slow and irregular respiration is 1. If there is vigorous cry, child has got a spontaneous cry, spontaneous respiration, it is 2. Right? Here, my dear students, any point on the APGAR score you can ask me, but it is something very, very important for you people to remember. So we are saying is no response, that is particularly 0, slow and irregular respiration 1, spontaneous cry, that is 2 is there. Then we say sign on X-ray in neonatal abnormalities. signs on the X-ray. In the hyaline membrane disease, what is the initial chest X-ray? In hyaline membrane disease, the initial chest X-ray is reticulogranular appearance. It is not ground glass appearance. Ground glass appearance is the final appearance. Final appearance. So in the hyaline membrane disease, which is due to surfactant deficiency, what is the initial response? That is the initial response is reticulogranular appearance. What is the final response? Ground glass appearance. In transient tachypnea of newborn, two appearance you get: sunray appearance and prominent bulging fissure, and this TTN is due to the retained lung fluid. This is due to the retained lung fluid. And where does the fluid collects? Fluid collects in the fissure, so there is prominent or bulging fissure. Meconium aspiration syndrome. The most common finding is the lung infiltrates. Lung infiltrates. And necrotizing enterocolitis, there is pneumatosis intestinalis or presence of air in portal way. Pneumatosis intestinalis means there is presence of air in wall of intestine. Presence of air in the wall of intestine. Last time you had two questions based on this respiratory disorders. HMD also, meconium aspiration also. Do remember the chest X-ray appearance, what we are saying here. Clear? So this was a third important thing which you should people remember is there. Next one. There should you know what is the difference of the word breastfeeding failure jaundice and breast milk jaundice. Breastfeeding failure jaundice or breast milk jaundice. Now what you need to understand, breastfeeding failure jaundice is usually seen in first week. Mother is giving less of the feed. If the mother is giving less of the feed to the child, there will be weight loss. There can be risk of hypernatremia, right? One of the important question. Due to inadequate breastfeeding, what can happen in the child? Hypernatremia can happen in a child. So in the breastfeeding failure jaundice, that is something usually seen in the first week of the life. This is due to insufficient intake. Breastfeeding is less. If the breastfeeding is less, there are chances of increased enterohepatic circulation. And if particularly the breastfeeding is less, there is weight loss which is seen. Very good, Prince. There is weight loss which is seen, and this can cause hypernatremia. So in this condition, you should remember there is increase in unconjugated bilirubin. Increase in the unconjugated bilirubin. Breast milk jaundice, that is seen in second or third week. That is basically seen in second or third week. A child has come to you, there is increased conjugated bilirubin, and the child is in second and third week. All the routine causes we have excluded. When there is no routine cause, then it is a diagnosis of exclusion, breast milk jaundice. What is the reason of breast milk jaundice? It is due to beta glucuronidase, an enzyme which is present in the breast milk, which increases enterohepatic circulation. Because the child is getting enough of the enough of the feed, there is a good weight gain which is seen. So in the breast milk jaundice also, there is increase in unconjugated bilirubin. So in both of these conditions, maybe breastfeeding failure jaundice and breast milk jaundice, there is increase in unconjugated bilirubin. But what is the difference? This is seen in first week, this is seen in second or third week. This is associated with weight loss, this is associated with weight gain. Then we say caput succedaneum and cephal hematoma. The both of them are swelling in the scalp. One is caput succedaneum, one is cephal hematoma. This caput is a subcutaneous swelling, right? The child was suspended in vertex position. Due to gravity, the fluid came down and collected below the skin. This is a subcutaneous swelling. And anything which is superficial or subcutaneous can cross suture line, can cross midline. This is present at birth and disappears in 2 to 3 days. Now, if in my hand is a subcutaneous kind of swelling, if I press, where I will press, a pit will appear there. So this is pitting type of edema. Pitting type of edema. This does not contain blood. Because there is no blood, no chances of neonatal jaundice. No chances of the neonatal jaundice. Cephal hematoma. Child was suspended in vertex position. I applied vacuum. Due to the vacuum, there is subperiosteal hemorrhage. This is a collection of the blood below the periosteum. If I take two parietal bones like this is the periosteum, this is the periosteum. So neither it crosses midline, neither it crosses suture line. Neither it crosses midline, neither it crosses suture line. But if you see in the caput, it was crossing suture and midline. So if this is a swelling present below the periosteum, I press here, swelling fluctuates to this side. I press here, swelling fluctuates to this side. So this is basically a fluctuant type of swelling. This appears in 2 to 3 days. Caput disappears and cephal hematoma appears in 2 to 3 days and persists for 5 to 7 weeks. And there is increased chances of the neonatal jaundice. Because this is containing the blood, so what will happen? Chances of the neonatal jaundice is there. Clear? Both swellings are important. You do need to remember the difference between caput and cephal hematoma is there. Then we consider the marasmus and kwashiorkor. Both are the important words. You should know the difference between them. Marasmus is something in extreme form. Kwashiorkor is not that much extreme, but the mechanism is different. In marasmus, what we say, the weight for age is less than 60%. The weight for age is less than 60%. There is no edema which is present. There is particularly no edema which is present. The child is alert with voracious appetite. Marasmic is weight for age less than 60%. Alert child, increased appetite. So what basically happens is if the child is not getting enough to eat, there is loss of subcutaneous fat. And due to loss of subcutaneous fat, there is loose folds of skin present. So there is loss of the subcutaneous fat. And due to the loss of the subcutaneous fat, loose folds of the skin are present. And this buccal pad of fat is lost in the last. And when the buccal pad of fat is lost, even the face becomes wrinkled. That face becomes wrinkled is called as old man faces. That is called as monkey faces. Old man faces, monkey faces. In this condition, there is no hepatomegaly. In this condition, there is no hepatomegaly which is seen. If we see in kwashiorkor, the weight for age is 60 to 80%. And in this condition, the edema is present. Right? Edema is present, and this is because of the protein deficiency. Protein deficiency. Mental changes are present, and there is decreased appetite. Decreased appetite. There is tense in the shiny skin, and this tense and shiny skin is due to edema. Their tense and shiny skin is due to edema. There is moon-like faces because there is decreased cortisol binding protein. And if the decreased cortisol binding protein is there, the increased amount of free cortisol, so what you get is moon-like faces. There is hepatomegaly, and the pathognomic feature is flaky pain dermatitis. Both of these topics are important. Just want to remember marasmus. Remember, marasmus is just like a monkey. You give anything to a monkey. What happens basically? The monkey snatches and eat. So this is an alert child with voracious appetite. This is an alert child with voracious appetite. But if you consider here mental changes are present and there is decreased appetite. So there is basically a difference between the word marasmus and the kwashiorkor is there. Right? Then dehydration, and we are talking of signs of dehydration in a SAM child, severe acute malnourished child. Yes, Mukul, very true. Marasmus is calories deficiency. Very true. Right. So we say here most reliable sign of dehydration in a SAM child is urine output. Remember this. The most basically you say reliable sign of dehydration in a SAM child is urine output. In the some dehydration in a SAM child, that is treated by giving Rizomol ORS. That is the rehydration solution for malnourished. This contains glucose 125, sodium 45, potassium 40. Compare it to the normal ORS. In the normal ORS, glucose is 75. Malnourished needs more glucose. You have made it 125. Already in the malnourished child, sodium is more. You have reduced the sodium to 45. Potassium is less. You have made it to 40. Apart from this, chloride 70, citrate 7, and at least remember which three minerals are present here: zinc, copper, and magnesium. Although magnesium is 3, zinc is 0.3, copper is 0.045, that is not to be remembered, but at least what you basically remember, the glucose is more, sodium is less, potassium is more, even chloride is more. If you consider in the low osmolar ORS, chloride is just 65, here is the chloride 70 which is there. If it is severe dehydration, what is the initial fluid of choice? The question which has been asked you 2 times. That the initial fluid of choice is 5% dextrose plus ringer lactate or 5% dextrose plus half normal saline. Initial fluid of choice is 5% dextrose plus ringer lactate or 5% dextrose plus half normal saline is there. Done here. This was regarding the SAM child. Then again an important topic, X-linked hypophosphatemic rickets. We are talking of X-linked hypophosphatemic rickets. It is a X-linked dominant condition. This is basically what? X-linked dominant condition. There is a gene called FEX gene, and the FEX gene location is XP22. There is a location which we call as the FEX gene, and the location is XP22, right? And in this what happens is increased amount of fibroblast growth factor 23. In X-linked hypophosphatemic rickets, there is increased amount of fibroblast growth factor 23. So what is basically causing this FGF23? This inhibits reabsorption. This inhibits reabsorption of phosphorus in kidney. This inhibits reabsorption of phosphorus in kidney. So there is increase in urine phosphorus. So the serum phosphorus becomes less. The point to be remembered here, serum phosphorus is decreased. Why it is decreased? There is increased amount of fibroblast growth factor 23, which causes impaired proximal tubular reabsorption of phosphate, leading to hypophosphatemia. If you consider here, serum calcium is normal. PTH level is normal. This is a very important point to be remembered. PTH level is normal in the X-linked hypophosphatemic rickets. Serum phosphate is decreased. The reason I already told you, fibroblast growth factor 23 inhibits reabsorption of phosphorus. So the urine phosphorus increases. That's why the serum phosphorus decreases. And the even 125 dihydroxycholecalciferol, that is calcitriol, that is decreased. Right? Simple words, remember rickets. What we remember is there, if there is increased PTH, you should think of vitamin D deficiency. What is to be remembered? Normal PTH level excludes the diagnosis of vitamin D deficiency. So if there is increased PTH, we should definitely think of vitamin D deficiency. If there is normal PTH plus decreased serum phosphorus, normal PTH plus decreased serum phosphorus, your answer is X-linked hypophosphatemic rickets. Our answer is X-linked hypophosphatemic rickets. That is what we see here in the X-linked hypophosphatemic rickets. Right? Next one, a topic which has suddenly become important for your people, congenital hypothyroidism. Congenital hypothyroidism, the most common cause is thyroid gland dysgenesis और agenesis, जिसका मतलब है thyroid gland is abnormal or not properly formed or it is ectopic thyroid gland. So most common cause is thyroid gland agenesis or dysgenesis, which includes ectopic thyroid gland, which includes aplasia, which includes hypoplasia. So most common is the thyroid gland dysgenesis, ectopic, aplasia or hypoplasia. Earliest clinical feature in neonatal period is the prolongation of jaundice. This is the earliest clinical feature. Just remember, organ of metabolism is liver, hormone of metabolism is thyroxine. If the thyroxine is less, unconjugated bilirubin is not converted to conjugated bilirubin. Right? Simple concept is there. Organ of metabolism is liver, hormone of metabolism is thyroxine. If there is thyroxine deficiency, the unconjugated bilirubin is not converted to conjugated, so there is prolongation of jaundice. There is the clinical features macroglossia, tongue size increases, and this is due to the myxedema of tongue. This is basically myxedema of the tongue. There is particularly umbilical hernia. There is abdominal distension, which is seen between 1 to 6 months of age. And the question what you should remember, every child should be screened for congenital hypothyroidism. What we say, every child should be screened for congenital hypothyroidism, and it is done between 2 to 5 days after birth by measuring T4 and TSH. It is done between 2 to 5 days after birth. Important thing. What do we measure for congenital hypothyroidism? It is T4 and TSH. And when do we measure? This is measured between the 2 to 5 days after birth. 2 to 5 days after birth is there. Right? You're feeling like some revision is going on or not? These all are very important topics for you people. You should definitely remember in the subject of pediatrics these all topics. Then we say here is the severity of dehydration. Severity of dehydration, right? So if you see in a child in dehydration, there can be minimal or no dehydration, which is less than 3% loss of body weight. This is mild to moderate dehydration, which is also called as some dehydration. Okay, Arshad. That is called as some dehydration, or the last is severe dehydration. In mild to moderate, there is 3 to 6% loss of body weight, and here we say less than 6% loss of the body weight. So there is minimal or no dehydration. It is mild to moderate dehydration, and this is something severe dehydration is there. Minimal or no dehydration, but you simply remember, child is alert, child drinks normally. Well, thirst is normal. If you look at the skin recoil, there is the instant skin recoil, and the urine output is normal or mildly decreased, but the better word we say is the normal only. So I cut it here. The urine output is normal. child is responding alert, child is not asking for extra fluid, child has got the skin recoil which is instant, and the urine output is normal. In some dehydration, restless or irritable, a child is constantly crying, asking for water, urine output is less, and the skin recoil is slow, less than 2 seconds. A child continuously crying, that means restless child hai or irritable child hai. Child is thirsty, wants to drink, there is recoil in less than 2 seconds, that is what we say is the slow recoil, and the urine output is decreased. Urine output is decreased. Severe dehydration. In severe dehydration, child is lethargic, unconscious, is not able to drink. Skin recoil is more than 2 seconds. More than 2 seconds, and urine output is minimal. Urine output is minimal. That becomes severe dehydration. According to IMNCI, which plan we are following for each? According to IMNCI, here we are following is the plan A. Here we are following is the plan B. And here we are following is the plan C. So according to the IMNCI, this is plan A, plan B, and plan C. What we are following is there, right? So this is what we are saying is minimal or no, mild up to moderate, which is also called some dehydration, and there is severe dehydration. Remember the plans which we are following. Plan A is for minimal or no dehydration. Plan B is for some dehydration, and plan C is for severe dehydration. Right? So dehydration part is an important one which you need to all learn it. Then we talk in the CNS part, clear, and the CNS part we have just taken the topic of febrile seizures, because if you see the question what was asked in the FMGE exam, which is the most common type of seizure. Sir, what is color? Color is basically of the plans, right? This plan A is so called as the green color, this is what we say is the yellow color, and this is what we say is the pink color. The plan basically is of the color is according to IMNCI. Green means everything is okay, you can manage at home. Yellow means in between situation. So you just like the traffic lights now, but we don't say red in severe, we say pink in severe. Done? Okay. CNS. In the CNS, we are talking is the topic of the febrile seizures basically. The febrile seizures are seen between 6 to 60 months of age. It is the most common type of seizure seen in children. It is not associated with CNS infection. In the same age group, there can be meningitis and encephalitis, but that is not febrile seizure. And then we say this is associated with rate of change of temperature. What we mean to say, if the temperature suddenly increases or the temperature suddenly decreases, both of them can cause the febrile seizures. Both of them can cause the febrile seizures. One we talk is simple febrile seizure. In simple febrile seizure, total duration is less than 15 minutes. There is no recurrence within 24 hours. It is always generalized, no neurological deficit. It is not neurologist. What we say here is there is no neurological deficit. What does it imply? After this seizure, child is normal. So what we are saying here, there is no neurological deficit, no investigation is required, no prophylaxis. If I just repeats, total duration in simple febrile seizure is less than 15 minutes. There are chances of no recurrence, and because recurrence is not there, prophylaxis is not required. No investigation is required, and it is usually generalized. If you consider complex febrile seizure, now simple was less than 15 minutes, this is more than 15 minutes. There is no recurrence in simple febrile seizure, and what we say here, recurrence within 24 hours is present. Recurrence within 24 hours is present. That was generalized, and this is mostly focal. This is mostly focal. There it is no neurological deficit, and here neurological deficit is present. There no investigation was required, but in a complex febrile seizure, you require EG and MRI. And in the complex febrile seizure, you give intermittent prophylaxis. What we give is basically intermittent prophylaxis, right? The difference between simple and complex febrile seizure. Then one more thing related to CNS you should remember. In meningitis in India, what is the empirical therapy? The empirical therapy we are giving is injection vancomycin plus third generation cephalosporin. Injection vancomycin plus third generation cephalosporin. So this is what we say is the empirical therapy in India we are giving for the meningitis. So in the CNS, what I expect is the questions can be asked on this. So you should both remember the simple and the complex febrile seizure. Then in the CVS part, if I consider, I just say a single topic of tetralogy of fellow. Last time you had a chest x-ray of TOF particularly. Here just I am saying a simple tetralogy of fellow. What are the components of the TOF is there? Now if I say the components, there is pulmonic stenosis. But what is supposed to be remembered? This pulmonic stenosis is subvalvular. It is not valvular, supravalvular. It is below the valve, subvalvular. There is right ventricular hypertrophy. There is VSD, there is overriding of aorta. So basically tetralogy means four things. So which four things are present here? Subvalvular pulmonic stenosis, there is RVH, there is VSD, and there is overriding of aorta. These four things makes the tetralogy of fellow. And if you consider overall, it is the most common cyanotic congenital heart disease. It is the most common congenital cyanotic heart disease. Now here if you say the question wise, which murmur is present? So if you particularly see here, we might say here two things are there. One thing, there is VSD, one is pulmonic stenosis, but the point to be remembered, VSD does not cause murmur and only murmur is pulmonic stenosis. And what is the murmur of pulmonic stenosis? Pulmonic ejection systolic murmur. So the point I want to say, you should remember what are the four components of TOF, that is true there, right? And then what we say particularly here, the stenosis is subvalvular, and in this, in spite of VSD, there is no murmur of VSD, there is a single murmur, pulmonic ejection systolic murmur. Pulmonic ejection systolic murmur. Then we talk in the CVS part, renal part here, we are talking is the nephrotic syndrome. Now, when we consider nephrotic syndrome, what you should remember, what is congenital nephrotic syndrome? Congenital nephrotic syndrome means which is presenting at birth or within first 3 months of life or within first 3 months of birth. Something which is manifesting at birth, that is congenital. It is due to two genes, NPHS1, NPHS2. NPHS1 codes for the protein nephrin, NPHS2 codes for the protein podosin. NPHS1 codes for the protein nephrin, NPHS2 codes for the protein podosin, and this nephrin is also called as the Finnish type of nephrotic syndrome. That is called as the Finnish type of nephrotic syndrome. Minimal change disease. This minimal change disease, very true, Prince, very true. Minimal change appears between 2 to 6 years of age. Remember the age group of minimal change, 2 to 6 years of age. There is no hypertension, no gross hematuria. No hypertension, no gross hematuria, Complement C3 level is normal. This is called minimal change because glomerulus appears normal. Glomerulus appears normal under light microscope. We say here glomerulus appears normal under light microscope. That's why this is called as minimal change disease. And minimal change disease is the most common cause of. It is the most common cause of steroid responsive nephrotic syndrome in children. Most common cause of steroid responsive nephrotic syndrome in children is minimal changes there. What are the clinical features here? The clinical features, if you say nephrotic, is nephrotic range proteinuria. Nephrotic range proteinuria, and what we get is usually UP to UC ratio more than 2. In the urine, the amount of protein is double the amount of creatinine. Now, when you see in adults, what you say, more than 3.5 grams in 24 hours. But the point is, how we will collect urine for 24 hours in a child? Practically impossible. So we go for the nephrotic range proteinuria, UP to UC ratio more than 2, which can be done in a single sample of urine. Now there is proteinuria. What happens to the albumin amount? The albumin amount can decrease. Albumin amount can decrease, and this is particularly due to the proteinuria. Albumin becomes less. If the albumin becomes less, what the body tries to synthesize? Body tries to synthesize proteins, but body synthesizes lipoproteins. So what is seen is hyperlipidemia, and this hyperlipidemia is due to the increased lipoprotein synthesis. Lipoprotein synthesis. Then there is lipiduria, and the edema is also present, but this edema is more severe in the morning. More severe in the morning. Now, what are the complications which can be seen in nephrotic syndrome in the child? There is increased susceptibility to infection. Because of the loss of protein, there is loss of complement proteins. And because of the loss of the complement proteins, what basically happens, there is chances of infection, and which is the most common infection seen, that is the pneumococci, which causes spontaneous bacterial peritonitis. It is the pneumococci causing the SBP. And second is hypercoagulability due to urine loss of antithrombotic factors such as antithrombin 3 and protein S. Two complications are there. Then in the renal, what is the important thing we should remember? Radiological investigation after first UTI. We are not saying after recurrent UTI. What was the previous theory? If a child is having recurrent UTI, that means there might be some underlying problem. Posterior urethral valves, micturating cystourethrogram. So you should go for the investigation. Now what we say, radiological investigation after first UTI, if it is age less than 1 year, 3 investigations are required. USG plus MCU plus DMSC. MCU basically will tell you regarding the vesico-ureteric reflux. That will tell you regarding the vesico-ureteric reflux. That is what we are doing here, right? And DMSA will tell you what is the renal parenchymal damage is there. If the age is 1 to 5 years, only 2 investigations to be done, ultrasonography plus DMSA. We are going for USG plus DMSA, and if any one abnormal, go for the third one, MCU. Then we are going for the micturating cystourethrogram. Age more than 5 years, we are only going for ultrasonography alone. And if there is problem in the ultrasonography, then DMSA and MCU, we are going for this, right? So this was the major part I have covered. Now basically in the part of the growth, what you should remember according to me, you should remember regarding the upper segment, lower segment ratio. Right? In the growth, what should be remembered? Upper segment, lower segment ratio. If you consider at birth, it is 1.7 is to 1. At 3 years, it is 1.3 is to 1. 5 years, 1.2 is to 1. 7 years, 1.1 is to 1. And 10 years, 1 is to 1. So simply what you should remember, both upper segment and lower segment, they become equal to one another at the age of. They become equal to one another at the age of 10 years. So if you basically see in a infant, upper segment is more than lower segment. A child of 3 years comes to you, it should be 1.3 is to 1. If in a child of 3 years you get 1.5 is to 1, what we say, this child is having infantile body proportion. This child is having what? Infantile body proportion. Right? So we say here, one body proportion is the infantile body proportion. Infantile body proportion means upper segment is more than lower segment. And another we say is the reverse infantile body proportion. Reverse infantile body proportion. And what we mean to say here is lower segment is more than upper segment. Infantile body proportion we get in 3 conditions. Do remember those 3 conditions. One is rickets, one is achondroplasia, and one is hypothyroidism. These are the 3 conditions where we get is the infantile body proportion. Reverse infantile body proportion we get in the Marfan syndrome, we get in the Klinefelter's syndrome, we get in the homocystinuria. This is something very important according to me to be remembered regarding the upper segment, lower segment ratio, infantile body proportion and reverse infantile body proportion. Then what you all should remember regarding the fontanelle, what is the sequence of closure of fontanelle? The first fontanelle to close is posterior up to 2 months. Up to 2 months. Second is sphenoid. Third is mastoid. And fourth is anterior. Sphenoid closes between 2 to 6 months, mastoid 6 to 18 months, and anterior between 18 to 24 months. So which is the last fontanelle to close, that is the anterior, and the first 3 you can easily remember by the word PSM. Posterior, that is PSM, you can remember posterior, sphenoid and mastoid. Very last, regarding the milestones, which milestones you should remember? Which milestones you should particularly remember for this FMG exam? If you consider 2 years, we say child can go upstairs and downstairs, and the point is 2 feet per step. 2 feet per step or 1 step at a time. Child is going up 1 feet, another feet, 1 feet, another feet. So this is 2 feet per step. At 3 years, we say upstairs 1 foot per step, but downstairs 2 feet per step. Child is going up, but the child is coming down, that is downstairs 2 feet per step. 4 years, downstairs 1 foot per step. Downstairs 1 foot per step. So if the examiner is only writing particularly upstairs, downstairs, your answer is 2 years. Apart from this, you should remember at 4 years, child hops. Child hops basically, yes, that's very true. The answer is 4 years. And at 5 years, child basically skips. So these are the topic which I chose for your FMG marathon. And according to me, these are the important topics to be remembered. If you feel like any more topic, I'm having 2-3 minutes. If you want, I should particularly discuss. I'm there to discuss with you, right? I'm your pediatrics faculty, Dr. Ashutosh Agarwal, already on our Telegram group. We had a quiz of 150 MCQs for your this FMG exam, which has been given 15 quizzes of 10 questions each. You can, whenever you want to attempt, you can attempt. If you've got time, do attempt those 150 questions. And if you feel, audio explanations are also there. So that will give you a boost for your preparation. YouTube channel, Peers Pointer Series, you can particularly just watch the small videos of important topic, and Instagram is always there. So feel like any more topic to be discussed, I'm there for you. You can ask me. तैयारी कर रहे हो, बस थोड़ी सी बात याद रखना, बहुत पत्थर खाए हैं तब मंजिलों तक आए हैं. All people struggle a lot there in the outside, preparing food, weather condition, बहुत कुछ है particularly. Clear? So what we say here particularly, the point we say here to be remembered, बहुत पत्थर खाए हैं तब मंजिलों तक आए हैं, चाहतों का बोझ था पर हौसला रोज था. You already, everybody want to become a doctor. So चाहतों का बोझ था पर हौसला रोज था, चक्रव्यूह कोई भी था, अभिमन्यु हम खुद भी थे. You all people basically find the solutions, everybody, every problem, right? So that is particularly there we say here कि चाहतों का बोझ था, हौसला रोज था, कोई भी चक्रव्यूह था, अभिमन्यु हम खुद ही थे. और मेरी बात याद रखना, मंजिल तू पा जाएगा अगर खुद से ही लड़ जाएगा. मंजिल तू पा जाएगा अगर खुद से ही लड़ जाएगा. दैट इज इंपॉर्टेंट हियर, राइट? तो अपने से लड़ना है, अपनी हिम्मत रखनी है, अभी से रोज प्रे करना है भगवान से, भगवान बिल्कुल मेरा साथ देना पेपर के टाइम पे. ये मत सोचना मैं उसी दिन प्रे करूंगा जिस दिन पेपर होगा, उस दिन सब लोग प्रे करेंगे, आपकी प्रेयर वेटिंग लिस्ट में जा सकती है. सो इफ यू वांट पर्टिकुलरली कि बेसिकली आपको मेहनत करनी है, आगे बढ़ते रहना है. Being as a faculty, I'm always there for you, right? Do get the time, do attempt the questions on the Telegram group. That's all what I can say right now, right? Thank you all for joining. Thank you so much. With this particularly, I take the all the very best to you. जो आपने सपना देखा है प्रीफिक्स का, वो आपको बहुत जल्दी मिले डीआर का सपना, and you live with pride is there. Thank you all my students. Stay blessed all.
Audible? IT team, if you can let me know if it is audible, you can let me know on WhatsApp or maybe on the comments of the YouTube. Audible? IT team, if you can let me know if it is Chali. So before anybody lets me know I'm audible, I can hear my voice by myself. चलिए जी, so this is Dr. Tushar Mehta, orthopedic surgeon, your faculty of orthopedics, and I know this is FMG marathon which is going on very quickly. I'll show you a few images. Honestly, will not write anything. We'll just want you to have a visual impression. Look at this photograph. Can you see a short webbed neck? Can you see low posterior hairline? Can you see decreased mobility at neck? Can anybody tell me what is this clinical condition? Yes, everybody. Prince_1357 is absolutely right. It is Klippel-Feil syndrome. So guys, in Klippel-Feil syndrome, you have a triad of short webbed neck, decreased mobility at neck, and low posterior hairline. Okay, Nyctophile is also right. Now look at this image. One of the most frequently asked images in your FMG licensing exam. Yes, fastest finger first. Yes, anybody? Klippel-Feil ho gaya. Klippel-Feil image we are done with. Anybody who can tell me about this image? Let's see who's the fastest finger first on the YouTube comment section. Okay. Okay, I think you people are taking time for this. This is spondylolisthesis. This is spondylolisthesis. Can you see the red arrow, the tip of red arrow? It is showing basically L5 vertebra over S1. So you can see L5 over S1. There is some posterior slippage. देखिए ध्यान से L5 and S1 में there is posterior slippage of S1. So this is spondylolisthesis, not spondylitis, not spondylolysis, not spondylosis. It is spondylolisthesis. Please mind you, everyone, please mind you, it is not spondylitis, not spondylolysis, not spondylosis. It is spondylolisthesis. Now look at this image. Anterior hip dislocation, posterior hip dislocation. So in the center, what you can see is the anterior hip dislocation. Look at the position of the hip. Look at the position of the hip. Flexion, abduction, external rotation. Look at the position of the head. Abduction, flexion, abduction, external rotation. Look at the center image. Flexion, abduction, external rotation. So this is anterior hip dislocation. Look at your image in the right, extreme right, your right. Flexion, adduction, internal rotation. That is posterior hip dislocation. So this image is very, very important for all of you. So anterior hip dislocation will have flexion, abduction, external rotation. Posterior hip dislocation will have flexion, adduction, internal rotation. All right. In anterior hip dislocation, you will have most common nerve injury, femoral nerve injury. आगे कौन सी nerve? Femoral nerve. In posterior hip dislocation, you will have sciatic nerve injury. Whether anterior hip dislocation, posterior hip dislocation, most common complication is same in both of them. Avascular necrosis of head of femur. Harsh 6301. Absolutely right. Absolutely right. Okay. So center you have anterior hip dislocation, right side you have posterior hip dislocation. Most common complication same, even of the head of the femur. Most common nerve injury different. Anterior में femoral nerve, posterior में sciatic nerve. Most common complication same in both of them. Now a very, very important question. Scaphoid cast versus Colles cast. So in scaphoid cast, you can see there is a glass holding cast. The shape is glass holding cast. Colles cast is basically handshake cast. Now I teach this multiple times in my lecture, in my FMG live classes, app classes, in DFX also. I teach this so many times that in your entrance exam, when you are under so much of pressure of clearing the exam, do you think at that point of time you will have the mindset that whether someone is holding the glass or shaking the hand? No. उस वक्त पे you will not have a mindset like this. So what you need to do at that point of time? Come on, what you need to do at that point of time? You need to see just the position of the hand. Okay? You just need to see the position of the hand. That's all what you need to do. So when you do that, you have to understand that the position of the hand, just look at the thumb. Just look at the thumb. If the thumb is free, all right, if the thumb is free, just take a look. If the thumb is free, Colles cast, handshake cast. If the thumb is covered, then scaphoid cast, glass holding cast. So in your licensing exam, you don't have that mindset to see कि किसमें क्या है ना? So just take care of this. So nectophile is right, and Setsing 2922 is right. So everybody is right. Good. Very happy. So this question comes very often. This question comes very often. So they are not asking you about the name of the caste. ठीक है ना? Although the shape, if you see the shape of the caste, it looks like it's a glass holding caste. It looks like it is a glass holding caste. But basically you have to see thumb is covered. And if the thumb is covered, then you have to go towards scaphoid fracture. This image is again very important. Just take a look. So basically, what do you see here? Come on, what do you see? Yes, anybody? What do you see? Sunray appearance, sunburst appearance. You can call it sunray appearance. You can call it sunburst appearance. So what do you see in sunray or sunburst appearance? You see periosteal reaction along Sharpie's fibers. You see periosteal reaction along Sharpie's fiber. All right. You see periosteal reaction along Sharpie's fiber. So this is sunray or sunburst appearance. Which topic are we talking about? Osteosarcoma. Very right. Setsing is exploding. No, everybody is exploding now. Very good. Very nice. Very nice. Now, what is this deformity? What is this deformity, boss? Cubitus valgus. One of the most frequently asked image-based questions for FMG licensing exam. If you have given any attempt till now, I'm 100% sure that you all will agree with me. I'm 100% sure that you all will agree with me. That whether they will ask you cubitus varus or they will ask you cubitus valgus, है ना? पूछेंगे ही पूछेंगे. Now, cubitus varus is like this. Which fracture? Supracondylar fracture humerus. Which deformity? Gunstock deformity. What is this? Cubitus valgus. Which fracture? Fracture lateral condyle humerus. Is that clear? Just keep this image into your head. So now these two fractures and their deformities. Oh my God, very amazing. So Colles fracture, mind you. The one that we have discussed just now is that if you have a supracondylar fracture humerus, most common complication malunion will give rise to cubitus varus gunstock deformity. Fracture lateral condyle humerus, most common complication non-union, it will give rise to cubitus valgus. Okay. Now two more deformities you should know in Colles and Smith fracture. So both fractures, when they will go into malunion, they will give rise to two deformities. Okay. Both the fractures, when they will go into malunion, they will give rise to two deformity. In Colles fracture, malunion will give rise to dinner fork deformity. Just take a look at the shape. देखो screen पे. Colles fracture, malunion, dinner fork deformity. Smith fracture, malunion, garden spade deformity. But mind you, I'm asking you a question. Let's see who answers first in the comment section. What is the most common complication of Colles fracture? Malunion, non-union? देखते हैं comments में, देखते हैं कौन जल्दी आंसर करता है. बताइए, most common complication of Colles fracture. Come on, tell me. Let's see in the questions. Most common complication of Colles fracture. Malunion, non-union? Most common complication of Colles fracture. Malunion, non-union? Let's see. Nidhi Prajapati, malunion. Ectophile, malunion. Hirsch 6301, nailed it. भाई तू तो stress मत ले. Finger stiffness. No, everybody is wrong. It's not malunion. It is not non-union. It is finger stiffness. So please remember this. Okay. So we are going to remember four deformities. Supracondylar fracture humerus, most common complication, malunion, cubitus varus, gunstock deformity. Fracture lateral condyle humerus, most common complication, non-union, cubitus valgus deformity. Smith fracture, most common complication, malunion, garden spade deformity. Colles fracture, most common complication, finger stiffness. Second most common complication, malunion, dinner fork deformity. Is that clear? चलिए, look at this image and tell me the surgical modality. Look at this image and tell me the surgical modality. What is this surgical modality? Look at this image and tell me what is the surgical modality. Tension band wiring. Again, if you have given any attempt previously, you will agree with me that this is a very, very frequently asked question. So it is tension band wiring. Okay. So this is tension band wiring. Where do we use tension band wiring? Give me two indications. Come on. अरे नहीं मेरे भाई, it is not K-wire. Abhishek Singh, no. Smriti Khare is right. Dr. Bilal Saab is right. Kunal Sharma ji सही कह रहे हैं. नहीं, कुणाल शर्मा जी गलत कह रहे हैं. It's not K-wire. It is TBW. होदा Dr. होदा ठीक कह रहे हैं. So it is TBW. It is tension band wiring. Of course, K-wire is a part of TBW, but this entire construct is called as tension band wiring. What are the two indications? बताइए बताइए, व्हाट आर द टू इंडिकेशंस? फ्रैक्चर ओलेकनॉन, फ्रैक्चर पटेला, भूलना नहीं, एक तो सामने ही है, पटेला तो सामने ही है, सो फ्रैक्चर ओलेकनॉन, फ्रैक्चर पटेला, क्लियर? Anybody, as I say always, anybody who's given a 10 previously will agree to this. Chalo, let's see. Fastest finger first. Nidhi said, Bilal, Dr. Huda, bataiye, what do you think is this image? Yes. What do you think is this image? Who is the fastest finger first? Let's take a look. So the way you have confusion between glass holding cast and handshake cast, similarly you can have a confusion between this and this, this and this and this. ये क्या प्रेशर बैंड क्या लिख रहे हो यार तुम लोग? डॉक्टर मोहम्मद निक्टोफाइल, क्या प्रेशर, कौन सा प्रेशर? अरे स्प्लिंट है, कौन सी स्प्लिंट है? वो तो मुझे भी पता है स्प्लिंट है। विच स्प्लिंट? स्मृति गलत। ये प्रेशर बैंड क्या लिख रहे हो यार तुम लोग? किसने पढ़ा दिया तुम्हें प्रेशर बैंड? नक्कल बेंडर, दिस इज नक्कल बेंडर स्प्लिंट, है ना? कुणाल शर्मा इज राइट। वैसे तो काफ़ी लोग लिखना चाह रहे होंगे, आई डोंट नो। कुणाल ठीक लिख रहा है। दिस इज नक्कल बेंडर स्प्लिंट। वेयर डू वी गिव दिस कुणाल? अल्नार पालसी, क्लॉ हैंड मेरे भाई। So knuckle bender splint is given in ulnar palsy, claw hand. What do you think is a splint that one can confuse with knuckle bender? ये आ गई ना? What is this? Come on, Kunal, Harsh, bolo. This is cock up splint. So knuckle bender is often confused with cock up splint. So this is knuckle bender. You are bending the knuckle. देखो ना knuckle bend हो गए. This is cock up. वो देखो कितना up है. So this is cock up splint. ये कहाँ देते हैं? ये कहाँ देते हैं? ये कहाँ देते हैं? अल्नर नर्व पाल्सी में देते हैं, क्लॉ हैंड में देते हैं। ये कहाँ देते हैं? रेडियल नर्व पाल्सी, रिस्ट ड्रॉप। वेयर डू वी गिव दिस? रिस्ट ड्रॉप। वो कॉकटेल अप, कॉकर। कोई बात नहीं, टाइपिंग एरर आई कैन इमेजिन, मेरे साथ भी होता। सो दिस इज अ डायनेमिक कॉकअप स्प्लिंट। वेयर डू वी गिव दिस? रेडियल नर्व पाल्सी, रिस्ट ड्रॉप। चलिए, ये तो कुछ और ही आ गया। Alright, so these are the few images which I wanted to revise with all of you very quickly. फिर से देख लेते हैं। So this is clipple field syndrome, triad है, short web neck, decreased mobility at neck, low posterior hairline, ठीक है? If one vertebra slips over another vertebra, it's not bloody spondylitis, spondylolysis or spondylosis, it is spondylolisthesis. The center image you have flexion, abduction, external rotation, which is anterior hip dislocation. The image onto your right is flexion, adduction, internal rotation, which is posterior hip dislocation. दोनों की most common complication is same, which is avascular necrosis of head of the femur. This is on one side you have scaphoid cast, which is glass holding cast, Colles cast, which is handshake cast. The only differentiating criteria is the position of the thumb, if it is free or if it is covered. ठीक है? Now this is an MCQ that comes often. Now this is sun ray appearance, sunburst appearance, which is pyroxal reaction along the Sharpie's fiber, classical of osteosarcoma. Always remember supracondylar fracture, humerus, most common complication, cubitus varus, gunstock deformity, lateral condyle fracture, cubitus valgus. Varus occurs due to malunion, valgus occurs due to non-union. Colles fracture, most common complication, finger stiffness, second most common, malunion, Dinnerfolk deformity. Smith fracture, most common complication, malunion, garden spade deformity. ठीक है अच्छे। टेंशन बैंड वायरिंग, TBW in front of you, fracture olecranon, fracture patella are the two indications. Basically you are supposed to require to identify the image. Knuckle bender splint, ulnar nerve palsy, claw hand, cock up splint, radial nerve palsy, wrist drop. Is that clear? Is that clear? So orthopedics is all about revision of these things. Plus orthopedics is about, so these are the important things which I mentioned here. These are my golden points, है ना? Let's say if there are 7-8 MCQs that are coming from orthopedics, believe me, 5 will be from either hip dislocation or sobable appearance or sun ray appearance or listhesis or clipple feel or compartment or Colles or patella or glass holding or handshake. यही सब आना है। Clear? Thank you Kunal bhai, thank you so much. Clear? These probabilities of orthopedics are clear to all of you. Just remember one thing. एक मुश्किल सवाल को सही करके आना उतनी बड़ी अचीवमेंट नहीं है जितना एक आसान सवाल को गलत करके आना बड़ी बेवकूफ़ी है। इंग्लिश आएगा नहीं तो इंग्लिश में नहीं बोल रहा है आदमी। It is not that big an achievement as getting a difficult question right as much as it is a stupidity to get an easy question wrong. So that is my only piece of advice to you. अगर आपसे गलती से by any chance if you do the Kohli's cast wrong or knuckle bender splint wrong or sun appearance wrong or listhesis wrong or hip dislocation wrong, boss you're doomed, है ना. FMG में प्रॉब्लम एक ही है. You try to find out some alien MCQs to solve them and you forget the basics one or you confuse with the basics one. So do not create any silly mistake. Have good patience in yourself. Have faith in yourself. You are prepared very well. Execution is more important than planning. मैं एक बात हमेशा बोलूँगा आपको, है ना. एग्जीक्यूशन इज मोर इंपॉर्टेंट देन प्लानिंग. प्लानिंग कुछ भी कर लो, एग्जीक्यूट नहीं करोगे तो क्या होगा. और एग्जीक्यूशन कैसे होगा? वट एवर डेज यू आर लेफ्ट विद, जस्ट डू अ प्रॉपर एग्जीक्यूशन. काम डाउन योर सेल्फ, गो स्लो, गो ग्रेजुअल. दैट्स ऑल वॉट यू नीड टू डू. ठीक है ना. कंसिस्टेंसी बीट्स इंटेलिजेंस एट एवरी सिंगल पॉइंट ऑफ टाइम. If anybody who's more intelligent than you right now may not be able to clear the cutoff, but if you're consistent till the end of your exam, you'll be able to clear the cutoff. ये बात हमेशा याद रखना. बहुत लोगों को लगता है यार he has done more, he has revised more, मेरा कैसे होगा, मैंने तो उतना किया नहीं. अरे कुछ नहीं है, 5 दिन भी बहुत होते हैं. पता है 5 दिन में 50 घंटे होते हैं, है ना. और कितने 100 मिनट होते हैं. तो ऐसे बेवकूफ़ी मत करो, है ना. बिल्कुल डोंट डू दैट. इन 50-60 आवर्स यू स्टिल कैन रिवाइज लॉट ऑफ थिंग्स एंड यू विल बी एबल टू क्लियर द कट ऑफ एंड यू विल अचीव व्हाट you want. I wish you guys all the best. Thank you so much. God bless all of you. Thank you. All the best for your exam. See you in the success party very soon, which will be organized.
Yes, sir. चलो. Good evening, everyone. Good evening. So I hope आप लोग सब मैराथन के लिए तैयार हो. So very all the best आप लोगों को. तो याद रखेंगे कि so I'm Dr. Srinath. I'll be taking 3 topics of yours, starting with respiratory system, renal, and rheumatology. चल. So let us get started. So मैराथन में हमेशा फ्रंट रनर कौन है, इसके ऊपर ध्यान दो कि मैराथन के फ्रंट रनर हमेशा रेस्पिरेटरी सिस्टम में होते हैं इन्वेस्टिगेशंस. सो वी वांट टू नो अबाउट द स्पायरोमेट्री, अबाउट एसिड बेस बैलेंस, अबाउट लंग वर्सेस रीनल केयर. वी वांट टू नो डायग्नोसिस इन नेफ्राइटिक सिंड्रोम, इंडिकेशंस फॉर डायलिसिस, एंड रूमेटोलॉजी पूरा का पूरा एंटीबॉडी बेस्ड है, फॉलोड बाय द पल्मोनरी रीनल सिंड्रोम. So focused है एग्जाम के लिए रिवीजन. We want to focus on the specific topic that are repeatedly asked. चलिए, so सबसे पहला स्टेप देखेंगे कि स्पायरोमेट्री अगर क्वेश्चन दिया हुआ है तो सबसे पहले शुरू करेंगे रेशियो से. अगर आपका रेशियो कम था, रेशियो नॉर्मल था, या रेशियो नॉर्मल से ज्यादा था, हमें इंटरप्रिटेशन लिखते जाना. अगर रेशियो आपका सबसे कम लेस देन 0.70 था तो डायरेक्टली आंसर मार्क करेंगे मोस्ट स्पेसिफिक फॉर ऑब्स्ट्रक्टिव एयरवे डिजीज. मोस्ट स्पेसिफिक फॉर द ऑब्स्ट्रक्टिव एयरवे डिजीज. बीच में लिख देते हैं नॉर्मल वैल्यू 0.70 to 0.80. इफ द रेशियो इज नॉर्मल तब हमने क्या करना चाहिए. और तीसरे तरफ लिखेंगे when the ratio is more than normal. Ratio is more than 0.80. It is specific for restrictive lung disease. So first step, I always tell, never miss out questions related to investigation. वो straightforward होते हैं. पेशेंट में आपने स्पायरोमेट्री रिपोर्ट देखा, सबसे पहले शुरू करो मोस्ट एक्यूरेट पैरामीटर रेशियो के साथ. रेशियो ने बताया ऑब्स्ट्रक्टिव है, रेशियो ने बताया नॉर्मल है, रेशियो ने बताया रिस्ट्रिक्टिव है. ये हमने टाइप्स को पहचाना. अगर ऑब्स्ट्रक्टिव डिजीज होगा तो चेक फॉर द ब्रोंको रिवर्सिबिलिटी, रिस्पॉन्स ऑफ द डिजीज टू द ब्रोंको डायलेटर थेरेपी, दैट इज सैल्ब्यूटामॉल. ब्रोंको रिवर्सिबिलिटी चेक करना. अगर ब्रोंको रिवर्सिबिलिटी इज गोइंग टू बी मोर देन bronchoreversibility is going to be more than 12%, or if it is going to be more than 200 ml from the baseline, answer directly mark हो जाएगा. This is diagnostic of the bronchial asthma. इसको हम डायग्नोस कर सकते हैं. अगर पेशेंट में रिवर्सिबिलिटी पार्शियल था, लेस देन 11% पार्शियल था, तो हम इसको COPD ऐसे डायग्नोसिस करेंगे. अमंग द COPD अगर आपको पहचानना है तो फर्दर यू कैन ऑल्सो लुक एट द DLCO से मैच करो, डिफ्यूजन कैपेसिटी ऑफ लंग टू कार्बन मोनोऑक्साइड. DLCO अगर एस्थमा में देखोगे तो DLCO एस्थमा में बढ़ जाता है. इंक्रीज इन द DLCO is going to be asthma. But in the patient of COPD, if the DLCO is normal or when the DLCO is reduced, तीन choices हैं. If the DLCO is normal in a patient of COPD, choose the answer chronic bronchitis. ये मार्क करना है. और अगर पेशेंट के COPD में हमारा DLCO कम हो गया है तो आंसर emphysema मार्क करना है. That is all. So in obstructive diseases, you are going to take into consideration two things. One is the bronchoreversibility. Second is the DLCO. That gives us complete answer. If the patient is going to have normal ratio, I want you to check the FVC value. FVC value is we want to check here. If the FVC value is going to be less, if it is going to be less, then we call it as early restrictive disease. Then we call it as the early restrictive disease. So obstructive restrictive pattern है वो late है. restrictive को पहचानने का दूसरा तरीका only FVC कम हुआ तो भी हम उसको अर्ली रेस्ट्रिक्टिव डिजीज बोलेंगे। रेस्ट्रिक्टिव डिजीज में DLCO को चेक करना, डिफ्यूजन कैपेसिटी ऑफ लंग टू कार्बन मोनोऑक्साइड। If the DLCO is going to be normal, then we can call it as the extrapulmonary, that is chest wall disorders. हम मार्क करेंगे the chest wall disorder में kyphoscoliosis हम इसको चूज कर सकते हैं। बट अगर DLCO कम है, then we are going to choose interstitial lung disease, that is pulmonary causes of the restrictive disorders. Okay. On the other side, if the patient has got FVC value also is normal, then we want to look at the DLCO. FVC value also normal. Look at the DLCO. If the DLCO is going to be worst affected, the worst reduction in the DLCO indicates pulmonary vascular disease. You will mark answer pulmonary hypertension. आपको mark कर देना है. And when the DLCO is normal, then you can say patient is having normal pulmonary function test. That's all. So we have discussed this in our class in the DFX. So this is very simple, but very, very important chart for us to remember. So स्पायरोमेट्री का क्वेश्चन आता है। स्पायरोमेट्री में सबसे इंपॉर्टेंट रेशियो देखना है, इसके बाद जरूरत के हिसाब से आगे चेक करोगे और फाइनल डायग्नोसिस को मार्क करोगे। इन द स्पायरोमेट्री अलोंग विद द लंग वॉल्यूम यू ऑल्सो वांट टू लुक एट द फ्लो वॉल्यूम लूप, जो बहुत इंपॉर्टेंट है, आपको बस पहचानना है। कलर कोड करते हैं। When the patient is having one obstructive pattern, scooped out appearance, miniature version, restrictive pattern, neuromuscular weakness like myasthenia gravis, circular pattern, and tracheal stenosis, we get a cylindrical or a box-shaped curve. Cylindrical or a box-shaped curve is going to tell you upper airway obstruction will be there. Images आपके सामने। When the patient is having scooped out appearance, answer obstructive disorder. When the patient is having miniature version, then you mark it as the restrictive disorders. When the patient is having box type curve, box shaped curve, then it is known as the tracheal stenosis, will be there, upper airway obstruction. And the presence of the circular pattern is indicating myasthenia gravis, neuromuscular weakness. Myasthenia gravis is going to be present. So directly look at the pattern and you can choose answer. So दो तरीके हैं। स्पायरोमेट्री में वॉल्यूम भी इंपॉर्टेंट है, फ्लो वॉल्यूम लूप भी इंपॉर्टेंट है, इसको मिस ना करें बिकॉज ये बार बार आता है। आगे दूसरा उतना ही कॉमन प्रॉब्लम है हमारा ABG डायग्नोसिस। आर्टीरियल ब्लड गैस के क्वेश्चंस भी हमको कॉमनली आते हैं, इसको कैसे हम टारगेट करेंगे? In the arterial blood gas, we have to follow the steps. Again, what are the steps? Step number 1, you want to look at the pH. Step number 1, based on the blood pH, हमको चेक करना है। अगर आपका blood pH है ना, सेंटर पॉइंट लिख के रखना, नॉर्मल इज 7.40, इसके आसपास देखो। When the pH is going to be going down, it is indicating acidosis. When the 7.40 से कम हो गया तो ये acidosis है, 7.40 से बढ़ गया तो ये alkalosis को फेवर करता है। प्राइमरी डिफेक्ट तो आप वैसे ही मार्क कर सकते हो। साथ में you want to compare, step number 2, you want to compare the direction of pH. Compare the pH direction with the direction of either the HCO3 or the direction of the PaCO2. नॉर्मल लिखिए, नॉर्मल बाय कार्ब है 22 to 26, मीन वैल्यू 24 मिली इक्विवेलेंट लेना है। PCO2 40 मिलीमीटर के साथ कंपेयर करके देखना है। तो हमें एक्रोनिम पता है ROMS, बट एक एक्स्ट्रा पॉइंट हमने सीखा है क्लास में, क्या करेंगे? कि when patient is having the pH acidosis हो रहा है, alkalosis हो रहा है। इसका एग्जांपल लेते हैं, pH acidosis हो रहा है मतलब pH is going down। pH के साथ साथ अगर bicarbonate is also going down, PCO2 also going down in the same direction, the primary defect is metabolic acidosis, ऐसे मार्क कर देना। बट pH हो रहा है नीचे और हमारा HCO3 और PCO2 बढ़ रहा है ऊपर, तो हम मार्क करेंगे प्राइमरी रेस्पिरेटरी डिजीज, ऐसे मार्क करना है। बट अगर हमारा pH और HCO3 ही अलग चल रहे, when HCO3 and the CO2 are in the different direction, HCO3 and CO2 खुद डिफरेंट डायरेक्शन में चल रहे हो, तो यहां पर मार्क करेंगे मिक्स्ड एसिड बेस बैलेंस डिफेक्ट, मार्क करेंगे मिक्स्ड एसिड बेस बैलेंस डिफेक्ट। सो बीमारी दोनों हो सकता है, रेस्पिरेटरी एसिडोसिस, रेस्पिरेटरी और रेस्पिरेटरी एसिडोसिस दोनों साथ में भी हो सकता है। मेटाबॉलिक एसिडोसिस, रेस्पिरेटरी एसिडोसिस साथ में हो सकता है, तो हम बोलेंगे मिक्स्ड एसिड बेस बैलेंस डिफेक्ट है। वेरी गुड। फिर स्टेप नंबर 3 को देखना, यू वांट टू लुक फॉर द कॉम्पनसेशन इफ इट इज प्रेजेंट। यू वांट टू लुक फॉर द कॉम्पनसेशन इफ इट इज प्रेजेंट। हर बार होगा ऐसा जरूरी नहीं है, आगे चेक करो इसको। अगर बीमारी मेटाबॉलिक है, रेस्पिरेटरी है, अगर बीमारी मेटाबॉलिक है तो कॉम्पनसेशन इज ऑलवेज प्रेजेंट बिकॉज इट अकर्स विद इन द मिनट्स, ऑलवेज प्रेजेंट। बट रेस्पिरेटरी में कॉम्पनसेशन अकर्स ओवर वीक्स एंड मंथ्स, over weeks and months the compensation is going to occur. That is why it takes time. In the respiratory disorder, based on the HCO3 value 22 to 26 milli equivalent को चेक करो। अगर हमारा HCO3 वैल्यू नॉर्मल रेंज में है, इसका मतलब देयर इज नो कॉम्पनसेशन प्रेजेंट, क्योंकि बीमारी अक्यूट डिफेक्ट है, because it is a acute respiratory defect, so compensation is not there. But if the patient bicarbonate value is abnormal, इसका मतलब compensation present है। compensation को लगते हैं हफ्ते और महीने, इसीलिए बीमारी हमेशा chronic defect होगा। बस इतना ही क्वेश्चन पूछते हैं। सो रेस्पिरेटरी होगा तो चेक करो अक्यूट रेस्पिरेटरी है कि क्रॉनिक रेस्पिरेटरी डिफेक्ट है। बट अगर मेटाबॉलिक है, ऑलवेज प्रेजेंट है, तो क्या करेंगे, यू वांट टू कैलकुलेट द एक्सपेक्टेड CO2, वांट टू कैलकुलेट द एक्सपेक्टेड CO2 एंड कंपेयर विद द ABG वैल्यू, कंपेयर विद द ABG वैल्यू, इसको चेक करके देखना है। एक्सपेक्टेड CO2 कितना है मेटाबॉलिक एसिडोसिस में और मेटाबॉलिक एल्कलोसिस में, उसका फॉर्मूला अलग अलग है। सो आज का दिन में समझना नहीं, सिर्फ फॉलो करना है। मेटाबॉलिक एसिडोसिस में विंटर्स फॉर्मूला 1.5 इंटू पेशेंट्स बाई कार्ब +8 ±2, एल्कलोसिस में 0.9 इंटू पेशेंट्स बाई कार्बोनेट +16, ये आपका फॉर्मूला लगाना है। फॉर्मूला लगाने के बाद आप कंपेयर करोगे कि हमारा जितना सोचा CO2 वो सेम है कि कुछ अलग है। if it is equal, if the expected is equal to the ABG value, इसका मतलब मेटाबॉलिक डिफेक्ट के साथ साथ जो रेस्पिरेटरी डिफेक्ट है, मेटाबॉलिक डिफेक्ट के साथ रेस्पिरेटरी जो डिफेक्ट है वो होने ही वाला है। थोड़ा तो रेस्पिरेटरी चेंज होने ही वाला है, क्योंकि द कंपनसेशन इज ऑलवेज प्रेजेंट। बट रेस्पिरेटरी डिफेक्ट सिर्फ कॉम्पनसेटरी होगा, ये कोई अलग बीमारी नहीं है। बट इफ एक्सपेक्टेड इज नॉट इक्वल टू द ABG वैल्यू, अलग है, इसका मतलब ये कोई एडिशनल डिफेक्ट है, रेस्पिरेटरी एडिशनल डिफेक्ट है, मेटाबॉलिक के साथ में there is a additional defect is present, right? So this is the one simple flow chart which will get you all the answer. So पिछले साल हमने नोट किया एबीजी बहुत आया, इस बार मुझे एक्सपेक्टेशन है कि स्पायरोमेट्री आएगा. सो स्पायरोमेट्री और एबीजी के लिए हम रेडी रहेंगे. इन दोनों को मिस नहीं करना है. ये 3 पेज पढ़ोगे, अब पक्का 3 क्वेश्चन तो आना ही आना है. एबीजी आ गया, स्पायरोमेट्री विथ फ्लो वॉल्यूम लूप. चलो आगे देखो. अभी आगे हमारा लंग कैंसर ऑर्फन टॉपिक है. ऑर्फन टॉपिक लंग कैंसर पूछते हैं. उसमें फर्स्ट क्वेश्चन, मोस्ट कॉमन कैंसर इन द वर्ल्ड, मोस्ट कॉमन कैंसर इन फीमेल नॉन स्मोकर, मोस्ट कॉमन कैंसर इन एस्बेस्टोसिस. तीनों अलग क्वेश्चन है, आंसर एक है, एडिनो कार्सिनोमा ऑफ द लंग. So whether it is lung cancer, whether it is female non-smoker, whether it is asbestosis, the most common cause is going to be adenocarcinoma of the lung is going to be present. In the adenocarcinoma, remember the common mutation EGFR mutation is present, and that is why it is unrelated to smoking. It is occurring in the non-smoker. बट क्वेश्चन को चेंज कर दो. द लंग कैंसर विच मिमिक्स ट्यूबरकुलोसिस, लंग कैंसर विथ रिस्क ऑफ हाइपरकैल्सीमिया, लंग कैंसर विथ पैनकोस्ट सिंड्रोम. आंसर मार्क करेंगे स्क्वामस सेल कार्सिनोमा. पैनकोस्ट सिंड्रोम में दिया होगा अपर लिम रेडिकुलोपैथी, टोसिस डिप्लोपी, देयर इज गोइंग टू बी हॉर्नर सिंड्रोम एंड होर्सनेस ऑफ वॉइस कैन बी प्रेजेंट. That is squamous cell carcinoma of the lung. But जब पूछेंगे strongest association with smoking, superior vena cava obstruction, neuroendocrine syndrome, but most chemosensitive tumor in entire oncology, answer small cell carcinoma of lung. बट इतना कीमो सेंसिटिव होने के बाद भी इसका प्रॉब्लम क्या, रिलैप्स विद इन 1 year ऑफ ट्रीटमेंट. इसीलिए प्रिवेंट करने के लिए देते हैं प्रोफाइलैक्टिक क्रेनियल रेडिएशन. बट फिर भी इसका प्रोग्नोसिस होता है सबसे वर्स्ट प्रोग्नोसिस, बिकॉज यहां पर रिकरेंस इज गोइंग टू अकर एंड सर्वाइवल विदाउट ट्रीटमेंट इज लेस देन 6 months. इसीलिए बोलेंगे वर्स्ट प्रोग्नोसिस इज प्रेजेंट. वेरी गुड. सो लंग कैंसर में हमको एडिनोकार्सिनोमा, स्क्वामस सेल कार्सिनोमा एंड स्मॉल सेल कार्सिनोमा. सो स्मोकिंग है, एसवीसी ऑब्स्ट्रक्शन है, एसआईएडीएच है और सेंसिटिव टू कीमो रेडियोथेरेपी. वाह, प्रिंस एकदम चमक गए. प्रिंस 1357 सारा एस ढूंढ के बैठ गया. वेरी गुड. चलो ग्रेट. सो आगे आते हैं इंटरस्टिशियल लंग डिजीज के तरफ. हमेशा बताता हूं एयरवे डिजीज का क्वेश्चन स्पायरोमेट्री में आता है, आईएलडी का क्वेश्चन बार बार थियरी में आता है. इंटरस्टिशियल लंग डिजीज एक नहीं ग्रुप है. कॉज को पहचानने के लिए यहां ध्यान से लिखना, गोल्ड स्टैंडर्ड टू कंफर्म आईएलडी इज द HRCT which shows ground glass opacity. The presence of the ground glass opacity on the HRCT is confirmatory of the interstitial lung disease. But interstitial lung disease एक नहीं group है. We want to identify the cause. To identify the causes of the ILD, the gold standard remains lung biopsy. Gold standard remains the lung biopsy, but biopsy is not always available. So what else we can do? We can do bronchoalveolar lavage finding. Also can give you the diagnosis in a patient with interstitial lung disease. लंग बायोप्सी आइडियल है, नहीं दिया तो ब्रोंको एल्वियोलर फाइंडिंग भी चल जाएगा. सो इंटरस्टिशियल लंग डिजीज में हमारे पास कॉजेस को ढूंढना है. हमारे पास कॉजेस हो सकते हैं ड्रग इंड्यूस्ड आईएलडी, कैन बी ड्रग इंड्यूस्ड आईएलडी. नहीं मिला ड्रग, इट कैन बी ऑक्यूपेशनल एक्सपोजर, related ILD, occupational exposure related ILD नहीं मिला तो autoimmune cause of the ILD can be present. चलो आगे लिखो. When the patient is having drug induced ILD, the diagnosis is based only on the history. इसका कोई टेस्ट नहीं होता. Diagnosis is based only on the history. Among the drug, the classical examples are the DMARDs, disease modifying anti-rheumatoid drug. methotrexate है, सल्फासेलिजीन है. पेशेंट को हमारा डी पेनिसिलामीन गोल्ड सॉल्ट है और दूसरा एमियोडरॉन एंटी अरिथमिक ड्रग. इसको याद रखना है. ठीक है. So these are our important causes of ILD, drug induced ILD. But अगर occupational exposure है तो इसको divide करो into organic dust exposure and the inorganic dust exposure. Organic dust exposure में हम इसको क्या नाम देते हो? इसको बोलते हैं hypersensitivity pneumonitis syndromes. हाइपरसेंसिटिविटी न्यूमोनाइटिस सिंड्रोम. इनऑर्गेनिक डस्ट में इंपॉर्टेंट टॉपिक सिलिकोसिस है. ऑटो इम्यून डिजीज में कॉज हमारा सार्कोइडोसिस है. सिलिकोसिस और सार्कोइडोसिस में कॉमन ढूंढो कि दोनों भी क्या करते हैं. बोथ ऑफ देम मिमिक्स ट्यूबरकुलोसिस. बोथ ऑफ देम आर गोइंग टू मिमिक द ट्यूबरकुलोसिस करके दिखते हैं. तो पहचानोगे कैसे? ब्रोंको एल्वियोलर लवाज shows lymphocytic predominant is present with the CD4 to CD8 ratio less than 1 is specific for the HP syndrome. In the silicosis, what X-ray finding is different? Eggshell calcification on the X-ray. Eggshell calcification on the X-ray. Presence of the snowstorm appearance on the X-ray is specific for the silicosis. Eggshell calcification, snowstorm appearance. Answer silicosis mark करना. In the sarcoidosis क्या डिफरेंस है? नॉन केजिएटिंग ग्रेन्युलोमा है. टीबी में केजिएटिंग ग्रेन्युलोमा, यहां पर नॉन केजिएटिंग ग्रेन्युलोमा इज प्रेजेंट. अदर देन नॉन केजिएटिंग ग्रेन्युलोमा ऑन द bronchoalveolar lavage, CD4 to CD8 ratio, when it is going to be more than 3.5, also is diagnostic of the sarcoidosis. So अगर HP सिंड्रोम में फोकस क्या करेंगे? CD4 to CD8 रेशियो कम होगा तो फिर HP सिंड्रोम. CD4 to CD8 रेशियो बढ़ गया तो आंसर मार्क करना है सार्कोइडोसिस. ये हमारा आंसर आ जाएगा. अगर हमें कुछ नहीं मिला, डायग्नोसिस ऑफ एक्सक्लूजन. Diagnosis of the exclusion, we can say patient is suffering from the idiopathic group of ILD. Idiopathic group of ILD is going to be present. This idiopathic group of ILD further divided into the 5 types. It is going to be divided into. आगे ले जाता हूं. ये कौन से 5 टाइप हैं, उनका एक एक मुझे फीचर चाहिए. The most common type is the usual interstitial pneumonia. कैसे पहचानेंगे? Bilateral honeycombing appearance. UIP, bilateral honeycombing appearance. On the HRCT, diagnosis is usual interstitial pneumonia. The second one, NSIP, non-specific interstitial pneumonia. Most common type associated with autoimmune disease. पेशेंट को SLE है, पेशेंट को स्क्लेरोडर्मा है, सिक्का सिंड्रोम है. आंसर NSIP सोचना चाहिए. आगे अगर थर्ड, पेशेंट को DIP, desquamative interstitial pneumonia, is the one that is exclusively occurs in the smoker. Desquamative interstitial pneumonia. Acute interstitial pneumonia can mimic the ARDS. Mimics the ARDS, acute interstitial pneumonia. And the COP, cryptogenic organizing pneumonia, comes with the intraluminar bud, Mason bodies on the HRCT, on the biopsy. Diagnosis will be complete. So we want to look at the keywords. Interstitial lung disease, फिर से बता रहा हूं, कंफर्म करने के लिए HRCT, बट कॉज के लिए आइडियली बायोप्सी. बायोप्सी नहीं होगा तो ब्रोंको एल्वियोलर लवाज फाइंडिंग आना ही चाहिए. कोई कॉज नहीं मिला, इडियोपैथिक के 5 टाइप पहचानने में आने चाहिए. आपका ILD पास हो जाओगे. आ गया प्लूरल एफ्यूजन. In the pleural effusion, very important is the Light's criteria. Light's criteria में क्या याद कर रहे हैं कि ट्रांसुडेटिव होगा तो सारा रेशियो कम होना चाहिए. ट्रांसुडेटिव होगा, रेशियो कम होना चाहिए, बट ग्रेडियंट बढ़ना चाहिए. सीरम एल्बुमिन माइनस प्लूरल फ्लूइड ग्रेडियंट बढ़ना चाहिए. एक्सुडेटिव में सारे रेशियो बढ़ने चाहिए, बट ग्रेडियंट कम होना चाहिए. That is diagnostic of exudative pleural effusion. Causes, most common cause is the acute heart failure. बाकी cirrhosis, nephrotic syndrome, hypoalbuminemia, hypothyroidism. Exudative का most common cause infective है, उसका most common cause TB है. हो सकता है रूमेटॉइड आर्थराइटिस हो, मैलिग्नेंसी, देयर कैन बी पैंक्रियाटाइटिस और इवन मीक्स सिंड्रोम. ये सब हमने रिवाइज किया. तो रेस्पिरेटरी खत्म, आधे घंटे में रेस्पिरेटरी. स्पायरोमेट्री ये हमारा पढ़ लिया. DLCO, फ्लो वॉल्यूम लूप, ABG, इंटरस्टिशियल लंग डिजीज, प्लूरल एफ्यूजन एंड लंग कैंसर. चलिए नेफ्रो के पास आते हैं. इन नेफ्रोलॉजी ये चार्ट को रट ही लो, ये चार्ट आना ही है हमें. सो व्हेन पेशेंट हैज कम विद acute kidney disease, how to differentiate between pre-renal and renal cause of AKI? Multiple parameters are present, but question number 1, which is the most sensitive parameter? It is FeNA. Fractional excretion of sodium is the most sensitive parameter. Urea create ratio when it is more than 20:1. Urine osmolarity when it becomes concentrated. Urinary sodium is less than 20. FeNA is less than 1%. You know you are dealing with a case of pre-renal AKI. But renal AKI में when the ratio is normal, but the urine is dilute in concentration, sodium is more than 40, FeNA is more than 2%. You know it is intrinsic AKI. Intrinsic AKI का most common cause acute tubular necrosis है, जहां पर FeNA more than 4% होगा. उसके आगे का कॉज acute interstitial nephritis है, जहां FeNA 2 to 4% होगा. एंड एक्सेप्शन टू द रूल हमारा ग्लोमेरुलोनेफ्राइटिस है, जहां पर FeNA का वैल्यू कैन बी लेस देन 1% also can be present. So FeNA is a very important test to identify the difference between pre-renal and renal. उसमें से रीनल का मोस्ट कॉमन कॉज होगा ट्यूबुलर नेक्रोसिस. डिरेंजमेंट ऑफ FeNA सबसे सीवियर है. इंटरस्टिशियल नेफ्राइटिस माइल्ड है, 2 to 4%. ग्लोमेरुलोनेफ्राइटिस में नॉर्मल हो सकता है. मोस्ट कॉमन कॉज प्रीरिनल AKI का हाइपोवॉल्यूमिक शॉक है. इसीलिए फर्स्ट लाइन ट्रीटमेंट पूछेंगे तो आंसर IV फ्लूइड देना चाहिए. IV फ्लूइड में कौन सा देना है? पॉइंट नॉर्मल सलाइन देना है. So we want to give normal saline is the fluid of choice for resuscitation in the patient with pre-renal AKI. ये चार्ट हमें आना चाहिए. Once we know कि diagnosis ये renal AKI है, ग्लोमेरुलोनेफ्राइटिस कॉमन नहीं था, बट हमारे लिए इंपॉर्टेंट है। नेफ्राइटिक सिंड्रोम कब बोलेंगे? जब क्वेश्चन में आपको क्या दिया? डिस्मॉर्फिक हिमैचूरिया। Patient is having dysmorphic hematuria is present. Hypertension is present. What is the type of proteinuria? Non-selective proteinuria is present. Then you know you are dealing with a case of nephritic syndrome. In the patient with nephritic syndrome, how to reach the diagnosis? Multiple parameters हमने पढ़ा, आज उसको एक साथ लेकर आते हैं. So nephritic syndrome is present and patient is having normal serum complement level. Nephritic syndrome is there. Patient is having normal serum complement level. In a patient of nephritic syndrome, then what will be the two choices? It can be either the IgA nephropathy, or it can be the case of the HSP, henoxylon purpura. To differentiate between the two, what are the differences you can see between the two, IgA nephropathy and HSP? IgA nephropathy is going to occur in the adult 20 to 30 year male dominant. Majority patient of HSP is going to present with only the kidney involvement, only renal involvement is present, and majority में antibody कौन सा आएगा? Anti IgA1 level is elevated in this person. In the HSP, it is occurring in the children before 10 years of age, males more than female. Predominantly, they present with the cutaneous rash. Skin rash is going to be present. Predominantly, only kidney, it never occur. And there is no antibody present. Both of them have normal complement level. You can make the best choice. But if the patient has got a nephritic syndrome with the low serum complement level, low serum complement either can be post-infective causes or can be autoimmune cause. Can be the post-infective causes or it can be the autoimmune causes of the disease. In between the two, how do you differentiate? Response to antibiotic therapy. आप check कर सकते हो. So when you check the post-infective, most common cause is post-streptococcal GM. It can be subacute bacterial endocarditis. It can be chronic hepatitis B, hepatitis C infection also. In the autoimmune cause, most common is the SLE. Can be Wood-Pasture syndrome, can be vasculitis syndrome also can be present. ये हमारा आंसर सर आ गया. When patient is having nephritic syndrome, using the complement level, हमने कैसे पढ़ा? हिमैचूरिया क्या पढ़ा? बट सेम ही आंसर है. नेफ्राइटिक सिंड्रोम है, नॉर्मल कॉम्प्लीमेंट होगा IgA वर्सेस HSP. लो कॉम्प्लीमेंट होगा तो पोस्ट इन्फेक्टिव वर्सेस ऑटो इम्यून कॉज ऑफ द डिजीज. ये हमको चूज करना है. कॉमनली पूछते हैं, एक नहीं मल्टीपल क्वेश्चंस आंसर करेक्ट हो सकते हैं. ठीक है. व्हाट अबाउट द डायलिसिस इंडिकेशन? डायलिसिस इंडिकेशन हमने याद किया, AEIOU. When the patient is having acidosis, when the patient is having electrolyte imbalance, when the patient is having electrolyte defect. acidosis में dreaded acidosis कब बोलेंगे? When the pH is less than 7.20. electrolyte में सबसे खराब कौन सा? potassium more than 6.5. When the patient has ingested a dialysable toxin. When the patient is having fluid overload state, when patient is gone into pulmonary edema, or when the patient is having serious uremic manifestation. patient is having serious uremic feature or when the patient ka urea level is more than 100. Urea level more than 100 can be used for indication of dialysis. तो याद रखना vowel AEIOU. Patient has acidosis, electrolyte effect, ingested dialysable toxin, fluid overload state, and the serious uremic feature is present. Diagnosis can start on dialysis. Bringing us to rheumatology. लास्ट स्प्रिंट कर रहे हैं रूमेटोलॉजी में. फिर से बता रहा हूं, सबसे इंपॉर्टेंट बस डीएफएक्स के बुक के एंटीबॉडी को रिवाइज करना. एंटीबॉडी एसएलई में कौन सा होता है? मोस्ट सेंसिटिव एएनए, बट इट इज नॉट स्पेसिफिक. बट अभी क्या है? एएनए का होना एसेंशियल क्राइटेरिया है. एएनए के बिना एसएलई हो ही नहीं सकता. एएनए का होना कंपलसरी क्राइटेरिया है. एंटी स्मिथ हमारा मोस्ट स्पेसिफिक है बट रेयर है. Present in 10 to 20% cases only it is going to be present. The most preferred is the anti-dsDNA is considered most preferred for the diagnosis of SLE because not only is it both sensitive and specific for diagnosis, it is also prognostic in SLE. Indicates both, predicts the risk of renal and CNS involvement. Anti-phospholipid antibody जिसका दूसरा नाम MCQ में क्या आ सकता है? Lupus anticoagulant. मिस नहीं करना. Lupus anticoagulant predicts the risk of thrombosis and recurrent first trimester abortion can be present. In the other autoimmune disease, डायरेक्ट आंसर मार्क करना है. एंटी सेंट्रोमियर एंटीबॉडी, क्रेस्ट सिंड्रोम. टोपोआइसोमरेस 1 SCL70 सिस्टमिक स्क्लेरोसिस. एंटीरो एंटीला है स्पेसिफिक इन द पेशेंट विथ सिक्का सिंड्रोम. In SLE, it is prognostic only antibody to cross the placenta. Antijo antibody sensitive in myositis, specific in dermatomyositis, and it is also prognostic in myositis syndrome. Prognostic क्या बताता है? Increased risk of interstitial lung disease, lung involvement बताता है. Antijo in myositis group can tell me prognosis. Increased risk of interstitial lung disease can be present. That is our other antibody. In the arthritis group of disease, RA factor, most sensitive prognostic. Anti-CCP, most specific prognostic. Prognosis में क्या बताते हैं? Not only increased risk of bone erosion, deformity, but also predict increased risk of organ involvement. Hence, they are considered both diagnosis and prognosis in the patient with RA, while ANCA is going to be most sensitive for the vasculitis syndrome. But vasculitis syndrome can mimic the Goodpasture's syndrome. Can mimic the Goodpasture's syndrome. क्यों बोलते हैं? Because last topic of our marathon, क्या याद रखेंगे? Because it can look like a pulmonary renal syndrome. Vasculitis syndrome can mimic Goodpasture syndrome because they can present as a case of pulmonary renal syndrome करके present करते हैं. When do you mark pulmonary renal syndrome as the answer? When patient has both lung involvement and kidney involvement in the form of glomerulonephritis. When only 2 organs are affected, answer हमेशा Goodpasture mark करना. जब any other organ is affected, typically skin rash होगा, तो vasculitis syndrome मार्क करना. Vasculitis syndrome में ANCA पॉजिटिव है, उसमें C ANCA पॉजिटिव है, तो आंसर वेजनर्स मार्क करना. P ANCA पॉजिटिव है, एंटी माइलोपेरोक्सीडेस, इयोसिनोफिलिया होगा, चर्क्सटॉस मार्क करना. नहीं होगा, माइक्रोस्कोपिक पॉलीएंजाइटिस मार्क करना. एंड आन का नेगेटिव पूछेंगे तो हेनॉक्सलॉन परप्यूरा एनाफाइलैक्टॉइड परप्यूरा मार्क करना। सो सिंपल है, हमारा तीनों सिस्टम में बहुत ही हाई यील्ड है मेडिसिन का। रेस्पिरेटरी मेडिसिन, एसिड बेस बैलेंस, नेफ्रोलॉजी, रूमेटोलॉजी, 8 क्वेश्चन तो आ ही जाएंगे, तो इसको नहीं छोड़ना। आराम से इतना पढ़ लो, काफी हो जाएगा, क्योंकि बाकी रूटीन में हमने पढ़ा है, बट यही हमारे मैराथन के फ्रंट रनर होंगे। चल ठीक है, चलो। सो ऑल दी वेरी बेस्ट, अगले सेशन के लिए तैयार हो जाइए। अगले सेशन में आ रहे हैं हमारे अचिन मेहरा सर, आपको सिखाने न्यूरोलॉजी, एंडोक्राइनोलॉजी। ठीक है, चलिए तो स्विच करेंगे, मैं लॉग आउट करूंगा। ऑल दी वेरी बेस्ट, मेहनत करते रहना। अभी आपने पढ़ लिया, खुद के ऊपर कॉन्फिडेंस को मेंटेन करना, एग्जाम अच्छा ही होगा। ठीक है, चलो, ऑल दी वेरी बेस्ट यू।
Right. Am I audible and visible to all of you? Okay. Right. Am I audible and visible to all of you? Chalo, let's start. Welcome to the session. Right. Just a second. Chalo, let's start and let's start the marathon now. For neurology and endocrinology, I've just picked out few important topics on the go, which I feel important for the exam, and we have already covered them in the revision sessions like regular batches and even the DFX sessions. Chalo, let's start. We'll begin with the seizure diagnostic matrix first of all, one of the first chapter that we cover. One type of seizure that we know is a focal seizure. And if you remember, in a patient of focal seizure, we have either a preserved or an impaired awareness most of the time. And that's a point to classify the seizure. Generally, on the basis of consciousness or cognition, you can easily classify a typical seizure that is focal or not. And in the patient of, we have focal seizure of palsy, which is post-ictal paralysis, TODS palsy, as the name suggests, right? And the drug of choice for managing a patient of focal seizure anytime will be lamotrigine, one of the safest drugs that we consider over here. Then we have with us the absence seizure, wherein my patient is going to have a sudden loss of consciousness, staring look, and they generally recover with an automatism, right? 3 Hz spike and wave, yes, that would be seen on the EEG in the patient. And the drug of choice in the patient of absence seizure anytime will be ethosuximide. Okay. Juvenile myoclonic epilepsy generally has an adolescent onset, myoclonic jerks with or without a GDCS an episode. And lifelong treatment is required for them, if you remember. And yes, for them, the drug of choice is anytime valproate. Valproate, the broad spectrum. One on the other side, GDCS that we see, we have got tonic, clonic phase and a confusion. And in the clonic phase, we have the frothing. And in the tonic phase, you might also have a tongue bite. And the drug of choice for managing a patient of GDCS anytime is valproate. Temporal lobe epilepsy, they come with focus seizure with impaired awareness. On the MRI, you have what the hippocampal sclerosis or atrophy. And most of the patients do not respond to treatment. And for managing a patient of temporal lobe epilepsy, what do you do? Temporal lobectomy. Correct? And don't forget the topic that will anytime improve your status in the exam, the status epilepticus. Wherein in my patient, the seizure is there for a duration of more than 5 minutes, recurrent, without recovery sometimes. Sometimes the patient may be just unconscious there for a longer time. Don't forget the protocol for managing status, very important for you. The first line drug for managing a patient of status is an IV lorazepam, followed by the anti-epileptic drugs like phenytoin or levetiracetam. Correct? Okay. And then going on to the maybe the tremor classification and type of movement disorder that we see. In case I have a lesion in the caudate nucleus, my patient is going to have chorea, which is classical for a Huntington disease. And what is chorea? It's a typical dance-like movement that the person does. Globus pallidus lesion, if you remember, is going to cause athetosis, a slow breathing movement like this. While a subthalamic nucleus lesion is going to cause balismus in the patient, which is typically a flinging movement. Right. And don't forget the tremor. Intentional tremor happen in patients of cerebellar lesions. Resting tremor that we have seen is seen in patients of Parkinson. And an essential tremor, for that the drug of choice is what? Beta blocker every time. So diagnose this tremor for me. This is a pen over here. I'm taking my hand towards the pen, and on reaching the target, suddenly the hand starts shaking. And sometimes it goes beyond the target also. What is that kind of a tremor? I'm touching the finger of the examiner and touching my nose. I'll take my finger like this, and on reaching the target, the hand starts shaking. Let me know what kind of tremor is it. It's easy, it's simple. Let me know your answer, please. The tremor which happens on approaching the target generally is maybe an intentional tremor that you see. Intentional tremor. Okay. And in case you have a patient with intentional tremor for you in the hospital, then it's a lesion that is possibly cerebellar lesion. Correct. Very good. But don't forget essential tremor. The drug of choice is always a beta blocker. Okay. And don't forget the classical triad of Parkinson disease. What is a classical triad? You've got resting tremor in the patient. Rigidity is there in the patient, along with what? Bradykinesia. Along with what? Bradykinesia. Right. Just a second. Right. So in a patient with a classical Parkinson disease that we see, we have got resting tremor in the patient with rigidity and a bradykinesia over there. The non-motor symptom that we generally find in the patient is going to be depression, anosmia, and a memory loss, also known as a dementia. Okay. Pharmacotherapy, if you remember faintly, for a patient of Parkinson disease, the mainstay treatment of the drug of choice is always levodopa and carbidopa. In case they have extreme dyskinesia or a problem, then they will be requiring amantadine as a drug which improves the central dopamine level. Okay. Apomorphine on the other side is a drug which is a rescue therapy. That means a patient of Parkinson is stuck with severe deep akinesia. In that case, you can give them an injection of apomorphine, which will bring in an instant improvement in the patient. Right. Now the atypical variant that we see. Progressive supranuclear palsy, yes, is going to have early postural instability, vertical gaze palsy, especially the downward gaze is very poor. So we have done this in the class. The person stands, walks with an extended posture, doesn't look down, and has a poor response to levodopa therapy, is a patient of progressive supranuclear palsy or the PSP. While a patient with dementia of Lewy body or the DLB, if you see, they will have dementia, Parkinson with what? Visual hallucinations, right? Okay. Multiple system atrophy. Don't forget, this is the patient of Parkinson, and the hallmark feature in the patient is orthostatic hypotension, which happens due to what? Autonomic failure that you see in the patient, right? Okay. So it's a nutshell. explanation about Parkinson is one of the most important topic, and the question that we generally find are based on this. What is the drug of choice? What is the rescue therapy? And don't forget these atypical variants that you find in the patient. Okay. Then going on to the cortical function, that's very easy and simple again. In case you have a frontal lobe problem, if you know the frontal lobe, it's important to maintain my motor control, behavior, and prefrontal area for executive function and behavior as well, and Broca's area for what? Speech production, speech production, speech production. That is, word formation will happen over here, and it's important for the speech production there. And don't forget the parietal cortex, it's for sensoromotor integration, correct? And the dominant or the left parietal lobe, if you have a problem there, what are we going to have? Yes, our Gerstmann syndrome, dyslexia, dysgraphia seen in the patient, and the non-dominant lesion, don't forget, are going to neglect everything onto the left side. This is known as a hemi-neglect phenomena. Temporal lobe is simple, it's for auditory processing, memory through the hippocampus, and Wernicke's, of course, for comprehension. Occipital lobe on the other side is important for interpretation and receiving a proper input of vision. And what is prosopagnosia? Don't forget this topic. It is known as face blindness. You see someone's face and you are really blind for that face. Whose face is this? You don't remember that. Prosopagnosia. Okay. A quick recap on the stroke syndromes. Yes, AC infarct if you have. Your patient is going to have leg weakness more than the arm with urinary incontinence and behavioral changes. Okay. The MC infarct on the other side, in the patient is going to have contralateral face and arm weakness. And don't forget, in the patient, if there is a dominant side left-sided lesion, the patient is going to have what? Aphasia. PC infarct, the patient is going to have this. We have done this in the class. In the patient, there is going to be a visual loss like this, half vision. And what we see in the patient is macular sparing. And what is this alexia? We have done this also. This is known as pure word blindness. Pure word blindness. So whatever word written in front of the patient, he simply cannot read it. His pure word blindness is a symptom of a PC infarct. Let me give you a quick recap on this again. In case you have an AC infarct, the leg is weak with a behavioral problem and urinary incontinence. In case it's an MC infarct, you have more of weakness and aphasia. In case it is a PC infarct, you're going to have cortical blindness with macular sparing and pure word blindness known as alexia. Okay. Right. Now we have a diagnostic matrix for aphasia also with us, and it's very simple. In case you have an aphasia type that's Wernicke's, the fluency of the speech is intact, but although the person doesn't understand what he is speaking, so he'll tell out some meaningless words, which is known as neologism. They will obviously have a poor comprehension anytime, and repetition is obviously impaired because they don't understand what to repeat. Broca's, yes, it's a non-fluent aphasia, one thing. Their comprehension is preserved and their repetition is impaired. Why is the repetition impaired in them? Because if I ask them to repeat something, they cannot form the word that needs to be repeated in them. While conduction is the one whose comprehension and fluency is intact, only the repetition is gone. Because once you listen to a word, you understand it in Wernicke's, you make the same word in Broca's, both are connected through the arcuate fibers and the conduction block occurs over there. And last but not the least, don't forget anomic. Everything is preserved. Can you tell me what is lost in anomic aphasia? It's a very simple question. What is lost in a patient of anomic aphasia? One variable which I did not mention in the table, but is lost in an anomic aphasia patient. Name it. So that's an easy diagnostic matrix to revise your chapter of aphasia. Now let's look at the paralytic phenotypes that we have seen in the classroom teaching. In a Yeoman paralysis, you have spasticity, hyperreflexia, extensor plantar. In element paralysis, on the other side, you have flaccidity, muscle wasting, hyporeflexia, and fasciculation. Correct. Intracerebral bleed, it's simple, localizer is required. One bleed is putamen, which is commonly returned to, is related to what? Severe hypertension. And the most common site of the intracerebral bleed that we generally find is putamen. Another site is thalamus, which comes with a profound sensory loss. And pons, don't forget, if you have a pontine bleed, what are you going to have? Pinpoint pupil. Pupils are so small in size, they actually look like a tip of a pin. Pinpoint pupils. Okay. And don't forget this topic, subarachnoid hemorrhage, subdural and extradural. Must know topic. In SCH first, they have a berienism rupture as a cause. They come with a thunderclap headache. And one complication they commonly come with is vasospasm. Okay. Just to add into your notes, maybe there's one drug which can inhibit vasospasm very well in a patient of SCH is nimodipine. Then I look into this SDH, which is due to rupture of the bridging veins, and it has a crescent shaped CT scan. Now, what do you mean by this? It looks like a half moon shape or a crescent shaped CT scan, or the bleed convexity is one side convex, other side is concave. EDH on the other side, if you can see in this picture, it's a lenticular or a biconvex opacity. Yes, and it occurs due to rupture of which artery? The middle meningeal artery tear, MMA. And they have a waxing waning period in them known as what? The lucid interval. Okay. So it's a must know topic. I believe this is something very easy to crack in the exam. Nothing fancy here, no hi-fi knowledge required. A history could be a simple tool to understand it, like a patient met with a head injury. After head injury, the patient has got some kind of a neurological deficit, and the deficit simply keeps on increasing with time and slowly, gradually over 1 or 2 months. Okay, this is what is a patient of SDH, slow progressive deficit. While a patient met with a head injury and maybe the next day the patient collapses, or the same day the patient collapses, maybe an intervening period of a normal sensorium with a lucid interval phenomena, it's a patient of EDH. Okay. Then we have dementia, memory loss, and it's very simple. We have Alzheimer with us, where you have an early memory loss in the patient with an anomic aphasia, just to add. Apraxia occurs later, and pathologically what you have is a myeloid plaque and a tau tangles over there. Okay. Just the younger brother of Alzheimer, don't forget, is FTD, who comes with an early behavioral problem. Memory as such is relatively spared in them, and they have a tau protein. This came for you in the FMGE. I remember this question. It was discussed in psychiatry also. Yeah, we have got a syndrome that is Capgras syndrome. Can someone of you tell me? What is a Capgras syndrome? What is Capgras syndrome? The patient feels his doctor has been body doubled, or is in the patient, like, they find that they have been body doubled. Who has been body doubled in this Capgras syndrome? It's a very interesting story. So in a Capgras syndrome, they feel the guardian, the doctor, their nurse, caregiver, whosoever has been body doubled by their own enemy. Delusion of doubles, yes, known as a Capgras syndrome. Okay. Then we have this Hakim trap, not Hakim but Hakim's trap, where the patient comes with dementia, gait disturbance, and urinary incontinence. It's a patient of NPS. Please remember this. Yeah. Maybe everyone feels nowadays the doctor is their enemy. So if their enemy has done some bridge course and overnight they become a doctor, and legally they can be killed with some medication, right? CJD is a patient of rapid onset dementia, myoclonus, and in the brain degeneration is seen, and the whole brain looks like a spongiform degeneration. Huntington also is another small topic but important for you in the exam. It comes with a CAG repeat sequence defect, chorea, dementia, and an autosomal dominant pattern of inheritance seen in the patient. Wernicke's encephalopathy is the favorite topic of the exam. It occurs due to thiamine deficiency, vitamin B1, and your patient has got what? Global confusion, ophthalmoplegia, and ataxia. And what is that triad known as? Yes, The capital of Punjab, Goa. Okay. Arre, capital of Punjab is Chandigarh. No. That's capital of Haryana also. Lot of fight between Punjabis and Haryanis. Okay. Why is Goa capital of Punjab? It's an old joke. Because English is a spoken language in Goa before 8 p.m. but in Punjab after 8 p.m. Cheers. Okay. Headache. Migraine. Migraine is a pulsatile unilateral headache with nausea and photophobia, and the drug of choice in the patient is what? Triptans. Tension headache is stress related, but it's often associated with a lot of depression and treated with what? Tricyclic antidepressant TCA. Cluster headache. Okay. स्माइल सर, अच्छा हाँ है स्माइल, मुस्कुराइए, आप दिल्ली में हैं. Cluster headache. Cluster headache is a periorbital headache with lacrimation, and in the patient you have oxygen and sumatriptan as the ideal treatment, right? Okay. Pseudotumor cerebri, you have got headache, papilledema, normal imaging, and no focal deficit. Okay. So please remember this, that if a female patient comes in a history, if the patient comes with a history of headache, papilledema, projectile vomiting, normal CT, and no focal deficit, young obese female, it's a case of a pseudotumor cerebri. Okay, simple topic. Now, don't forget the CSF diagnostic matrix. It's very easy and an important topic for you. Pyogenic meningitis, if you remember, the CSF shows increase in cell count, which is generally neutrophilic, high protein, low glucose, and treat them with antibiotic and a steroid Dexa. Okay. On the other side, if you look at tubercular, they have got basal exudates, and on the CSF, what you see in the patient is a cobweb appearance. CSF shows a lot of lymphocytes, high protein, ATT, and steroids. Viral HSV, you got fever, seizure, and altered sensorium. Yes. Treat the patient with acyclovir. Neurocystic sarcosis, don't forget dimag mein keeda. Seizure is most common presentation in the patient. Yes. Vesicular stage is a live stage that goes into the dead stage, calcified. And how do you treat NCC? You treat it with albendazole and a steroid therapy. Okay. So in the exam, what you need to look at the question is that in the exam, if you have a history of basal exudates, it is TBM. If it is a very low CSF glucose, it is pyogenic. In the history, if they give you altered sensorium, fever, and seizure, think about viral. If they give you a history of a ring enhancing lesion coming with seizure, think about NCC. Okay. Yeah, intentionally I removed the triangle because they were becoming too much for my life also. Too many triangles are bad. Thoda the normal theory should be there. Okay, triangles and all, that method of teaching makes the thing simple. 3 point someone, like, Okay, Brown-Sequard syndrome. Hemisection in the spinal cord that you see is going to have an ipsilateral motor and proprioception loss and a contralateral spinothalamic loss. Let me repeat. Below the level of lesion, posterior column is lost onto the same side. Below the level of lesion, UMN symptoms onto the same side. Below the level of lesion, spinothalamic loss onto the opposite side. Correct? Brown-Sequard syndrome. Hira Thakur hai, mat bhulna. Zehar-wari kheer, very important. Syringomyelia is a disease wherein you have a central cavity and the spinothalamic tract is specifically involved in the patient, causing a dissociated kind of a sensory loss in a cave-like distribution. Okay. Conus medullaris on the other side, the patient comes with the early bladder involvement, saddle anesthesia, and a mixed UMN and LMN signs. Cauda equina has an asymmetrical radiculopathy element with a late bladder involvement. Okay. And just to add, conus wala patient is going to have one more thing, saddle anesthesia. Saddle anesthesia. They generally come with a saddle anesthesia, right? In which they have the anesthesia on the perineal region round like this, in a shape of a saddle. As you sit on a horse for a longer time and do a horse ride, the perineal part that touches the horse back or the saddle gets anesthetized. Okay. Will it be enough for the exam? It's more than enough for the exam. Don't worry, be happy. We are here not to read at the moment, we are just here to revise everything at the moment. Myasthenia gravis, don't forget, fatigable weakness, acetylcholine receptor antibody is seen, and treatment of choice for myasthenia anytime is what? Pyridostigmine. Lamberton-Eaton syndrome improves with use. A weakness that improves with use, that means a weakness that recovers on exertion, is a Lamberton-Eaton syndrome. Okay. And it's often associated with the lung cancer, the small cell carcinoma of the lung. And the antibodies are not acetylcholine, they are calcium channel antibody, which block the calcium channel that is important to reduce acetylcholine from the nerve. Okay. So if I ask you a question like which of the two is associated with thymoma? That's why we do thymectomy in myasthenia, no? Because we have a higher incidence of thymic abnormalities. So thymoma is something seen in patients of myasthenia gravis, while small cell carcinoma of the lung is commonly seen in patients of Lamberton-Eaton syndrome. Okay. And the favorite topic, Guillain-Barré. It's a post-infectious ascending paralysis, and treatment for this is IVIG and plasmapheresis. Multiple sclerosis, it comes with a relapsing remitting course, and don't forget the MRI finding, typical periventricular demyelinating region known as a Dawson finger. And if a relapse of MS happens, what do you give to the patient? Steroids. Neuromyelitis optica is a patient with optic neuritis. Yes. Transverse myelitis, that's why the word myelitis comes here. And an AQP4 acupurin 4 channel antibody seen in patients of NM. So patients of myasthenia, if you ask me, the symptoms are worse in the evening time. They're worse in the evening time, right? So we're done with neurology and quick recap of endocrine. Nothing great here, not too much, but basic facts again. If a patient of prolactinoma, if you want to find in the question, look out for these two symptoms, galactorrhea and amenorrhea. And treatment for prolactinoma patient is what? Cabergoline. Okay. More in the evening, worsen in the evening is myasthenia. Not like worsening on morning or evening in LEMS. No. It's not like this. It's like more of a weakness that improves on exertion is Lamberton-Eaton syndrome. A worsen of weakness on exertion is a patient of myasthenia gravis, right? Acromegaly comes with an enlarged jaw and they got a high IGF-1 level. And don't forget, for acromegaly, surgery is the first line of treatment. And what surgery have we done for acromegaly? We remove the pituitary from the sphenoidal sinus, doing a surgery known as a transsphenoidal resection, TSR. Diabetes insipidus, polyuria and polydipsia are the chief complaints. Nephrogenic DI, what do you give? Thiazide. Central DI, what do you give? Desmopressin. Okay. SIDH, on the other end, concentrated urine comes out with less sodium in the blood. And what is the treatment of choice for managing SIDH patient? Fluid restriction. But the drug of choice for managing SIDH patient is always a Veptan. Okay. Adrenal problems are quick and fast. Cushing's syndrome is a glucocorticoid excess in which we find in our patients central obesity and stry. Screening test is a dexamethasone test and treatment is for the etiology specific. Okay. Looking at the hyperaldosteronism, they come with diastolic hypertension, hypokalemic alkalosis. High aldosterone-renin ratio is clearly diagnostic for it. And if I see hyperaldosteronism excess and I call it as कौन syndrome, बताओ कौन है ये लोग, कहाँ से आते हैं ये लोग? You should know these people कौन. They are patients of what? Adrenal adenoma. So patients with adenoadenoma are referred as Conn syndrome. Right. Well, if I ask you a question like a patient of Cushing disease, not Cushing syndrome, who is he? He's a patient with what? Pituitary adenoma. These are all commonly asked questions. Right. And primary adrenal insufficiency comes with hypotension, hypoglycemia. So any question that you find with a catastrophic kind of a situation, like patient BP is not recordable, sugar is very low, think about adrenal insufficiency. Maybe primary, as I can suggest, also known by the name as Addison disease. Key signs is hyperpigmentation. Why? Because if the cortisol goes up, the ACTH moves up. ACTH moves up with the MSH, causing hyperpigmentation on the friction side, pressure sides, and sun exposed side in the body. Right. Treatment of choice for adrenal insufficiency anytime is what? Steroids. Diabetes mellitus definition is very important. In a patient with type 1 diabetes, you have what? Absolute insulin lack. It's not there at all. Type 2, you have got what? Insulin resistance. That's very important to understand. And both have got feature of polyuria and polydipsia. Right? Acute crisis, don't forget, is decay. Decay has got hyperglycemia, acidosis, and ketonuria. And for managing a patient of decay, you follow this flip regimen: fluid, insulin, and the potassium. Hyperosmolar state comes with hyperglycemia, high serum osmolarity, and obviously no what? Ketone bodies. No ketosis is seen in the patient. Okay. Hypoglycemia, don't forget the Whipple's triad. What is Whipple's triad? You have patients of neuroglycopenic symptoms, hypoglycemic symptoms. Requires a rapid glucose correction. The moment you give glucose, the patient gets better. And the third thing, if you remember, we have got documented hypoglycemia in the patient. That's a Whipple's triad. Okay. For the thyroid state, it's simple: hypothyroidism. Weight gain, cold intolerance, high TSH, low T4. And for treating a patient of hypothyroidism, what do you give to them? Levothyroxine. Hyperthyroidism, weight loss, tremor, low TSH, high T3, T4. And what do you treat with them? Antithyroid drugs. Hypercalcemia, you have got in the patient parathyroid hormone excess, which is generally malignancy related also. If I ask you parathyroid excess, most common cause, if you see, maybe the word primary in the parathyroid gland. What is it? It's a very commonly asked question for you. Parathyroid excess due to the problem in the parathyroid gland, the most common cause is what? Parathyroid adenoma. A tumor in the parathyroid gland over there. Okay. Classical presentation, don't forget, is stone, bones, and growths. Three things. More calcium, more stones, nephrocalcinosis, pain in the bone, and abdominal pain and colic is there. That is known as the growths. Okay. Acute treatment, don't forget, yes. For a treatment for hypercalcemia, if I ask you, the first choice is IV fluid. Bisphosphonates also. And one diuretic has to be given. Can you tell me which diuretic is given for treating patient of hypercalcemia? I'll give you a hint. This diuretic will take out the excess of calcium out in the urine. It seems to have a calciuric effect. Which diuretic is calciuric? Is it thiazide or furosemide? Loop diuretic, furosemide? Yes, good. So we have the loop diuretic with us, furosemide, which is considered for treating a patient of hypercalcemia. ठीक है. So it's simple, it's easy. provided you have your concepts clear. These marathons are not magic treatment. You have studied, you have revised. It's just for a kind of a recap of everything. And maybe in these slides, I've tried to include what was asked in the exam, what could be asked in the exam, and few important points. Okay, like they say as keywords or prompts nowadays. Yeah, because I made a patient in my OPD, I was giving him advice about fatty liver, don't eat this, don't eat that. He was recording my conversation and he puts it on ChatGPT and asks ChatGPT, is it correct? ChatGPT says, yes, it's correct, but please consult a doctor first. So every topic that you come across always has got some prompt, some kind of a, right. Chalo, all the best. See you soon in the felicitation programs. Okay, so that you crack the exam and with a marathon. Okay, FMG. Thank you.
Hi, good evening, guys. Comment पढ़े. Wish you all a very good evening. Chalo, I'm set. The momentum is already great to see your comments, guys. Chalo, without wasting any time, the momentum is already there. I hope पहले तो आप सब सही हो. Before I start a session, you guys are fine. You guys are in a good mental space more than anything else that what matters to me right now. A good physical space and in a good mental space, right? बाकी सब हो जाएगा. रिजल्ट तो सब हो चुका है. इतनी मेहनत जो आपने की है वो जाया नहीं जाएगी. इम्पोर्टेंट टू मी इज कि आप लोग ठीक हो फिजिकली भी. जैसा आजकल स्टूडेंट्स का हाल चल रहा है, जब लेनी होती है ऊपर वाला लाइब्रेरी में बैठे बैठे अपने घर में सोए ले लेता है ना. तो आई होप यू आर फिजिकली फाइन सबसे पहले, देन मेंटली, राइट? बाकी सब हो जाएगा. चलो, विद अ गुड स्पेस, विद अ गुड एनर्जी, लेट्स स्टार्ट अ सेशन. इमेजेस देखेंगे. आई हैव ट्राइड टू कंपाइल एवरीथिंग इन फॉर्म ऑफ इमेजेस ओनली, साथ ही इमेजेस देके सारे क्वेश्चन रिवाइज कर सके. कीप योर एनर्जी ऑन, कीप ऑल द प्रेप यू हैव डन. इधर निकाल दो सब, यहाँ पे सारी फ्रस्ट्रेशन निकाल दो, सारा स्ट्रेस निकाल दो. यहाँ बोल के जो बोलना है, कोई कमेंट आपका ब्लॉक नहीं होगा. अच्छी बुरी जो भी बातें आ रही है सब निकाल दो, राइट? चलो, विदाउट वेस्टिंग एनी टाइम, लेट्स स्टार्ट अ सेशन, गाइस. चलो, इमेज देख के फटाफट बताते चलो मुझे, और जो मैं पूछूं वो भी बताना है. जो मैं पूछूं स्मॉल है, डार्कली स्टेन्ड आरबीसी है. वेरी स्मॉल डार्कली स्टेन्ड आरबीसी, दिस आर स्फीरोसाइट्स. स्फीरोसाइट्स का मोस्ट कॉमन कॉज, पहले तो कौन सा टेस्ट कराओगे? स्मॉल डार्कली स्टेन्ड आरबीसी है, कूम्स टेस्ट कराओगे. कूम्स टेस्ट इज पॉजिटिव. अब AIHA पे टिक करके आ जाओगे. ऑटोइम्यून हेमोलिटिक एनीमिया, कूम टेस्ट इज नेगेटिव, गो विद हेरिडिटरी स्फीरोसाइटोसिस. आइडेंटिफाई द सेल, and most common cause of spherocytosis is AIHA, right? Then now look at this image, come on. What are these cells called as? Yes, bite cells. कहाँ मिलते हैं bite cells? G6PD deficiency anemia में. G6PD deficiency anemia में कौन सी स्पेशल बॉडीज? हाइंस बॉडीज. सब कुछ लिखा होता तो तुम दिमाग नहीं लगाओगे. आता है तो सुनते चलो, नहीं तो लिखते चलो। हाइंस बॉडीज, डन। नेक्स्ट पे आते हैं। लुक एट दिस क्रिसेंट शेप आरबीसीज, फटाफट बता दो मेरे को, सबको बताए। दीस आर सिकल सेल एनीमिया। 6 पोजीशन, ग्लूटामिक एसिड गई, वेलिना गई। फटाफट बता दो सिम्टम्स क्या क्या आते हैं सिकल सेल एनीमिया के। सारे इशीमिया वाले, सारे इशीमिया वाले। वी नो प्रायपिज्म, प्रायपिज्म, डेक्टेलाइटिस, हैंड एंड फुट सिंड्रोम, हैंड एंड फुट सिंड्रोम, प्रायपिज्म, पेनफुल इरेक्शन हो जाता है। ऑस्टियोमाइलिटिस का मोस्ट कॉमन कॉज, अदरवाइज स्टाफ ऑरियस, पर इन सिकल सेल में कॉमन बता दो मोस्ट कॉमन कॉज ऑफ ऑस्टियोआर्थराइटिस, ऑस्टियोमाइलिटिस, साल्मोनेला। चलो लेट्स लुक एट अदर क्वेश्चंस। सॉरी, चलो टारगेट ड्रॉप, टीयर ड्रॉप, आरबीसीज, फटाफट। टारगेट है, टीयर है, मुझे पता है तुम अपने टारगेट की तरफ पहुंचोगे, बेशक रोते रोते पहुंचोगे पर पहुंचोगे। दिस इज फॉर यू गाइस। कितना भी अभी रोना आ रहा हो, कितने भी टीयर्स निकल रहे हो, बट ट्रस्ट मी दिस इज ऑल जस्टिफाइड, बिकॉज आई एम श्योर soon, very soon you're gonna almost there, reach at your target. Target and tear drop, thalassemia. Thalassemia की treatment of choice, bone marrow transplant, right? You give blood transfusion, but then bone marrow transplant. कौन सा फेस है? चिपमंक फेस. Seen in again, thalassemia. Keep your energy high. जो यहां आ रहा है वही एग्जाम में आएगा, कुछ और नहीं आएगा. जो मैं कह रहा हूं ध्यान से सुनना, मैं ये नहीं कह रहा ये क्वेश्चन एग्जाम में आएगा, मैं ये कह रहा हूं यहां याद आ रहा है तो वहां भी आएगा, यहां याद नहीं आया तो भी वहां आएगा, क्योंकि यहां ऑप्शंस नहीं है, यहां पे टाइम नहीं है. यहां आ रहा है तो वहां 100% आएगा आएगा, यहां नहीं आ रहा तो भी वहां 100% आएगा. इस तरफ ये देखने के लिए कि आ रहा है कि नहीं आ रहा. नथिंग इज गोना चेंज. चलो फटाफट एग्जाम निकलना है, इसको कोई नहीं रोकेगा. हेयर ऑन एंड अपीयरेंस सीन इन थैलेसीमिया. Hair on end appearance, mainly thalassemia, but can only be also be seen in sickle cell anemia. चलते रहेंगे. ये तो somebody has to impress me. What do you see here? RBC में हीम एग्लूटिनेशन हो चुका है. If anybody could impress me, come on. हीम एग्लूटिनेशन हुआ है. RBC की एग्लूटिनेशन हुआ है. चलो हिंट दे देता हूं. पेशेंट कोल्ड डिग्री सेल्सियस पे गया था, कहीं कोल्ड डिग्री सेल्सियस पे गया था, हीम एग्लूटिनेशन हो गया. Come on. Which antibodies? Which antibodies are called antibodies? IgM. Come on, which are warm antibodies? IgG. So heme agglutination है, सारे RBC agglutinate. Think about the cold antibodies. We all know cold antibodies are IgM antibodies. बता दो सर, बता दो क्या हो गया इस नाखून को? सर ये तो स्पून शेप्ड नेल्स हैं सर. स्पून शेप्ड नेल्स आर सीन इन कोइलोनिकिया. बताना आपको पड़ेगा टाइप करके. कोइलोनिकिया सीन इन आयरन डेफिशिएंसी एनीमिया. हाथ रुकने नहीं चाहिए, दिमाग थकना नहीं चाहिए. दैट्स हाउ विल स्पेंड आवर नेक्स्ट लाइक से 45 to 50 मिनट्स. हाथ थकने नहीं चाहिए, ध्यान दे चलने जो. दिस विल ओनली बूस्ट योर कॉन्फिडेंस. चलो इससे बाहर कुछ नहीं आना होता सर. क्या दिख रहा है? नक्कल हाइपर पिगमेंटेशन. कौन सा एनीमिया? नक्कल हाइपर पिगमेंटेशन. इट इज मेगैलोब्लास्टिक एनीमिया. B12 डेफिशिएंसी, नक्कल हाइपर. 2 years बैक FMG. पहचान लोगे. नेक्स्ट इमेज सब आता है आपको. चलो सर ये कौन से न्यूट्रोफिल दिख रहे हैं सर? सर ये तो अरे पहचानो ना कितने लोग हैं सर. मैं क्यों बता रहा हूं, आप ही कैलकुलेट कर लो सर. 1 2 3 4 5 6 7. कौन सा न्यूट्रोफिल है जिसमें 6 से ज्यादा लोब हो गए? दिस आर हाइपर सेगमेंटेड न्यूट्रोफिल्स. कहां मिलेंगे? अगेन मेगैलोब्लास्टिक एनीमिया. इट्स अ फीचर ऑफ मेगैलोब्लास्टिक एनीमिया. हाथ नहीं थकने चाहिए. चलो फटाफट नेक्स्ट पे आते हैं. अरे बता दो कौन सा RS सेल है? सर ये तो आउलर अपीयरेंस जैसा नहीं दिख रहा सर. सो द पेशेंट इट हैज गॉट पिंक न्यूक्लियोलाई बॉस, पिंक न्यूक्लियोलाई. सो कम ऑन, पिंक वाला तो है, इट हैज टू बी रीड-स्टर्नबर्ग सेल्स. क्लासिक हॉजकिन लिम्फोमा. ब्लू वाला होता तो साइटोमेगेलोवायरस. यू विल हैव टू इंप्रेस मी एवरीबॉडी. जहां जब मैं पूछूंगा बताना पड़ेगा. दिस विल ओनली टेल मी दैट बॉस ये मेरे चाहे फाड़ के आने वाले हैं. CD मार्कर्स of Hodgkin lymphoma, CD15, CD30, 1530 पॉजिटिव. ये क्लासिकल वाला Hodgkin लिम्फोमा है. फटाफट अगर वही Hodgkin लिम्फोमा विद व्हाइट साइटोप्लाज्म, लैक्यूनार सेल्स. नेक्युलर स्केल्स, नोडुलर स्क्लेरोसिंग, नोडुलर स्क्लेरोसिंग वेरिएंट ऑफ हॉजकिन लिम्फोमा। मैंने कहा था लैक्यूना मतलब व्हाइट साइटोप्लाज्म, और स्क्लेरोसिस में स्क्लेरा आ गया, स्क्लेरा का कलर व्हाइट, तो व्हाइट वाले आर लैक्यूनार सेल, नोडुलर स्क्लेरोसिंग वेरिएंट। चलिए नेक्स्ट पे देखते हैं। अरे बता दो साहब, दिल खुश हो जाएगा, जितने इसमें और रोड्स हैं उतनी खुशी मिल जाएगी मेरे को। सर ये तो फैगेट सेल्स नहीं है क्या सर? सर फैगेट सेल तो सर मल्टीपल और रोड्स वाले सेल्स होते हैं सर, एंड मल्टीपल और रोड्स वाले सेल तो सर एएमएल में मिलते हैं सर। सर कौन से एमएल बता दो, ये दिल तुम्हारा फटाफट, एएमएल M3 15 17 ट्रांसलोकेशन, पीएमएल रारा ट्रीटेड बाय एक्ट्रा ऑल ट्रांसरेटिनोइक एसिड। क्या सब कुछ याद आया? सब कुछ याद आ गया तो तुम फाड़ के आने वाले हो, ट्रस्ट मी ऑन दिस। फिर पहचान लो, पेशेंट में इम्यूनोग्लोबुलिन्स का लेवल हाई है, और ये इमेज दे रखी है, सुमेर सर वुड कवर्ड जस्ट इन केस मेरी पैथो से आ गया है, पंच आउट लीशन। ये गलत किया तो जितने पंच इसके स्कल में उतने तुम्हारे स्कल में पड़ेंगे, और मुझसे ही पढ़ेंगे, एग्जाम के बाद पढ़ेंगे। पंच डाउन लीजन्स, मल्टीपल माइलोमा, मल्टीपल माइलोमा। चलने दो चलने दो, सब कुछ कवर करना है। ये नहीं आता तो कुछ नहीं आता। तुम्हारी रीढ़ की हड्डी ना रीढ़ की हड्डी ना कोई रीढ़ की हड्डी का नाम तक नहीं लेगा, कहीं भी मुक्का मारो रीढ़ की हड्डी पे नहीं मारने का, रीढ़ की हड्डी का नाम भी नहीं लेने का। वर्टिब्रा पे क्वेश्चन आएगा ही नहीं, आएगा तो छोड़ देना, 1 मार्क्स मेरे लिए। ऑस्टियोलिटिक ऑस्टियोप्लास्टिक बात ही नहीं करना वर्टिब्रा के बारे में। मोट सेल, मल्टीपल माइलोमा, मल्टीपल माइलोमा। देन नेक्स्ट पे आते हैं सर, एम स्पाइक दे रखी है सर। सर मेरे को एग्जाम में इमेज दे रखी है, एक ओल्ड एज पेशेंट है और एम स्पाइक है, ये दिखेगा आपको, बट अब ट्राई दिस, वो वाली इमेज डाल दो जो एक एग्जाम में होगी या उसके बारे में कुछ ना कुछ होगा। एम स्पाइक है तो मल्टीपल माइलोमा, इट्स मोनोक्लोनल एम प्रोटीन। मल्टीपल माइलोमा के पेशेंट में यूरिन प्रोटीन कौन सी होती है? बेंस जोन्स प्रोटीन। चलने दो सर। एक बूढ़ा आदमी है, इट इज आफ्टर 60 ईयर्स, ल्यूकीमिया के साथ आया है, बूढ़ा आदमी है, और ये टूटे फूटे, दिस फ्रेगमेंटेड लिम्फोसाइट्स आर सीन। अरे बता दो, ये तुम्हारा, कम ऑन बता दो, दिस हैज टू बी स्मज सेल्स। कहां दिखते हैं स्मज सेल्स? कहां पे? CLL में। स्मज सेल्स आर सीन इन CLL। डन डन डन। सर कौन सा टेस्ट है जिसमें 922 की ट्रांसलोकेशन दिख रही है सर? सर ये तो 922 ट्रांसलोकेटेड दिख रहा है सर। सर ये तो फिश है ना सर। सर फिश को तो हम ट्रांसलोकेशन के लिए यूज करते हैं ना सर। तो फिश तो CML में BCR ABL जीन, इसको तो फिलाडेल्फिया क्रोमोसोम कहते हैं सर। CML पे क्वेश्चन आया तो एक स्पेशल सेल और मिलेंगे, बता दो क्या मिलेगा? जिसने बता दिया लास्ट ईयर FMG, कम ऑन। सर ये तो क्रम्पल्ड टिश्यू पेपर साइटोप्लाज्म जैसा नहीं लग रहा? सर ये तो मेरे को आता है। क्रम्पल्ड टिश्यू पेपर साइटोप्लाज्म इज अ फीचर ऑफ गॉशर सेल्स और स्यूडो गॉशर सेल। हिस्ट्री देख के पढ़ लेना। गॉशर सेल्स, फिश कॉलेज गर्ल अपीयरेंस, अच्छा फिश कॉलेज गर्ल, चलो क्रम्पल्ड टिश्यू पेपर गॉशर डिसीज एंड स्यूडो गॉशर सेल्स आल्सो नोन एज सी ब्लू हिस्टियोसाइट्स। तुम लोग शानदार जा रहे हो। चलो ये भी बता दो सर, पेशेंट है DIC का या TTP का, और ये सेल्स दे रखे हैं, जिसने ये बता दिया ये तुम्हारा एब्सोल्युटली बीटा सेरिब्रोसाइडेज डेफिशिएंसी। कम ऑन, दीस आर हेलमेट सेल्स आल्सो नोन एज हिस्टियोसाइट्स। कहां मिलते हैं? महा की कंडीशन में, माइक्रो एंजियोपैथिक हिमोलिटिक एनीमिया, उसमें TTP आ गया, DIC आ गया, HUS आ गया, या प्रोस्टेटिक वाल्व्स आ गई। सबने पहचान लिया क्या? सही जा रहे हो। चलो ये तो प्यारा सा नन्ना सा बच्चा सिर्फ तुम्हें दुआएं देने आएगा, अफ्रीकन चाइल्ड विद मैंडिबुलर मास। हमने इसके बारे में गलत किया तो हमें पाप लगेगा। बर्केट्स लिम्फोमा, किसकी एक्टिविटी बड़ी होगी? सीमिक की एक्टिविटी बड़ी होगी। कॉस्टिव एजेंट एप्स्टीन बार वायरस। मजा तो तब है ना जैसे जैसे मैं लिख रहा हूं उसी स्पीड से तुम्हारे दिमाग में जा भी रहा है, मजा तब है। और मैं फिर बता रहा हूं, यहां याद आ रहा है तो वहां तो आएगा ही आएगा, और यहां याद नहीं आ रहा है तो फिर भी वहां तो आएगा ही आएगा, क्योंकि यहां तो मैं टाइम ही नहीं दे रहा हूं सोचने के लिए, वहां तो भरपूर टाइम होगा। विल हैव एन एम्पल टाइम, सो इन केस यू कैन रिकॉल एवरीथिंग, ब्रिलियंट। इन केस यू आर नॉट एबल टू रिकॉल इट, स्टिल ब्रिलियंट। सो मेक श्योर या तो देखते याद आ जाए या बोलने के बाद याद आ जाए। हाँ, अगर हाँ निकल रहा है तो सच में हाँ ही होगी एग्जाम में। स्टारीज का अपीयरेंस, बर्केट्स लिम्फोमा, डन। नेक्स्ट इमेज पे आ जाते हैं। सर ये नहीं बताया ना, इसी रैकेट से तुम्हारे ग्लूटियस मैक्सिमस सारी आईटीज करवा दूंगा वहां पे फटाफट। टेनिस रैकेट अपीयरेंस, बर्बेक ग्रेन्यूल्स, कहां पे LCH में। CD मार्कस बता दो, सबसे पहले वाला सबसे बाद वाला, CD1A CD207। ये भी याद आ गया तो ये जितने भी मेरे पास है वो सब तुम्हारे। परफेक्ट परफेक्ट परफेक्ट। चलो, जब इलेक्ट्रो माइक्रोस्कोपी की इमेज आई है तो थोड़ी सी जनरल पैथ की इमेजेस भी देख लेते हैं। सर ये तो वर्ल नहीं दिख रहे, ब्राउन ब्लैक वर्ल्स ऑफ इलेक्ट्रो माइक्रोस्कोपी, क्या है ये? माइलिन फिगर्स किससे बनी होती हैं? फॉस्फोलिपिड्स एंड कैल्शियम से। किसमें मिलती हैं? सर रिवर्सिबल में भी मिलते हैं, इरिवर्सिबल में ज्यादा, मोर इन नंबर दिख रही हैं इस सीन इन इरिवर्सिबल इंजरी। मैं सोचने का टाइम नहीं दे रहा हूं क्योंकि सोच के तुम और कॉन्फिडेंट हो जाओगे यार। मैं धीरे धीरे बोलूंगा, फिर तुम्हारे सारे क्वेश्चन बन जाएंगे। वाओ आई एम सो प्रिपेयर्ड, यू माइट गेट ओवर कॉन्फिडेंट। नहीं दे रहा टाइम, मेरे को पता है तुम्हारा निकलना है, क्यों तुम्हें जबरदस्ती सर पे चढ़ाऊं? मैं नहीं चढ़ा रहा। टाइम विल नॉट गिव मच टाइम। देखते सॉल्व करो। कौन सी नेक्रोसिस? कौन सी नेक्रोसिस? वाइट है, वेज शेप है, पाप लगेगा पाप। इट हैज टू बी कोएगुलेटिव नेक्रोसिस। कोएगुलेटिव नेक्रोसिस पहचान लिया ना? ऑर्गन बता दो। हार्ट, हार्ट में होती है। एनी ऑर्गन एक्सेप्ट ब्रेन, राइट? डन है। चलो फिर नेक्स्ट पे आ जाओ। सर सेल आउटलाइन दिख रही है सर। सर आई कैन सी द माइक्रोस्कोपिक इमेज। सर सेल आउटलाइंस आर प्रिजर्व्ड बट देयर इज नो न्यूक्लियस। There's no nucleus inside. Come on, it has to be coagulative necrosis. Again, cell outlines are preserved, right? Done. Next पे आते हैं। सर ये दे दिया सर, सर ब्रेन में दे दिया और ब्रेन गीला गीला हो गया। आई मीन गीले गीले का मतलब समझ गए हो। इट हैज टू बी लिक्विफैक्टिव नेक्रोसिस। ब्रेन में है तो गो विद लिक्विफैक्टिव नेक्रोसिस। कॉमन कॉज इन्फेक्शन। टिश्यू आर्किटेक्चर नॉट प्रिजर्व्ड, नॉट प्रिजर्व, नॉट प्रिजर्व। नेक्स्ट पे आ जाते हैं सर। सर ये तो लंग्स का नहीं लग रहा सर, ये तो दिस इज समथिंग चीजी मटेरियल नो सर। सर ये चीजी मटेरियल तो मैं बचा रहे सर, इतने इजी दोगे क्या? वो भी तुम्हें यही देगा, केशिएटिंग नेक्रोसिस। TB has to be the first thing, other it is in nocardia also, coccidomycosis also, histoplasmosis also, but ये गलत नहीं करना, पाप लग जाएगा। सर ये तो ओमेंटम सा नहीं लग रहा सर, दिस हैज टू बी फैट नो। और फैट पे येलो येलो चौकी वाइट एरिया दिख रहे हैं सर। Somebody has to impress me. Again, बाहर निकलने को तैयार, तुम्हारी जेब में आगे गिरने को तैयार। क्या दिख रहा है? येलो चौकी वाइट एरियाज, सेपोनिफिकेशन। सेपोनिफिकेशन, फैट, it has to be fatty necrosis, fatty necrosis। सही जा रहा है डार्लिंग, सही जा रहा है। चल फटाफट। ब्लड वेसल की इमेज है। अगेन टाइम टू इंप्रेस गाइस, टाइम टू इंप्रेस। ब्लड वेसल पे पिंक नेक्रोसिस इन द वॉल, पिंक नेक्रोसिस इन द वॉल, पिंक फिब्रिनॉइड नेक्रोसिस सीन इन एनी वेस्कुलर इंजरी। मैंने निमोनिक बताया था। MRP किसको सैगो दिखावे, किसको सैगो दिखा? करम जली, जला जली है तो सॉरी, जला है तो चलने दो मैडम, दिखा रहा हूं, आ रहा हूं। साबुदाना लेके मैं खुद ही आ रहा हूं, रुक जा एक मिनट, रुक जा। मैलिग्नेंट हाइपरटेंशन, रूमेटिक हार्ट डिसीज एंड पैन। MRP। देन ये नहीं पहचाना तो जाके सो जा, सो जा भाई, सीधा एग्जाम वाले दिन उठेंगे। अब तू सो जाएगा, तुझे ये भी समझ नहीं आया तो। बी में स्टेप लेडर पैटर्न दिख रहा है इलेक्ट्रोफोरेसिस पे, ये भी नहीं आता तो बेटे सो जा। नंबर अपना लिख दे, एग्जाम वाले दिन मैं सुबह सुबह अलार्म लगा के उठा दूंगा तेरे को। तू सो जा भाई, हक नहीं है तुझे जागने का। चलो फटाफट। स्मीयर पैटर्न दिखे तो एपोप्टोसिस, सॉरी स्मीयर पैटर्न दिखे तो नेक्रोसिस। नेक्रोसिस, चलो चलो चलो, चलने दो चलने दो। ट्राई टू कवर, रुकने से अच्छा मैक्सिमम आपकी नजरों के सामने घुस जाना चाहिए। वर्ल पैटर्न है, बट दिस टाइम ऑन लाइट माइक्रोस्कोपी। पर्पल वर्ल्स ऑफ कैल्सिफिकेशन। सर क्या बात कर रहे हो सर? ना इसकी मां ना उसकी मां, सामोमा, राइट? PSM वाले ट्यूमर्स, पैपिलरी कार्सिनोमा थायराइड, सीरस एडेनोमा ओवरी, मेनिंजियोमा। बोलने पे आ रहा है, आ रहा है। यहां लिख देता तो तुम्हारा दिमाग नहीं होता। मैं चाहता हूं यू पे टू दिस साउंड्स, फोकस ऑन साउंड्स दैट आई एम सेइंग। ਹੁਣ ਸੋ ਕੇ ਕਰਨਾ ਵੀ ਕੀ ਹੈਗਾ ਪੁੱਤਰ, ਨੀਂਦ ਨਹੀਂ ਆਉਂਦੀ ਤੈਨੂੰ? ਹੁਣ ਸੋ ਕੇ ਕਰਨਾ ਕੀ ਹੈਗਾ? ਤੂੰ ਤਿਆਰੀ ਕਰ ਪਾर्टी ਦੀ। चलो, पेरीन्यूक्लियर है, ब्राउन पिगमेंट है, इट्स अराउंड द न्यूक्लियस। 83 ईयर ओल्ड का है, हार्ट की बायोप्सी है, पेरीन्यूक्लियर ब्राउन बॉडीज है। सर ये नहीं पता लगेगा तो पाप लगेगा ना सर, ये तो एजिंग पिगमेंट नहीं है सर, Perinuclear brown is aging pigment, lipofuscin, wear and tear pigment. 83-year-old cardiac biopsy, ये इमेज go for it. चलो नेक्स्ट में, सर ये तो क्या हो गया, सर ये तो टीबी की हिस्ट्री दे रखी होगी और पिंक पिंक केशिएटिंग नेक्रोसिस दिख रहा होगा, सेंटर में पिंक केशिएटिंग नेक्रोसिस है। सर ये वाली नेक्रोसिस इमेज में आई जहां सेंट्रल पिंक नेक्रोसिस है, सर आई विल नॉट वेस्ट टाइम, इसमें केशिएटिंग नेक्रोसिस होगा, मेरा फर्स्ट आंसर टीबी ही होगा, क्योंकि टीबी में सेंट्रल में पिंक नेक्रोसिस होगी, दिस इज केशिएटिंग नेक्रोसिस। कंपेयर दिस द नेक्स्ट वन जहां पे सेंट्रल नेक्रोसिस नहीं होगी, ओनली टाइट क्लस्टर्स ऑफ सेल्स होंगे, ये नॉन केशिएटिंग हो जाएगा। वेयर इन द सेंटर, कौन बताएगा? इंप्रेस, ग्रैनुलोमा बनाने के लिए मोस्ट इंपोर्टेंट सेल्स एपिथेलियोइड सेल्स, तो दिस हैज टू बी नॉन केशिएटिंग ग्रैनुलोमा। कहां दिखेगा, कहां दिखेगा? सार्कोइडोसिस में। द फर्स्ट थिंग, मिलने को तो और भी बहुत जगह मिल सकता है, हाइपरसेंसिटिव न्यूमोनाइटिस में मिल सकता है, क्रॉस में मिल सकता है, बट एग्जाम पॉइंट ऑफ व्यू से एग्जाम से एक दिन पहले नॉन केशिएटिंग सुनते ही अगर सार्कोइडोसिस दिमाग में आ रहा है तो जिंदा हो तुम। नेक्स्ट पे आते हैं, ये कौन सा ग्रैनुलोमा है बॉस? अरे बता दो साहब। अरे ये नहीं आएगा क्या? अरे अरे इसका तो टाइम आने वाला है तुम्हारा, जल्दी से, जब गर्दन पे, पीठ पे, हाँ कम ऑन। स्टार शेप ग्रैनुलोमा, स्टीलेट ग्रैनुलोमा। कौन सी डिसीज? कैट स्क्रैच डिसीज, कैट स्क्रैच डिसीज। बहुत बढ़िया, बहुत बढ़िया, फटाफट फटाफट। अरे क्यों जानू बोलो, डोनट खिला दो, तो बोलना है क्यों करम जली, खुद अपने पैसों से खा, क्यों? डोनट ग्रैनुलोमा, क्यू फीवर, क्यू फीवर सबको आता है सर, ये इसके थोड़ी टाइम यूज करूंगा। सर ये वाला जॉइंट सेल अगर आपने पहचान लिए तो वहीं बैठे बैठे मुझे हाईफाई दे देना, वहीं बैठे बैठे हाईफाई दे देना। स्ट्रेस में पहचानना आसान नहीं होता, आ रहा है, पहचान लिया है, हॉर्स शेप है, तो ये रहा हाईफाई, लग गया, लग गया, पहचान लिया, बहुत जोर से थप्पड़ पड़ा है मेरे हाथ पे, मतलब पूरे इंडिया से आया है। लैंगहैंस जॉइंट सेल विल गो विद टीबी, लैंगहैंस जॉइंट सेल इज फॉर टीबी, टीबी। चलो फटाफट एवरीबॉडी, सूचर्स की हिस्ट्री है, टॉक की हिस्ट्री है, एंड दिस इज ऑल क्लस्टर्ड haphazardly, दिस इज फॉरेन बॉडी जॉइंट सेल, फॉरेन बॉडी जॉइंट सेल। डन डन डन, बहुत बढ़िया। चलो सर ये तो दे रखा है, इओसिनोफिक इंक्लूजन है अंदर सर, अगर जायंट सेल के सेंटर में पिंक पिंक इंक्लूजन दिखे सर, ये तो वॉर्थिन फिंकल डी है सर। वॉर्थिन फिंकल डी अगर आपने बता दिया, अगर आपने बता दिया, ये टुकड़े 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 करके भी तुम्हारे पास। चलो फटाफट, वॉर्थिन फिंकल डी सीन इन मीसल्स। सर कश्मीर से हाईफाई, अच्छा कश्मीर से आया था तभी बहुत जोर के लगा है। वॉर्थिन फिंकल डी इस मीसल्स, राइट, डन डन डन। ये भी पहचान लो फिर, वो जाइंट सेल जिनका साइटोप्लाज्म है, दिस अ क्लियर साइटोप्लाज्म, इन द सेंटर सेल्स आर क्लस्टर्ड एंड देन वी हैव क्लियर साइटोप्लाज्म, दिस इज टाउटन जाइंट सेल्स। ये भी इज नॉट इजी टू रिकॉल, इफ यू कुड दिस, भाई साहब वहीं बैठे बैठे दोबारा हाईफाई, चलो देते रहे। अरे 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 अरे, हाँ हाँ हाँ, वेरी गुड। टाउटन जाइंट सेल्स आर सीन इन ज़ेंथोमा, टाउटन जाइंट सेल्स आर सीन इन ज़ेंथोमा। ये सी क्या लिखा है बे? सी, अबे मैं एबीसीडी खेल रहा हूँ, ये ऑप्शन कौन चूज कर रहा है? अरशद भाई, अरशद भाई ऑप्शन किसके लिए? एक तो ये ऑप्शंस वाली आदत, फटाफट बता दो, फटाफट बता दो। किलोइड है सर, सर मार्जिन को क्रॉस कर गया सर, ये सर ये इमेज आएगी तो मैं बता ही दूंगा ना सर, ये तो किलोइड है। फिर तुमसे पूछेगा किलोइड की मोस्ट कॉमन साइट स्टर्नम होती है, तुमसे पूछेगा किलोइड का ड्रग ऑफ चॉइस, किलोइड का ड्रग ऑफ चॉइस है तुम्हें पता है, देवी का नाम लेना है, देवी का नाम क्या है? सनीलियोनी, ट्रायमसिनिलॉन, ट्रायमसिनिलॉन, राइट, डन है, डन है, सही जा रहे हो, सही जा रहे हो। बट सर नहीं सर, नहीं 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 सर, गंदी बातें नहीं करनी, कोई सनीलियोनी नहीं सर, आएगा नहीं सर। मैं तो सर इस टाइम पूजा मेरी बहन है, सीमा मेरी बहन है, दुनिया की हर लड़की मेरी नहीं भी कर्म जलो तुम्हारी, तुम्हारी, तुम पढ़ाई देने ना इस टाइम। सर मेरे को चाहिए नहीं सनी लियोनी सर, मेरे को तो एग्जाम में हाइपरट्रॉफिक स्कार आएगा जो अपनी हद में रहेगा, कभी अपने मार्जिन को क्रॉस नहीं करेगा, जैसे मैं हूं। मुझे पता है अभी तुम हाइपरट्रॉफिक स्कार हो, और जैसे तुम्हारा एफएमजी निकला साड़ो सब तुम किलोइड बनोगे, मुझे पता है। अभी हद में रहो, कोई प्रॉब्लम नहीं, बाद में जो करना कर लेना, अभी स्टे विद योर मार्जिन्स, बी लाइक हाइपरट्रॉफिक स्कार। डन सर। सर ये अमाइलॉइड नहीं है सर, पिंक पिंक, मुझे आपसे जाना है, पिंक अमाइलॉइड सैल्मन पिंक दिख रहा है, प्लीज राइट इट डाउन फॉर मी। अमाइलॉइड सैल्मन पिंक दिख रहा है, तो इट हैज टू बी विच स्टेन एंड विच माइक्रोस्कोपी? अगर सैल्मन पिंक दिख रहा है तो इट इज कॉन्गो रेड स्टेन, ऑन विच माइक्रोस्कोपी? लाइट माइक्रोस्कोपी। पर यही कॉन्गो रेड लगा के मैंने अगर लाइट माइक्रोस्कोपी की जगह कौन सी माइक्रोस्कोपी पे, पोलराइज्ड माइक्रोस्कोपी पे देख लिया तो क्या दिखेगा मेरे को? एप्पल ग्रीन बायरिफ्रिंजेंस, एप्पल ग्रीन बायरिफ्रिंजेंस दिखेगा। दिख रहा है ना सबको? सब दिखेगा। मैं सेब लेके तैयार हूं, तुम एग्जाम निकाल के आओ। हाँ जी मैडम, साबुदाना, ए साबुदाना, ए कहाँ आपको सैगो दिख गया था मैडम? ये रहा सैगो ग्रेन, दिस इज कॉल्ड एज सैगोस्प्लीन। प्लीज बता दो कहाँ पे, प्लीज बता दो, वेट कर रहा हूं। जहां पे मैं वेट करूंगा, मैं आपके जवाब सुनने बगैर आई विल नॉट मूव टू द नेक्स्ट क्वेश्चन। सैगोस्प्लीन हैज टू बी रीनल अमाइलोइडोसिस, स्प्लीनिक अमाइलोइडोसिस। सैगो मतलब राइट पल्प या व्हाइट पल्प? व्हाइट पल्प। रेड होता तो लारेडिशियस होता। राइट, डन डन डन। नेक्स्ट पे देखो, पेडिग्री फटाफट सोल्व कर दो। मदर है, मेरी वर्ड्स को सुनना, पेडिग्री नहीं भी आएगी तो वहां पे समझ में आएगा। मदर टू ऑल द चिल्ड्रन, सन नॉट टेकिंग टू द नेक्स्ट जनरेशन, डॉटर टेकिंग टू द नेक्स्ट जनरेशन, माइटोकॉन्ड्रियल। मैंने कहा है ना, यहां बन रहा है तो ब्रिलियंट, नहीं बनेगा तो ब्रिलियंट, क्योंकि वहां बहुत टाइम होगा, है ना, है ना, इसलिए स्ट्रेस नहीं लेना, फटाफट। चमन, स्किप जनरेशन है? यस सर, है रिसेसिव है सर। मदर, डॉटर ऑल्सो अफेक्टेड, सन ऑल्सो अफेक्टेड, ऑटोसोमल रिसेसिव। पेडिग्री में ज्यादा टेंशन मत लेना, मुझे पता है वहां आराम से टाइम लगता है। इतना बता देना, चलो जो मैं पूछ रहा हूं बोलने पे याद आते नहीं, फादर टू ऑल द डॉटर्स, ये बता दो तुम तो बस। दिस इज फॉर विच पेडिग्री? फादर टू 100% ऑफ डॉटर्स। सर ये तो एक्स लिंक डोमिनेंट नहीं होता क्या? आ गया तो ये बिना मांगे तुम्हारा। फादर टू 100% ऑफ डॉटर्स, एक्स लिंक डोमिनेंट, डन। नेक्स्ट पे आते हैं। सर ओनली ये बताना पड़ेगा, बताना पड़ेगा, ओनली सल्स आर अफेक्टेड, ओनली मेल्स आर अफेक्टेड, फीमेल्स आर जस्ट कैरियर्स, ये तो बताना ही पड़ेगा। ओनली मेल्स अफेक्टेड, फीमेल्स आर जस्ट कैरियर्स, एक्स लिंक रिसेसिव। तुम लोग शानदार हो, बिल्कुल शानदार हो, ब्रिलियंट जा रहे हो, ब्रिलियंट गाइस, ब्रिलियंट ब्रिलियंट। चलो अब थोड़ी सी लाइट माइक्रोस्कोपी रिवाइज कर लेते हैं। कौन सी आर्टीरियोस्क्लेरोसिस? सर ये तो पिंक नहीं है क्या? सर पिंक वाली तो हाइलिन वाली नहीं होती क्या? हाइलिन वाली सीन इन बेनाइन हाइपरटेंशन। बट अगर ये वाली इमेज आ गई तो सर ये तो ऑनियन स्किन अपीयरेंस जैसा नहीं दिख रहा क्या सर? सर ऑनियन स्किन तो मैलिग्नेंट हाइपरटेंशन में नहीं मिलती थी क्या? बोलने पे याद आ रहा है क्या? है ना, टाइम ही नहीं है, अपन को पूरा पूरा रिवाइज करना है। मैलिग्नेंट हाइपरटेंशन, ऑनियन स्किन अपीयरेंस, ठीक है सर, ठीक है ना सर, इतना क्या कर रहे हो सर, हमें भी पता है कि कौन सी स्किन है। सर रेड येलो दिख रहा है, अरे सर हमारे सामने मत पेलो ज्यादा ज्ञान, तुमसे ज्यादा हमको पता है, टीटीसी है सर। इन टीटीसी रेड का मतलब तो वायबल होता है बॉस, और जो पेल दिख रहा है दैट इज इनफैक्ट है सर। हमें ना सिखाओ सर, तुम अपनी नौकरी बचाओ, हो सकता है एफएमजी निकाल के हम किसी कोचिंग में नहीं, हाँ किसी में पढ़ा, पैथो नहीं पढ़ाना, बस मेरे पेट पे कोई लात नहीं मारेगा। डन, टीटीसी इनफैक्ट डन। लेट्स मूव टू द नेक्स्ट क्वेश्चन। अरे ये इमेज नहीं आई तो जहां इसका है ना वहीं तुम्हारे मुक्का पड़ेगा। दिस इज जाइंट सेल वेस्कुलाइटिस, टेम्पोरल आर्थराइटिस, जाइंट सेल आर्थराइटिस। एज कितनी होनी चाहिए? मोर देन 50। मोस्ट कॉमन सिम्टम हेडेक, मोस्ट स्पेसिफिक जॉ क्लॉडिकेशन। बहुत सही जा रहे हो, बहुत सही जा रहे हो। सर ये कौन सी वेस्कुलाइटिस है सर जिसमें कम ऑन लंग्स में कैविटी लीजन्स बनी है? और सर नोज तो सैडल है ना सर, नोज सैडल है सर, कैविटी सैडल नोज, कम ऑन। अरे मार खाओगे, फटाफट लिख के बता दो। वैजिनस, हैज टू बी वैजिनस ग्रैनुलोमेटोसिस। अरे बहुत सही जा रहे हो। कोई पैथो पढ़ाए तो मैडम मैं ही हेल्प करूंगा उसकी पढ़ाने में, मुझसे ज्यादा खुश कोई नहीं होगा, कोई मुझसे अच्छा, मतलब मैं तो कुछ भी नहीं हूं। आई प्रे टू गॉड यू गेट एवरीथिंग यू वांट इन लाइफ। सर बच्चा है परप्यूरिक रैश है एक्सटेंसर सरफेस पे, सर बच्चे के परप्यूरिक रैश है एक्सटेंसर सरफेस, सर मुझे तो एचएसपी याद नहीं आना चाहिए क्या? सर एचएसपी याद आ रहा है तो मुझे आईजीए का लेवल भी याद आएगा, इसमें तो आईजीए का लेवल बढ़ जाता था। बहुत बढ़िया जा रहे हो सर, ये तो आपको आता है, एचएसपी में आईजीए है। सर ये कौन सा लीवर है सर? सर खुश कर दो ना प्लीज 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 प्लीज, नटमेग लीवर। अरे सब कहाँ दिखता है सर? ये तो मिलता है क्रॉनिक वेनस कंजेशन लीवर में। सर वो कहाँ मिलता है? सीवीसी लीवर। सर ये तो राइट हार्ट फेलियर में नहीं मिलता क्या? सब कुछ याद आ रहा है क्या? सब कुछ यार, सब कुछ चांस, मुझे टेंशन हो रही है यार तुम्हारे लिए। तुम्हें सब कुछ याद आ गया, तुम ओवर कॉन्फिडेंस में चले गए तो नहीं 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 नहीं, बता दो सर, फिर ये बता दो, थोड़ा डरा देता हूँ। सर डिस्पनिया के साथ हिस्ट्री है एंड लंग बायोप्सी में ब्राउन मैक्रोफेजेस मिल रहे हैं सर। On lung biopsy, you get to see brown macrophages. Sir, these aren't this heart failure cells? सर पता है तुम्हें सर, लंग की बायोप्सी में ब्राउन मैक्रोफेजेस हैं. दिस आर हार्ट फेलियर सेल. व्हाट आर हार्ट फेलियर सेल्स? हीमोसिड्रिन लेडन मैक्रोफेजेस. तुम लोग शानदार हो. फटाफट. 5 साल का बच्चा है, हिस्ट्री ऑफ एलिवेटेड पीआर इंटरवल है, और पहले तो ये सिनोसिस दे रखी है. सर बता दो कौन सी सिनोसिस है? फिश माउथ है सर. फिश माउथ सिनोसिस है सर. ये कहाँ मिलती है बॉस? क्रॉनिक आरएचडी के पेशेंट में. आरएचडी तो बना दिया. इतने सारे इंटरव्यू कैसे लोगे बॉस? मैं अगर इस हालत में ऐसे पढ़ा सकता तो मैं कुछ भी कर सकता हूँ. आई एम अ ब्लेस्ड किड. चलो, एश ऑफ नोड्यूल. एश ऑफ नोड्यूल, एक्यूट आरएचडी, एक्यूट आरएचडी. चलने दो, चलने दो. सर ये भी बता दो. नहीं तो ये जो दिख रहा है ना तुम्हें, तुमने ये नहीं बताया ना, यही बन के आऊंगा तुम्हारी जिंदगी में. ऐसी जगह काटूंगा करम चलो, किसी को बता भी नहीं पाओगे. कैटरपिलर. एनएच सेल्स, अगेन फीचर ऑफ एक्यूट आरएचडी. एनएच सेल्स. चलो चलने दो, चलने दो. सर एथलीट कोलैप्स ऑन फ्लीट, और इतना बड़ा हार्ट है. प्रोमिनेंट हार्ट है सर. मसल्स ही मसल्स है सर. और जो इसकी कैविटी है वो भी बनाना शेप कैविटी है सर. सर इट हैज टू बी HOCM. हैज टू बी HOCM सर. आता है सर, हमें सब आता है, ज्ञान मत पेलो सर. तो सर आपने फोटो में लिख दिया, आई नो पहचान लोगे. मुझे पता है इमेज से ज्यादा वो पूछेगा. बॉक्स कार न्यूक्लियस सीन इन, बॉक्स कार न्यूक्लियर, HOCM में दिखता है बॉक्स कार न्यूक्लियर. चलने दो. सर ये नहीं बताया तो दिन में तारे दिखा दूंगा, मैं तुम्हें तारे दिखाऊंगा. फटाफट. निंजा स्टार कहाँ पे? HOCM में. निंजा स्टार न्यूक्लियर, HOCM, सॉरी DCM. निंजा स्टार न्यूक्लियर, DCM. देन एस्मा का पेशेंट है, हिस्ट्री ऑफ विजिंग डिस्निया एंड एक्सपोजर डस्ट. फटाफट. ये ग्रीन वाली बॉडीज कौन सी है? अरे पिंक नीडल शेप क्रिस्टल. फटाफट बता दो यार. दिस इज चारकोट लेडन क्रिस्टल. सर आपको ट्रॉमा कब हुआ? बस भाई अभी नहा रहा था बाथरूम में, अपने हुस्न अपनी लंबी लंबी जुल्फे संभाल रहा था, पैर स्लिप हो गया. अभी भी हुआ है बस भाई. खुशी में था ना, तुमको पढ़ाने आने वाला था भाई. दिस आर चारकोट कर्शमैन स्पाइरल्स. अगेन एस्मा, स्पाइरल प्लग्स एस्मा. सर ये बता दो सर. सर ये तो पूरा लंग ब्लैक नहीं है सर, ये तो ब्लैक लंग्स नहीं है क्या? सर दिस इज ब्लैक लंग. ब्लैक लंग के बायोप्सी में यानी एंथ्राकोसिस पूछ रहा है. बायोप्सी में क्या मिलेगा? बायोप्सी में क्या मिलेगा सर? इसमें तो सर कोल लेडन मैक्रोफेजेस मिलेंगे ना. उन डस्ट को सेल्स को क्या बोलते हैं? डस्ट सेल्स. व्हाट आर डस्ट सेल्स? कार्बन लेडन मैक्रोफेजेस. कार्बन लेडन मैक्रोफेजेस एंथ्राकोसिस पे टिक करके आ जाएंगे, एंथ्राकोसिस पे टिक करके आएंगे. ये बता दो, मार खाओगे नहीं तो. सच में मार. जो इमेज दिख रहा है ना वही घुमा के मारूंगा तुम्हें. कौन सी शेप दिख रही है? डम्बेल शेप दिख रही है. डम्बेल. लेड और पाइप इंडस्ट्री है, डम्बेल शेप बॉडीज है. फेरोजेनस बॉडीज, एस्बेस्टोसिस पे टिक करके आ जाना. फेरोजेनस बॉडीज, एस्बेस्टोसिस. चलने दो, चलने को. सर ये कौन सी बॉडीज है सर? सर तो स्टीलेट बॉडीज है सर. गाइस दिल मत तोड़ना. स्टीलेट और एस्ट्रॉइड बॉडीज, सार्कोइडोसिस. स्टीलेट ग्रैनुलोमा, स्टीलेट ग्रैनुलोमा, कैट स्क्रैच डिसीज. स्टीलेट और एस्ट्रॉइड बॉडीज हैज टू बी सीन इन सार्कोइडोसिस. सर ये तो पर्पल वॉल ऑफ कैल्शियम है ना सर. दिस तो शोमैन बॉडीज. ये तो शोमैन बॉडीज हो गया. सीन इन सार्कोइडोसिस. अगेन सार्कोइडोसिस. सार्कोइडोसिस में मिलने दो. फटाफट. दिल खुश हो जाएगा. क्या पहचाना? लंग बायोप्सी है. देयर हैज टू बी 2 क्वेश्चन फ्रॉम लंग कैंसर. सर पिंक कैरेटिन पल्स है ना सर? पिंक पल्स दिख रहे हैं ना? तो क्या हुआ? स्क्वैमस सेल कार्सिनोमा. सर स्क्वैमस सेल की ISC मार्कर क्या था? P40 P63. सर पैरानियोप्लास्टिक सिंड्रोम क्या था? हाइपरकैल्सीमिया. याद आ रहा है? P और C अल्फाबेट. थिंक अबाउट स्क्वैमस सेल कार्सिनोमा. डन. नेक्स्ट देखना. सर तो ग्लैंड्स नहीं दिख रहे सर. सर तो ग्लैंड्स दिख रहे हैं. ग्लैंड्स का मतलब एडिनो. एडिनो. ISC में नेप्सिन ए. नेप्सिन ए. डन. सर सब कुछ ब्लू दिखे तो स्मॉल सेल कार्सिनोमा. स्मॉल सेल कार्सिनोमा. सर ISC, सर साइनेप्टोफाइसिन क्रोमोग्रेनिन, साइनेप्टोफाइसिन, क्रोमोग्रेन, पैरानियोप्लास्टी सिंड्रोम, SIADH, कुशिंग सिंड्रोम। सब कुछ याद आ रहा है क्या? एकदम आई शपथ खा के बोलो, आई शपथ। सब कुछ याद आ रहा है जो मैं पढ़ा रहा हूँ? ऐसा तो नहीं हो सकता। अब मेरे को डर लग रहा है क्योंकि ऐसा हो रहा है तो तुम कुछ गलत करके आ जाओगे एग्जाम में। चाइल्ड विद कोला कलर यूरिन कौन सा हम पे? ये भी पहचान लिया तो भाई साहब एग्जाम निकालना फॉर्मेलिटी है तुम्हारे लिए। बस तुम्हें एग्जाम में फॉर्मेलिटी करके आने, अगर ये भी पहचान लिया। चाइल्ड विद कोला कलर यूरिन, सब एपिथेलियल हम दिख रहा है, PSGN। बेसमेंट मेम्ब्रेन के ऊपर दिख रहा है ना, तो PSGN। ओह भाई साहब, ओ भाई साहब, इसमें ना आई शपथ मत खाना, क्योंकि तो सही हो ही नहीं सकता किसी का भी। जब किसी का नहीं हो सकता तुम्हारा कैसे हो जाएगा? क्योंकि अगर तुमने ये भी सही कर दिया, अब मेरी लिटरली फटने वाली है। कम ऑन गाइस, कम ऑन। क्या हुआ बेसमेंट मेम्ब्रेन को? रप्चर्ड है। रप्चर बेसमेंट मेम्ब्रेन हैज टू बी RPGN। क्या ये भी याद था? ये तो थोड़ा मुश्किल था, याद आना नहीं चाहिए था। इमेज देखे तो बिल्कुल भी नहीं आता एग्जाम से पहले तो। रप्चर RPGN, हाँ ये मैं मान सकता हूँ आ गया होगा सर, ये तो हमें आता है सर, क्योंकि ये भी नहीं आया ना, जो चांद तारे तुमने तोड़ के देने अपनी वाली को, मैं दे के आऊंगा। क्रिसेंट शेप, RPGN, चलने दो सर। इफेसमेंट दिख रही है पोडोसाइट्स की, एवरीबडी। इफेसमेंट जानबूझ के नॉर्मल डाला है सो यू कैन रिलेट। इफेसमेंट ऑफ पोडोसाइट चाइल्ड में है मिनिमल चेंज डिसीज, has to be minimal change disease. Effacement of podocytes, minimal change disease. Come on, what is this? ये तो आ ही नहीं सकता, चांस ही नहीं है। सुनो मुझे, चांस ही नहीं है कि तुमसे क्वेश्चन बन जाएगा। चलो हिस्ट्री दे देता हूँ। एडल्ट विद मैलिग्नेंसी एंड प्रोटीन यूरिया, चांस ही नहीं है। हिस्ट्री, केमिस्ट्री, जूलॉजी, सब कुछ ले लो, बन ही नहीं सकता तुम्हारा ये। दिस इज स्पाइक एंड डोम अपीयरेंस, ये तो आ ही नहीं सकता, इसलिए मैं टाइम वेस्ट करता ही नहीं हूँ। अबे 300 में से 300 थोड़ी आते हैं किसी के। Spike and dome appearance is membranous glomerulopathy. चलो डायबिटिक पेशेंट है, हिस्ट्री दे रहा हूं। डायबिटिक पेशेंट में ये बताना पड़ेगा, डायबिटिक पेशेंट में नोड्यूल्स बन गए हैं, पिंक नोड्यूलर स्क्लेरोसिस हो चुकी है। व्हाट इज दिस नोड्यूल कॉल्ड एज? देखा निकला ना किसी का FSGS। चल बेटे तेरे 300 तो नहीं आएंगे, 299 में एडजस्ट कर लियो प्लीज। किमलस्टीन विल्सन डिसीज, किमलसन विल्सन डिसीज, डन। डायबिटिक में मिलता है सर। मलार रैश की हिस्ट्री है सर, ये नहीं गलेगा क्या सर? यही लटका के मारूंगा तुमको। एवरीबॉडी कम ऑन। वायर लूप लीजन्स कहां मिलता है? लूपस नेफ्राइटिस में। वायर लूपस नेफ्राइटिस क्लास 4 में। कास्ट बता दो सर, ये तो दिख ही नहीं रहा सर जो दिख ही नहीं रहा वो पहचानेंगे कैसे? नहीं दिख रहा तभी तो पहचानना है। हाइलिन कास्ट, वेरी फेंटली विजिबल आउटलाइन, हाइलिन कास्ट, टैम हॉर्सफॉल प्रोटीन से बना हुआ है। मोस्ट कॉमन कास्ट 2 years बैक FMGE, हाइलिन कास्ट, फेंटली विजिबल, मोस्ट कॉमन, टैम हॉर्सफॉल प्रोटीन। नेक्स्ट पे आ जाते हैं सर। ये तो गंदा ब्राउन कास्ट है सर, दिस इज मड्डी ब्राउन कास्ट सर, और मड्डी ब्राउन कास्ट इज सीन इन एक्यूट ट्यूबुलर नेक्रोसिस। मड्डी ब्राउन, मिट्टी की तरह ब्राउन, मैंने कहा था एक्यूट ट्यूबुलर नेक्रोसिस मतलब सेल डेथ, मरने के बाद सब मिट्टी हो जाना है। मिट्टी मर गया, सेल डेथ, एक्यूट ट्यूबुलर नेक्रोसिस। डन सर। कास्ट में ना क्रैक्स आ गए हैं जिसमें, दिस इज वेक्सी कास्ट, क्रॉनिक रीनल फेलियर। वेक्सी कास्ट, क्रॉनिक रीनल फेलियर, ये भी याद रखा। ये वाला कास्ट तो नहीं आ सकता नहीं। चलो ये स्टोन बता दो फिर, कौन सा अपीयरेंस है सर? डम्बल स्टोन है सर डम्बल है। मोना इज डम, कैल्शियम ऑक्सलेट मोनोहाइड्रेट, मोनोहाइड्रेट। सर एक मिनट सर आपके सक्सेस में अगर हम इंटरव्यू तक नहीं पहुंच पाए तो ये वाला एनवेलप भेजोगे क्या? भेजूंगा। एनवेलप में कौन सा स्टोन डाल के भेजूंगा? एनवेलप कैल्शियम ऑक्सलेट डाइहाइड्रेट। एनवेलप के लिए 2 डंडे, कैल्शियम ऑक्सलेट डाइहाइड्रेट। डन सर। कॉफिन लिड नहीं बताया तो इसी कॉफिन में गए तुम। कॉफिन लिड फटाफट, कॉफिन लिड, स्ट्रूवाइट स्टोन्स, स्ट्रूवाइट्स अगेन रेडियोलॉजी पे ग्रॉस में विल गिव स्टैग ऑन अपीयरेंस। ट्रिपल फॉस्फेट और अमोनियम फॉस्फेट स्टोन, वो स्टोन जो एल्कलाइन पीएच पे होते हैं, स्ट्रूवेट फॉस, प्रोटियस इन्फेक्शन से होते हैं। जो मैं बोल रहा हूं वो भी सुनना है। हम एक 1 आवर में सारा तभी कवर कर पाएंगे जब आप मुझे सुनोगे भी, राइट? एल्कलाइन फॉस्फेट पीएच पे होगा, प्रोटियस से होगा स्ट्रूवाइट स्टोन। चलो नेक्स्ट पे आ जाते हैं सर। यू आर माई डायमंड, यूरिक एसिड डायमंड और रोम्बॉइड शेप, डायमंड शेप स्टोन्स, येलो टिंच होगा सर, यू आर माई डायमंड, सो डायमंड और रोम्बॉइड शेप स्टोन है विद येलो टिंच, थिंक अबाउट यूरिक एसिड, राइट, यूरिक एसिड, डन है, डन है, डन है, डन है। नेक्स्ट पे देख, अरे दिल खुश, हाई फाई वाला क्वेश्चन, हाई फाई वाला क्वेश्चन, दिस इज फ्ली बिटन अपीयरेंस seen in malignant hypertension, फ्ली बिटन किडनी, malignant hypertension, डन, बहुत सही जा रहे हो, कम, और ये भी एकदम स्टेराइल पायूरिया, सर दिस इज पुटी किडनी, रीनल टीबी में, पुटी टीबी सर, रीनल ट्यूबरकुलोसिस में, चलो डन पे चलते हैं, ब्रेस्ट कैंसर है सर, पहला अपीयरेंस प्यूडी ऑरेंज, प्यूडी ऑरेंज दिख रहा है सर, नॉर्मली विच कैंसर, इन्फ्लेमेटोरी कार्सिनोमा, कैंसर का नाम भूल जाओगे चल जाएगा, बट ये तो पहचान ही लोगे, प्यूडी ऑरेंज तो पहचान ही लोगे, मोस्ट कॉमनली सीन विद इन्फ्लेमेटरी कार्सिनोमा, ये बता दो प्लीज बता दो, अरे इसी के फाइलों में जाना है, इसी दफ्तर में जाना है तुम्हें, एग्जाम निकालते ही एनएमसी में जाओगे, फाइलें एक दूसरे पर पड़ी होंगी, तुम देखोगे अरे मेरा तो 190 आया था, मेरी वाली फाइल पहले निकाल दो यार, इसकी 150 आई थी, इसकी बाद में निकालना, चलो इंडियन फाइल पैटर्न, विच कैंसर, विच कैंसर, लोब्यूलर कार्सिनोमा, इंडियन फाइल पैटर्न, लोब्यूलर कार्सिनोमा, डन है, डन है सर, सर रिंग, सर रिंग वेट कर रही है ना, पिरानी ना रिंग, उसको फटाफट बता दो कौन से रिंग है, सिग्नेट रिंग सेल, सिग्नेट रिंग, स्टमक में मिले तो, स्टमक में डिफ्यूज गैस्ट्रिक कार्सिनोमा, ब्रेस्ट में लॉब्यूलर ब्रेस्ट कार्सिनोमा, ओवरी में बता दो, ओवरी में सिग्नेट रिंग सेल्स, सर क्रूकनबर्ग ट्यूमर, हमें ना सिखाओ सर, क्रूकनबर्ग ट्यूमर, सर ये तो अरे सर ब्रेस्ट की इमेज है और सारा क्लियर दिख रहा है, सर क्लियर दिख रहा है, सर क्या चीज है ये क्लियर क्लियर, सर ये म्यूसिन है, वो एग्जाम में लिख देगा म्यूसिन पूल दिख रहे हैं, और करम जला पर ऑप्शन में म्यूसिनस नहीं देगा, वो क्या देगा, कोलॉइड कार्सिनोमा, क्लियर क्लियर म्यूसिन दिख रहा है, म्यूसिनस कार्सिनोमा और लोब्यूलर कार्सिनोमा और कोलॉइड कार्सिनोमा और म्यूसिनस कार्सिनोमा, सब कुछ क्लियर दिखे, म्यूसिनस और कोलॉइड, डन है, बहुत बढ़िया जा रहे हो, चलो चलो फटाफट, 45 ईयर ओल्ड विद फ्रंटल लोब मास और बटरफ्लाई दिख रही है, सर बटरफ्लाई दिख रही है, अरे नहीं बटरफ्लाई नहीं है सर, ये तो मेरा दिल है जो तुम ऑलरेडी लूट चुके हो, जिस तरह तुम आंसर कर रहे हो, ट्रस्ट मी द सक्सेस इज जस्ट राउंड द कॉर्नर, ग्लायोब्लास्टोमा, ग्लायोब्लास्टोमा, बटरफ्लाई ट्यूमर, ग्लायोब्लास्टोमा, डन, सर ये कौन सी नेक्रोसिस थी, सर तो सांप का बच्चा दिख गया सर, सर सर्पेंटाइन नेक्रोसिस सर, पिंक पिंक सांप का बच्चा, एक साइड बॉयफ्रेंड दूसरी साइड गर्लफ्रेंड, लिख के बता दो, ट्रू पेलिसेडिंग सूडो पेलिसेडिंग, बटरफ्लाई ट्यूमर सूडो पेलिसेडिंग, कम ऑन, हैज टू बी ग्लायोब्लास्टोमा, 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 डन डन, सर टिनाइटस वर्टिगा, लास्ट एफएमजी, टिनाइटस वर्टिगा, वर्टिगो, और कौन सी पेलिसेडिंग दे रखी है सर, ये तो ट्रू पेलिसेडिंग नहीं दिख रही क्या सर, सर ये तो श्वानोमा नहीं है क्या सर, जिसने ये बता दिया कौन सी बॉडीज मिलती थी, दिस ट्रू पेलिसेडिंग वाली बॉडीज इन श्वानोमा, द ट्रू पेलिसेडिंग इन श्वानोमास आर कॉल्ड एज वेरुके बॉडीज, श्वानोमा, एंटोनी ए, एंटोनी बी, वेरुके बॉडीज, S100 पॉजिटिव, थिंक अबाउट श्वानोमा, डन, सर बच्चा है, चाइल्ड विद सेरिबेलर मास है सर, बच्चा विद सेरिबेलर मास है, पिंक पिंक रोड शेप्ड इंक्लूजन है सर, पिंक पिंक है सर, सर ये तो रोजेंटल फाइबर्स नहीं होने चाहिए, कहां दिखता है, आई बैट ऑन दिस, नहीं गलत है तुम्हारा, मुझे पता है, मेरे को पता है, ये तो तुम नहीं बता सकते बिना ऑप्शन के, ऑप्शन देखिए माइट गो फॉर द राइट आंसर बट आई एम क्वाइट श्योर ये तो नहीं बता सकते तुम, फटाफट बता दो मेरे को, कहाँ मिलते थे, अरे रोज दिया था ताकि पिल्लो, सिटिक, आइस्ट्रोसाइटोमा, याद है क्या, ओ नहीं आया ना, किसी का भी नहीं आया ना, कोई बात नहीं, ऑप्शन देख के आ जाएगा, अरे ये नहीं आया तो मक्का मुक्का, मैं रीढ़ की हड्डी पे मार दूंगा दोबारा, फीमेल विद हिस्ट्री ऑफ हेडेक, राउंड राउंड पर्पल वर्ल ऑफ कैल्शियम, सामोमा बॉडीज, सर ब्रेन में हेडेक में सामोमा बॉडीज दिख रही हैं, ट्यूमर, ब्रेन में सामोमा बॉडीज, मेनिंजियोमा, 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 सर फीमेल विद फ्रंटल लोब मास एंड सीजर्स, सर देखो तो सही, देखो तो सही सर, every nucleus is surrounded by the whiteness, the perinuclear clearing that you see. This is Friday का appearance sir. सर हमें पता है सर, अंडा आएगा, अंडा कहाँ से आएगा, चिकन से आएगा ना सर, आप थोड़ी दोगे बैठ के वहां पे, वैसे भी जिस हालात में आप होना सर आप अंडा दे भी नहीं पाओगे, मैं किसी भी हालत में अंडा नहीं दे सकता था शायद। फ्राइड एग चिकन वायर कैपिलरीज, ओलिकोडेंड्रोग्लाइमा, फ्राइड एग टेस्टिस सेमाइनोमा, दिस जर्मिनोमा, कम ऑन, बहुत खुश, एकदम बहुत खुश। फ्राइड एग अपीयरेंस बोन मैरो में, हेयरी सेल ल्यूकीमिया। चलो इमेज देख के बता दो साहब, जिसने ये बता दिया ना एकदम एकदम मतलब एकदम ऐसे शाहरुख खान की तरह मेरा हाथ खुल जाए कर दूंगा मैं फटाफट। ट्रू रोजेट, सूडो रोजेट्स, बिल्कुल शाहरुख खान पोस्ट रेडी सर। पिंक ल्यूमेन है सर। होमेर राइट रोजेट, पी फॉर पिंक, पी फॉर सूडो, होमेर राइट रोजेट्स कहां पे, ब्रेन की बात करूं तो मैं मेडुलोब्लास्टोमा में, होमेर राइट रोजेट्स मेडुलोब्लास्टोमा विद द पिंक ल्यूमेन। लुक एट दिस सर, ये तो व्हाइटनेस दिख रही है सर रोजेट्स में सर, इसके रोजेट्स हैज अ क्लियर ल्यूमेन, व्हाइट ल्यूमेन है सर। सर दिस इज फ्लेक्सनर विंटरस्टीनर रोजेट्स, ट्रू और सूडो? ट्रू रोजेट्स, फ्लेक्सनर विंटरस्टीनर, ट्रू रोजेट्स, ट्रू रोजेट। चलो फटाफट, अनडिसेंडेड टेस्टिस की हिस्ट्री है, फ्राइड एग आ गया सर। सर पढ़ लिया सर आपने सर पढ़ लिया सर। फ्राइड एग टेस्टिस में दिख रहा है सर, फ्राइड एग टेस्टिस में दिखेगा तो सेमाइनोमा है ना सर, जिसकी आईएससी क्या थी, कलरफुल किट पहन के 3-4 अक्टूबर को मैं किससे मिलने गया था, नाना जी से, याद आ रहा है ना, सी किट ऑक 3 फॉर नाना जी, ट्यूमर मार्कर एलडीएच, सभी याद आ रहा है क्या, ये भी याद था क्या, एक बार आई शपथ बोल दो। आईएससी मार्कर्स भी याद थे क्या सेमिनोमा के, आई शपथ बोल दो एक बार, देन नहीं तो यही बाल और टीथ घुसा दूंगा फटाफट। टेरेटोमा, हेयर्स एंड टीथ, टेरेटोमा, डन है, ये तो सबको पता होता है, हेयर्स एंड टेरेटोमा। सर ट्यूमर मार्कर है बच्चे में, 3 ईयर ओल्ड टेस्टिकुलर मास है बच्चे में, मोस्ट कॉमन टेस्टिकुलर ट्यूमर सर यॉर्कसैक ट्यूमर है ना सर, यॉर्कसैक में तो शिलर डुवेल बॉडीज मिलती थी ना सर, शिलर डुवेल बॉडीज कहां दिखता है, यॉर्कसैक ट्यूमर, ये भी बता दो दिल खुश। ट्यूमर मार्कर अल्फा फीटोप्रोटीन, AFP, अल्फा फीटोप्रोटीन। एक मिनट सर ओवेरियन मास है सर, अब की बार ओवेरियन मास है और पिंक कलर की बॉडीज मिल रही हैं। इमेज आई डोंट थिंक दिल गिव यू, बट मैं वुड हैव डेफिनेटली टोल्ड यू, कॉल एक्सटर्नल बॉडीज, कम ऑन, कॉल एक्सटर्नल बॉडीज, नहीं बताया तो मुक्का। कॉल एक्सटर्नल बॉडीज, ग्रेनुलोसा सेल ट्यूमर ओवरी, GCT ओवरी, ट्यूमर मार्कर इनहिबिन, ISC CD99, कॉल एक्सटर्नल बॉडीज, शिलर डुवेल बॉडीज, यॉर्कसैक ट्यूमर, कॉल एक्सटर्नल बॉडीज, ग्रेनुलोसा सेल ट्यूमर ओवरी। सर प्यूर्स-जैगर सिंड्रोम, पेरिओरल मेलानोसिस, प्यूर्स-जैगर सिंड्रोम। पप्पी क्यों मिली थी, क्रिसमस वाले दिन मिली थी, क्रिसमस वाले दिन दीदी मूड में थी, पप्पी, एवरीबडी, दिस हैज टू बी व्हाट, आर्बोराइजिंग और क्रिसमस ट्री पैटर्न, आर्बोराइजिंग और क्रिसमस ट्री पैटर्न, कम ऑन। प्यूर्स-जैगर सिंड्रोम, जेनेटिक STK11, सर मेल एब्सॉर्प्शन सिंड्रोम के साथ आया है, and these are the special cells. So these are the special cells. Sir, these are acanthocytes, sir. Sir, these are acanthocytes, sir. Sir, A beta, A for acanthocytes, A for A beta lipoproteinemia. Acanthocytes, A beta lipoproteinemia. सर मेल एब्सॉर्प्शन के साथ आया है और फिंगाई की विलाई की शेप मेंटेन है, विलाई में पास पॉजिटिव पिंक मैक्रोफेजेस दिख रहे हैं, बता दो ना यार, विलाई के अंदर पास पॉजिटिव पिंक मैक्रोफेजेस हैज टू बी विपल्स डिसीज ना सर, विपल्स आर 2P पास पॉजिटिव, PP विपल्स, डन है सर। फर्स्ट इमेज नॉर्मल है सर, बट सेकंड इमेज में देखो सर, ये तो बता दिया जिसने, विलाई की एट्रोफी हो चुकी है सर, विलाई एट्रोफी विद क्रिप्टिक हाइपरप्लेजिया। कौन सी डिसीज है सर ये? सर ये तो सीलियक डिसीज नहीं थी, विलाई एट्रोफी। सर ये बता दो एकदम ऐसे फटाफट, अरे यार फटाफट, थैंक यू सो मच। TTG यार, एंटी TTG नहीं बोलनी है, बाकी एंडोमाइसियल भी है, ग्लाइडिन भी है, पर TTG नहीं बोलनी, विलाई की एट्रोफी मिलेगी। चलो नेक्स्ट पे आ जाते हैं। थायराइड आ गया सर, थायराइड सर बिल्कुल व्हाइट कलर के न्यूक्लियाई हैं सर, क्लियर न्यूक्लियाई हैं सर, क्लियर व्हाइट न्यूक्लियाई हैं, व्हाइट न्यूक्लियाई हैं, ऑर्फन एनी है ना सर, ये तो सर, ये तो ऑर्फन एनी है ना सर, ये तो पेपिलरी कार्सिनोमा थायराइड में मिलता है ना सर। वो पेपिलरी कार्सिनोमा जो किसके बाद होता है, मैंने सारे P अल्फाबेट पढ़ाए थे, P फॉर पेपिलरी, P for post radiation मिलता है, post radiation. Patient will come to you with P for palpable lymph node, palpable lymph node, palpable lymph node. इसमें P से क्या मिलेंगी? सामोमा बॉडीज. याद आ रहा है? पैपिलरी कार्सिनोमा, पोस्ट रेडिएशन, पैल्पेबल, सामोमा बॉडीज, perfect prognosis. That means it has the best prognosis. And P for it is the most popular cancer. That is the most common thyroid cancer. चलो, तो थायराइड में पिंक पिंक अमाइलॉइड दिख गया. लास्ट इमेज है, फटाफट बताता हूँ. थायराइड में अमाइलॉइड दिख रहा है, अमाइलॉइड, थायराइड में अमाइलॉइड दिख रहा है. सर मेडुलरी कार्सिनोमा थायराइड. सर कौन सा अमाइलॉइड अभी डिस्कस करेंगे. सर मेडुलरी कार्सिनोमा थायराइड है. सर अमाइलॉइड दिख रहा है. चलो नेक्स्ट पे देखते हैं. सर सिनाइल डिमेंशिया के साथ आया है और ये फ्लेम शेप सेल्स मिल रहे हैं. डिमेंशिया, अल्जाइमर्स, फ्लेम शेप सेल्स, न्यूरोफिब्रिलरी टेंगल्स. कौन सी अमाइलॉइड? ए बीटा अमाइलॉइड से बना है. न्यूरोफिब्रिलरी टेंगल्स, ए बीटा अमाइलॉइड. डन 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 डन. नेक्स्ट देखो सर, ब्रेडिकाइनेसिया के साथ आया है. पिल रोलिंग ट्रेमर्स है. सर देखो ना सर, ईओसिनोफिलिक ल्यूमन है सराउंडेड बाय हेलोस, पिंक ल्यूमन सराउंडेड बाय हेलोस. पिल रोलिंग ट्रेमर्स. सर दिस आर लुई बॉडीज सीन इन पार्किंसन डिसीज. लुई बॉडीज पार्किंसन डिसीज. अरे बाय मुझे लगा था टाइम होगा तो पढ़ा दूंगा. चलो चलो 1 सेकंड से फटाफट, जो मुझे लगता है 2 मिनट और इंपॉर्टेंट क्वेश्चन है उनको भी डिस्कस कर लेते हैं सर, उनको भी डिस्कस कर लेते हैं फटाफट. जो इंपॉर्टेंट टॉपिक बता देंगे मुझे बताओ फटाफट. कैस्पेसिस की बात कर लेते हैं. कोई देखेगा नहीं, लास्ट पॉइंट मांग रहा हूं, देखेगा नहीं. इंट्रिंसिक पाथवे कैस्पेस 9, एक्सट्रिंसिक 8 और 10, 8 और 10, एक्सिक्यूशन 367, 367. नेक्रोप्टोसिस में कोई कैस्पेस इन्वॉल्व नहीं है, कोई कैस्पेस इन्वॉल्व नहीं है. फटाफट अमाइलॉइड पाप लगेगा, देखना मत. मल्टीपल माइलोमा में अमाइलॉइड, एएल एएल. हीमोडायलिसिस वाली ए बीटा 2 माइक्रोग्लोब्यूलिन, माइक्रोग्लोब्यूलिन. सेनाइल अमाइलोइडोसिस, सिस्टमिक सेनाइल अमाइलोइडोसिस, एटीटीआर, ट्रांसथायरेटिन. सेनाइल अमाइलोइडोसिस में कौन सा ऑर्गन? हार्ट. अमाइलॉइड पॉलीन्यूरोपैथी, एटीटीआर म्यूटेंट वाली, एटीटीआर नॉर्मल वाली, सेनाइल अमाइलोइडोसिस, एटीटीआर म्यूटेंट, अमाइलॉइड पॉलीन्यूरोपैथी. सर ए टाइप फैमिलियर मेडिटेरियन फीवर, फैमिलियर मेडिटेरियन फीवर. और एल्जाइमर्स में ए बीटा, एल्जाइमर्स में ए बीटा. मेडुलरी कार्सिनोमा थायराइड, ए कैल. ये तो पता है मेरे चैम्प्स को आता है, ए कैल. और क्रॉनिक इन्फ्लेमेशन में ए टाइप ऑफ अमाइलॉइड. याद आ गया ना सबको, याद आ गया ना सबको. एक भी नहीं भूले ना, जो भूले उस पर ध्यान रख लेना. चलो फिर इसमें बता के बता देना. इन्फ्लेमेशन में अर्लीस्ट वेस्कुलर इवेंट ऑफ इन्फ्लेमेशन, अर्लीस्ट वेजोकॉन्स्ट्रिक्शन, फिर हुआ था वेजोडाइलेशन. पूछता है किसकी वजह से? हिस्टामिन से. व्हाट इज द हॉलमार्क साइन ऑफ एक्यूट इन्फ्लेमेशन? इंक्रीज इन वेस्कुलर परमेबिलिटी. परमेबिलिटी ये छोड़ दो, इसको बता दो. मार्जिनेशन और रोलिंग किसका काम है? अगर आपने ये भी बता दिया ना, मार्जिनेशन रोलिंग, सेलेक्टिन मार्जिनेशन और रोलिंग करती थी. गाइस एडहेशन, इंटीग्रिन्स एडहेशन करते हैं. कम ऑन. पीकैम ट्रांस माइग्रेशन करता है. पीकॉक लव्स टू ट्रांस माइग्रेट. पीकैम ट्रांस माइग्रेशन. कम ऑन. साइटोकाइन्स बता दो, मेरा दिल एकदम खुश हो जाएगा. LIC वाले मॉलिक्यूल्स कीमोटेक्सिस करते हैं. दैट इज ल्यूकोट्राइन B4, इंटरल्यूकिन 8, C5A. ये तीनों कीमोटेक्सिस मॉलिक्यूल है. याद आ रहा है क्या? देन ऑप्सोनिन बता दो, बाय करेंगे चैप्टर को. ऑप्सोनिन IgG ऑप्सोनाइजेशन एंटीबॉडी है एंड C3B. IgG C3B ऑप्सोनाइजेशन वाली एंटीबॉडी. ये भी याद है क्या तुमको? चलो फटाफट. हिस्टामिन के बारे में इसमें कुछ खास क्वेश्चन नहीं. साइटोकाइन्स देखते हैं. फीवर इंटरल्यूकिन 1. फीवर इज कॉज्ड बाय इंटरल्यूकिन 1. कैंसर कैकेक्सिया TNF अल्फा. मैंने कहा था क्लास में भी. ट्यूमर नेक्रोसिस फैक्टर अल्फा. नेक्रोसिस मतलब सेल डेथ, बॉडी के सारे सेल मर जाएंगे, वेट कम हो जाएगा. कैंसर कैकेक्सिया. एंजियोजेनेसिस VEGF. फाइब्रोसिस लास्ट ईयर FMGE. फाइब्रोसिस TGF बीटा. ग्रैनुलोमा G फॉर ग्रैनुलोमा. एक्यूट फेज रिएक्टेंट्स इंटरल्यूकिन 6. चलो अब फटाफट वुंड हीलिंग को रिवाइज करते हैं. वुंड हीलिंग डे 0 पे क्या हुआ था? फर्स्ट सेल एट द राइट साइड ऑफ इंजरी, इट इज प्लेटलेट्स. डे 1 पे न्यूट्रोफिल्स आए थे. मुझे आप इतना बता दो एवरीबॉडी. सारे क्वेश्चन एक साइड ये बता दो. ग्रैनुलेशन टिश्यू में कौन सा कोलेजन? और मैच्योर स्कार टिश्यू में क्या हो गया? ये बता दो मेरे को. तो ग्रैनुलेशन टिश्यू में कौन सा कोलेजन और स्कार टिश्यू में? ग्रैनुलेशन टिश्यू में टाइप 3 है और मैच्योर स्कार टिश्यू में टाइप 1 है. मैंने आपको क्लास में बताया था. कोलेजन के साथ रूल ऑफ 3 याद रख लेना. कोलेजन अर्ली कोलेजन डे 3, अर्ली कोलेजन डे 3, कोलेजन मैक्सिमम इन अमाउंट 3 वीक्स, कोलेजन मैक्सिमम स्ट्रेंथ 3 मंथ्स। 3 दिन पे अर्ली कोलेजन, 3 वीक्स में मैक्सिमम अमाउंट ऑफ कोलेजन एंड 3 मंथ्स में मैक्सिमम स्ट्रेंथ इन कोलेजन, क्योंकि 3 मंथ्स के बाद टाइप 3 टाइप 1 में कन्वर्ट हो जाएगा। क्या ये भी याद आ रहा है क्या? तुम इतने समझदार तो नहीं हो सकते हो, इतने समझदार तो नहीं हो सकते हो। मुझे बता दो, ट्रांसलोकेशन बता दो, ट्रांसलोकेशन डाउन सिंड्रोम 1421 एंड स्टार मार्क कर लेना, रोबर्ट्सोनियन ट्रांसलोकेशन, मेंटल सेल लिम्फोमा 1114, ये भी याद आ रहा है क्या? ये तो नहीं याद आ सकता। 1114 मेंटल सेल लिम्फोमा, फॉलिकुलर 1418, फॉलिकुलर 1418, तो 14 तारीख को फुल, मेंटल 1 और 1 11, बर्किट्स 8 हैज टू बी देयर, रिमेंबर 814 फूल कटता है हमारा 14 तारीख को, 14 फेब को, तो फॉलिकुलर इज 14। एक्यूट अडल्ट टी सेल ल्यूकीमिया 25, AML M2 821, AML M2 821, ये मत भूलना सर। CML 922, अभी सब पे ध्यान नहीं देना, जिसपे मार्क करो वो कर लेना। CML 922 राइट, एंड इविंग भी 1122 है, इविंग सार्कोमा ऑल्सो 1122, बाकी सब पे ध्यान नहीं देना, इंपॉर्टेंट पे ध्यान देना है। चलो केमिकल्स रिवाइज करते हैं। कार्सिनोजेनिक केमिकल्स, एल्काइलेटिंग एजेंट्स, एल फॉर एल्काइलेटिंग एजेंट, एल फॉर ल्यूकीमिया, बेंजीडीन, D फॉर डीन, बेंजीडीन, D फॉर डीन, D फॉर ब्लैडर, ब्लैडर में D है, ब्लैडर में D है, ब्लैडर कैंसर, ट्रांजिशनल सेल कार्सिनोमा, एथेनॉल हेपेटोसेलुलर कार्सिनोमा। अरे ये नहीं बताया ना, और अगर ये भी नहीं बताना भाई तो सो जा, अपना फोन नंबर देके सो जा, और उठा दूंगा मैं तेरे को एग्जाम में फॉर्मेलिटी करने तो जाना है, मैं उठा दूंगा तेरे को, जा। एस्बेस्टोसिस मोस्ट कॉमन एडिनोकार्सिनोमा, एस्बेस्टोसिस मोस्ट स्पेसिफिक मेसोथेलियोमा। Tobacco smoke, you know, like lung cancer, adeno cancer, arsenic, again lung cancer. ये बता दो तो दिल खुश हो जाएगा। वैट बताया था, वैट विनाइल क्लोराइड, आर्सेनिक एंड थोरोट्रास्ट, विनाइल क्लोराइड, आर्सेनिक, थोरोट्रास्ट, हिपैटिक एंजियोसार्कोमा, रेडिएशन से कौन सा कैंसर होता है? अभी बताया, पैपिलरी थायराइड कैंसर, ल्यूकीमियास, मेनिंजियोमा भी ऐड कर लो, मैंने LMP निमोनिक बताया था। रेडिएशन से LMP कैंसर होते हैं, LMP सर, ल्यूकीमिया, मेनिंजियोमा, पैपिलरी कार्सिनोमा, थायराइड। नाइट्रोसामीन पे ध्यान देना, नाइट्रोसामीन्स पे गैस्ट्रिक कैंसर, नाइट्रोसामीन कॉसेस इंटेस्टिनल कार्सिनोमा। बेंजीन AML, बेंजीन में ल्यूकीमिया, बेंजीडीन ब्लैडर, बेंजीन ल्यूकीमिया, बेंजीडीन ब्लैडर। एल्काइलेटिंग में L है, L फॉर ल्यूकीमिया। और अगर ये भी नहीं बताया तो मार खाओगे, लिख के बताओ या नहीं लिखा हो। एफ्लाटॉक्सिन कौन सा फंगस? एफ्लाटॉक्सिन कौन सा फंगस? एस्परजिलस फ्लेवस, कॉसेस हिपेटोसेलुलर कार्सिनोमा। ISC तो अपन ने पढ़ ली। अरे हो गया क्या? हो गया है, चलो सब हो गया कवर, सब याद था तुमको। अब क्या करें? बाय करें, कर देते हैं, चलो। So that is me, Dr. Gaurav, signing off. 1 hour में, trust me, ये images इसलिए नहीं थी कि you will expect a straightforward question. I'm no one to tell you like this, है ना? क्योंकि अगर मुझे क्वेश्चन पता होता तो अभी तक नीट यूजी का नहीं, FMG का भी पेपर लीक हो चुका होता। शुक्र मनाओ नहीं हुआ है ना? तो this questions was just for your mental exercise. I पिन पॉइंटेड द टॉपिक्स जहां से आपका ब्रेन थोड़ा वर्क करना पड़े, थोड़ा सोचना पड़े। मैं भी सब लिख के आ सकता था, पर मुझे लगा ब्रेन वर्क नहीं करेगा सब कुछ लिखा होगा तो। सो साइनिंग ऑफ गाइस, गॉड ब्लेस यू वेरी मच। ट्रस्ट मी, अगर आप इफ यू कुड रिकॉल मोस्ट ऑफ द थिंग्स, अगेन आई रिपीट, ऑप्शंस नहीं थे, टाइम नहीं था, बिना ऑप्शंस के और बिना टाइम के इफ यू कुड सॉल्व द इमेजेस, या तो आप टीचर हो जैसे कि मैं हूं, पढ़ा रहा हूं इसलिए पता है, या तो आप फाड़ू स्टूडेंट हो। तो ऑब्वियसली टीचर तो आप हो नहीं, तो आप बचे क्या? जस्ट फाड़ू स्टूडेंट्स। मैंने से फाड़ू, ट्रस्ट मी, यू आर, व्हेन आई गॉट ट्रस्ट इन यू, यू जस्ट गॉट टू ट्रस्ट योरसेल्फ। इस टाइम कुछ भी नहीं सर, लिखा जा चुका है, तुम्हारा पेपर भी और तुम्हारी किस्मत भी लिखी जा चुकी है। ट्रस्ट मी ऑन दिस, यू कैन नॉट चेंज एनीथिंग इन कमिंग फ्यू डेज, कुछ भी बदल नहीं सकते हो। क्या कर सकते हो? विद द बिलीफ की होने वाला है, जो कर रहे थे करते रहो। डोंट लुक फॉर एनी मिरेकल इन लास्ट डेज। ये वाली लड़ाई वो जीतता है जो अपने लास्ट डे में कुछ अलग नहीं करता। आई रिपीट, ये वाली लड़ाई वो जीतता है जो अपने लास्ट डेज में कुछ अलग नहीं करता, बट जो कर रहा था वो कर पाता है। सेम जो चीज कर रहे थे एल एक्स्ट्रा के ट्राई में, रिदम को मत तोड़ो। जो सर्कल चल रहा था, जो पढ़ रहे थे पढ़ो। इस टाइम पे कुछ भी ऐसा मत कर लेना विच इज टोटली समथिंग न्यू टू योर ब्रेन, मत करना ब्रो। जो चल रहा है, ट्रस्ट द प्रोसेस, ट्रस्ट द हार्ड वर्क दैट यू हैव पुट इन, ट्रस्ट एवरी बिट ऑफ इट। जो इतने टाइम से किताबों में घुसे हो, इतने टाइम से गौतम नगर के या इंडिया के किसी भी पार्ट में, इफ यू गॉन इनटू द बुक्स, यू गेव एवरीथिंग यू कुड, ही इज देयर टू सी यू। मैं एक लास्ट चीज बोलूंगा सर, ट्रस्ट मी, यूनिवर्स इज नॉट देयर टू डिफीट यू, यूनिवर्स इज देयर टू मेक यू विन। एग्जाम में हर चीज आपको जिताने के लिए हुई है, वहां पे हर चीज आपको जिताने के लिए हो रही होगी। अगर 3 क्वेश्चन गलत हो रहे हैं तो आपको जिताने के लिए हैं, वो बस आपको टेस्ट कर रहे हैं कि यार तो 3-5 क्वेश्चन गलत देके कहीं तो घबरा तो नहीं जाएगा। मेक श्योर दिस, यू अंडरस्टैंड दिस थिंग, द यूनिवर्स इज देयर टू रिवॉर्ड यू विद सक्सेस। यूनिवर्स आपका दुश्मन नहीं है, वो ये नहीं चाहता कि आप हारो, कोई नहीं चाहता। आप नहीं चाहते, आपके पेरेंट्स नहीं चाहते, आपके टीचर्स नहीं चाहते, आपके दोस्त नहीं चाहते, और 1-2 लोग चाहते भी हैं, वो हम सबको थोड़ी हरा देंगे यार, नहीं हरा सकते ना वो। यू हैव टू बिलीव इन दिस। यूनिवर्स जब वो बैठा होगा ना, उस स्क्रीन से लेके, उस उंगलियों से लेके, उस कीपैड से लेके, वहां पे जो मॉडरेटर होगा, वो जो सेंटर होगा, एवरीथिंग इज देयर टू मेक यू विन। आपको विश्वास रखना है, गलत सिग्नल नहीं पकड़ लेना, अरे लेट हो गया मैं, आज ये हो गया वो हो गया, आज कुछ गलत होने वाला है, मुझे वाइब्स अच्छी नहीं आ रही, मुझे इंट्यूशन गलत है। तेल में गिल लेने गया इंट्यूशन तेरा 2 सेकंड का इंट्यूशन तेरे पिछले 6 महीने की मेहनत को डिफीट नहीं कर सकता मेरे भाई। सो गाइस, गो विद द पॉजिटिव नोट, डोंट ट्राई एनीथिंग न्यू। जो कर रहे हो, जो भी शेड्यूल बनाया है, मैराथन ज्वाइन करो। अगर ये आ रहा है तो टीचर का आ जाएगा, राइट? तो चलो गाइस, दैट इज ऑल फ्रॉम माय साइड। दिस इज डॉक्टर गौरव साइनिंग ऑफ मैन, विशिंग यू ऑल द वेरी बेस्ट। मैनिफेस्टिंग एन इंटरव्यू विद यू गाइस, मैनिफेस्टिंग इट मैन। जब भी पढ़ने का मन ना करे, जस्ट विजुअलाइज, जस्ट विजुअलाइज। स्क्रीन पे जैसे ही पास देखोगे, वो जो लाउडली तुम स्क्रीम करने वाले हो, जितने जोर से मम्मा पापा को हक करने वाले हो, जितने जोर से अपने दोस्तों को बताने वाले हो बॉस मैंने कर दिया, जस्ट विजुअलाइज इट। हर चीज को विजुअलाइज कर ले, जो तुम इमेजिन करने वाले हो ना, सब विजुअलाइज करना है। जब पढ़ने का मन ना करे, इस टाइम पढ़ने से ज्यादा इंपॉर्टेंट इज विजुअलाइजेशन। बस विजुअलाइज, बस एक बार एग्जाम देके आया, उस स्क्रीन पे ही जैसे यस आएगा पास, मुझे कहाँ घूमने जाना है, मेरी कौन सी वेब सीरीज है मुझे पेंडिंग देखना है, मुझे कहाँ ट्रेवल करना है, किसको हक करना है, visualize it. It's gonna happen. God bless you guys. Take care.